empiric antibacterial therapy that was used in response to fever, around 30% of them were inappropriate. They were inappropriate because of eventually finding out that the patient had bacteremia caused by an organism that is resistant to our first-line agent. Now, this is obviously a problem because we recognize that early appropriate treatment is essential if we wanted to improve outcomes in our most vulnerable patients when they're experiencing gram-negative bacteremia. Now, one possible approach that has, again, seen some recent advance is the option of screening for lower GI tract carriage. The idea is that in the majority of our patients, those who go on to develop bacteremia, the organisms that go on to cause infection are generally derived from their gastrointestinal tract. And when a patient is colonized with gram-negative bacteria, particularly resistant agents, and we are aware of that, then that can result in infections caused by this organism. So the question then comes, is it possible to screen patients and identify those who might be expected to need more than our routine screening or more than our routine empiric treatments? In this study, what the investigators were trying to do is identify what was the cause of bacteremia and how did this relate to the organisms that were identified in screening. So here you would have patients who are expected to become at risk of gram-negative infections or infections in general, and then they would have rectal swabs tested either by culture or PCR to identify, for example, in this study, carbapenem-resistant enterobacterales or carbapenem-resistant gram-negatives. In this study, more than 700 individuals were screened for carriage, lower GI carriage, and of those, a proportion were then identified to have underlying genes associated with resistance to carbapenemase. So you can see that some had NDM enzymes, VIM enzymes, or KPC enzymes. Then the investigators looked at the proportion who went on then to develop gram-negative bacteremia caused by these organisms. And you can see now in this survival curve that among us, those who had NDM genes detected in their lower GI tract or their screening swabs, nearly 70% of them developed bacteremia caused by the same gene-carrying organism within the next 4 months. KPC enzymes were seen in nearly 40%. So screening for carriage could predict which patients might go on and develop an infection caused by organisms harboring those genes. This is a different study. This one is specifically focused on stem cell transplant recipients in Sao Paulo in Brazil. And here the investigators are reporting the results of their screening pre-transplant. And here you could see that the proportion who were colonized was nearly 40%. And then post-transplant, 27%, or you'd say 1/4 of those patients developed bloodstream infections. Of these, 60% were caused by the same genes or carrying organisms that were identified in colonization. Translating this into practice could mean something like introducing rectal screening for our patients before they become at risk. So, for example, at the time of admission to a hematology ward in preparation for transplant or in preparation for chemotherapy, a lower GI tract, a rectal swab that can be then submitted to the lab for culture or PCR could identify patients who are known or become known to be colonized with multi-drug resistant organisms. And then if they go on and develop fever or unexplained neutropenic fevers, when we're constructing an empiric antibacterial treatment regimen, we should be able to include agents that are more likely to address those organisms and reduce the likelihood of giving inappropriate antibacterial therapy. Now, using screening is not something that doesn't have downsides. If we screen using PCR, for example, we would be able only to identify the genes. And the presence of the gene is not necessarily always an indication of a presence of resistance, because bacteria could be carrying the gene without expressing it. We could also be missing bacteria that are resistant without using this particular carbapenemase or this particular gene. And if we were to identify the presence of these organisms in the lower GI tract, it doesn't necessarily mean that it's always going to be the cause of subsequent infection. So there is a risk that we could be unnecessarily increasing costs and using unnecessary antibiotics, and there is a risk that we could be driving resistance. But if used in balance and used along with other clinical information, I believe, and the data supports this suggestion, that using rectal screening in our high-risk patients could guide treatment and empiric choices, at least in the first 48 hours while we're waiting for cultures, and that can reduce the risk of inappropriate treatment during the time of most risk. But we need to combine those diagnostics with clinical expertise, with microbiological expertise, so that when we apply them to patients in our floors, we apply them optimally and we get the balance right. We don't want to treat unnecessarily, but obviously we don't want also to miss patients who could potentially have serious underlying bacteremias. I'll move on now to the third part and last part of this talk, where I'm going to talk about viruses. And obviously these days, the virus that bothers us more than anything else is SARS-CoV-2 or COVID-19. And there has certainly been quite a lot of learning in the last 3 years that we've had this pandemic with us. If we focus on patients with underlying hematological malignancies, and those who are recipients of hematopoietic stem cell transplants, we find two important patterns. In relation to COVID-19 itself, we know that those patients are at an increased risk of progressing to severe disease, and we also know that they are at an increased risk of death compared with patients who do not have such disorders. We also know that within our population of hematology patients with various disorders or transplant recipients, we know that within them, those who are older or have uncontrolled malignancy or had had recent chemotherapy or are neutropenic, these are at an even higher risk of disease progression and death compared with the remaining group. So we started to develop an understanding of which of our hematology patients are especially to be worried about. But we've also become aware that although vaccines have become widely available and many of our patients are luckily vaccinated, we know that those vaccines are generally less effective in our patients compared with the general population or with individuals with other medical problems. We also know that the vaccine effectiveness is not just smaller in magnitude, it's also shorter in its longevity. So an individual with underlying active hematological malignancy will be less likely to develop an effective response after a vaccine. And even if they develop a response, this response tends to be short-lived compared with the rest of us. This becomes concerning these days because I'm sure the situation in Jordan is not different from where I live or the rest of the world. Generally speaking, most of the social distancing interventions and mitigation interventions have been lifted. So in most places that it's no longer compulsory now to wear masks or to avoid certain crowded spaces. And our patients who are at risk of severe COVID may not find it possible that they can avoid being exposed to COVID. Now, fortunately, and thanks God, generally speaking, we have less COVID circulating now than we did a few weeks or a few months ago, but that could change very quickly. What we've learned over the past 3 years with the pandemic is that these viruses keep changing and new variants and subvariants keep emerging all the time. And there is a significant immunological escape associated with these variants to the point where our immune system may no longer recognize the variants and may no longer be able to mount an effective response. This was shown vividly in a meta-analysis that was published only 2 days ago, where the investigators looked at studies that reported the effectiveness or the effect of having one COVID infection on the risk of developing a subsequent infection. And as you can see to your left, protection against reinfection, if you look at the lower end, once you've had an infection with the alpha variant, that particular variant had an effectiveness of around 90% in preventing the subsequent infection. But as you go forward with the more recent variants, particularly the Omicron variant, you could see that this protection becomes around 45%. Saying it differently, the recent variants not only managed to escape our immune responses and be able to reinfect again, they're also less able to prevent reinfection. So if our high-risk patients were to have an infection with something like Omicron, unfortunately, this doesn't protect them against reinfection. It also is not very effective at protecting them from symptomatic disease and not as effective as previous variants in protecting against the most severe forms of the infection. It means there is more pressure on us, and it's important for our patients to recognize that once they have COVID disease, they will have to take action. And we need to try to take action as early as possible and to be able to give them interventions that can reduce the risk of progression, because their previous infection, their previous vaccination may not be able to do that. Now, one of the group of medication that we've had available to try to prevent disease progression are monoclonal antibodies. And many of them were introduced to clinical practice in the past 3 years. Unfortunately, another effect of the emergence of variants and subvariants is that they've gradually lost their effectiveness to a point that right now, among us, the circulating variants of the Omicron SARS-CoV-2, none of the existing monoclonal activity agents has any useful in vitro or clinical activity. Unfortunately, those monoclonal antibodies would not be able to help most of our patients right now because of the currently predominant circulating variants being non-susceptible to those monoclonal antibodies. The other option we have is to use antivirals, and we are fortunate, our patients are fortunate, because we have 3 different antivirals to choose from. All have been shown in randomized clinical trials to be able to reduce the risk of disease progression when used very early in someone who is at risk of severe disease. Remdesivir is available as an intravenous injection. It's given over 3 days, and it's able to reduce the relative risk of severe disease by nearly 90%. So it's highly effective. The complexity of need for intravenous administration might limit the access for some of our patients. Molnupiravir and nirmatrelvir are both available as oral agents. They're very well tolerated, and they need to be taken for 5 days. But the clinical effectiveness of molnupiravir is relatively small compared with the other agents, whereas nirmatrelvir has very high effectiveness. And this is reflected in the numbers needed to treat at the bottom of the table. So if we wanted nowadays to optimize or reduce the risk of disease progression in our patients with underlying hematological diseases or recipients of transplant, the ideal scenario would be that we would create a situation where patients are aware of what symptoms to look out for, where they would go for testing if they would develop symptoms, and how to get those tests done as quickly as possible and to turn around the results as quickly as possible, and then provide access to treatment to optimize care and minimize the risk of disease progression. The current guidelines for management of COVID in the early setting or in the outpatient setting recommend Paxlovid as first line, largely because it's oral and it's highly effective. The second option in this order is remdesivir, and it's second only because of the complex logistics, but in terms of the effectiveness, it's actually very good. And the others, particularly molnupiravir, falls third, largely because of its lower efficacy. However, Paxlovid or nirmatrelvir is deliberately given with ritonavir to boost its pharmacokinetic profile. And that means that there's an increased risk for interactions because ritonavir acts as an inhibitor of cytochrome B3A4 system. It is therefore important to review the patient's medications and ensure that there are no potential drug-drug interactions. And if there are any drug-drug interactions, that those need to be addressed, sometimes being able to stop the medication for a few days while the patient completes the course of Paxlovid, but sometimes those interactions are not manageable and one has to avoid the drug altogether. The key to remember, I think, for me and for this group, is that our patients continue to be at risk of severe COVID, even if most of the population are not necessarily at the same risk. It is very dangerous that at this point in time, we think that the pandemic is over, because unfortunately it isn't. And we need to continue to be vigilant and try to identify our patients as early as possible and offer them treatment where we can. And if we optimize our processes for identification and intervention, that we would offer our patients our best chances in surviving this particularly nasty virus that's been with us for the last 3 years. This has been a very quick run through some of the recent advances. I hope you find it useful, and thank you very much again for the opportunity.
Thank you very much, Dr. Omrani, for this nice talk. Really very fruitful and nice and comprehensive presentation. Now we will open the session for asking questions. So if anyone from the audience have a question, I think Dr. Ali is pleased to answer.
شكرا دكتور علي على the fruitful discussion. Do you think using probiotics is safe during chemotherapy? I always ask this question by my patients in my practice. Thank you.
Thank you. Using
Probiotics.
Probiotics. Oh, interesting. I personally don't think they're safe. There are very well documented reports of individuals, immune-compromised patients, developing invasive infections when they're giving probiotics. And I would personally avoid them if the patient is immune-compromised. I would also, this is a personal view, I would also avoid them because I'm not convinced that the clinical data supports that they're useful anyway. So my judgment is that they're not necessarily very useful, and they may be risky for our patients. So I don't use them and I don't recommend them. But I also recognize that this is a debatable subject, and maybe colleagues have a different view.
Yes, I'm wondering regarding these massive screening for rectal swab or nasal swabs for each of the patients being admitted to the hospital. I'm dividing my question. Does this satisfy, I mean, outweigh the risk of increasing the cost and antibiotic use? I mean, I'm asking regarding the solid tumor patients and the transplant and hematology patients. Do you still recommend doing that? I know in our hospital we're doing these screenings, and I think this is lots of cost, and maybe isolation more for those patients, etc. Can you comment on this, please?
Yes, thank you very much. This is a very important point you make. We, where I work, screen everyone for MRSA. I'm sure you do anyway. And we also screen patients before they become neutropenic using a rectal swab. The way we find this information useful is that once we know that someone is colonized, for example, with a carbapenemase producing E. coli, if they go on and they become neutropenic and develop a fever, when we give them empiric treatment, we make sure that we include an aminoglycoside because we want to cover this possibility. I think it is like everything else, obviously comes with a cost, including a financial cost, and one needs to balance this against what is the potential yield. We find this useful, and we think that by knowing in advance what patients are colonized with, we're able to better select empiric treatment, and we find that this is something that is cost effective. It could be right in your setting, it could be wrong. I think it's an assessment that each center and each hospital will have to make for their own. But overall, what I was trying to do is to stimulate the discussion and the thinking and the thought about what is it that we can do now different to what we were doing a year or 2 or 3 ago in those patients who might be at risk of multi-resistant gram-negative infections. It also, another important point is, if you happen to be fortunate enough to be working in a place where the incidence of multi-resistant infections is very low, then obviously this would be likely to be not cost effective. But unfortunately, if you work in a place like mine, this has become a major issue. Around 20 to 30% of our bacteremias are caused by carbapenem-resistant gram-negatives now. So we do want to know about them as early as possible.
Dr. Ali, thank you very much for your presence. Thank you for all the audience for this for attending this nice session. Thank you very much.
Thank you.
Before I start, I just want to make sure Rami is available.
You can ask that.
Rami, can you hear me? Oh, now I see Rami.
Good morning.
So good afternoon, everybody. It's a great honor and privilege to present my lifetime friend, Rami Kumrokji. I've known Rami for more than 30 years at all levels, academic levels, social levels. He's more than a decade neighbor in lovely state of Florida. So I have a problem presenting him. If you review his very summarized CV, it will be more than the lecture. I would say proudly Rami is a graduate of Jordan University Medical School, 1996. And then he pursued his internal medicine and subspecialty of hematology and oncology in the United States. He was trained in hematology oncology with the pioneers of the field in Rochester, in New York, and then he moved to Cincinnati, and then later on in the world-known prestigious Moffitt Cancer Center. He is one of the world experts in myeloid disorders. He had more than 350 at least, probably where he put in his CV publications in the peer-reviewed journals with high impact factor, including New England Journal of Medicine, JCO, Blood. And if you just check him in the ResearchGate, you will be nicely surprised. Rami had significant awards and achievements. He was, I will just name few, the King Hussein Cancer Foundation Lifetime Achievement last year, and numerous international and awards as well. He specialized in myeloid disorders, specifically MDS. I had numerous patients with him, and I would like to thank him in advance for what I learned from him and the patient care he provided for my patients. The only thing I was doubtful he will be awake now, but he's nicely surprised me. Good morning, Ram.
Good morning, Osama.
So without wasting your time with my presentation, I'll let you enjoy his lecture.
Thank you very much. Good morning, and thank you for the kind introduction. It's an honor and pleasure to join you this morning. Yes, it was a struggle to wake up. I'm not a morning person, but I was excited about this. So thank you again for the kind invite. And I was asked to talk about recent advances in myelodysplastic syndromes. So I'll try my best to cover in the coming 45 minutes. I actually wanted to start with 3 cases just to illustrate the heterogeneity of this disease and the spectrum that we deal with, showing on the surface that many patients present, almost the same. Obviously, the most common presentation or the entry to the diagnosis of MDS is usually cytopenias. So here we have 3 cases. Those are actually real cases from my practice. All of them early 70s. Presented with variable cytopenias. The first patient actually came already had erythroid stimulating agent and was on azacitidine for almost 6 months and no response. the original bone marrow obtained by the local hematologist or oncologist had shown increased ring sideroblast, so the patient was treated as MDS ring sideroblast. The other two patients were newly diagnosed. The original workup did not show any bleeding or nutritional deficiencies. So the first patient, we actually repeated the bone marrow and indeed had more than 15% ring sideroblasts, but no increased myeloblasts, no other overt dysplasia. The karyotype was normal and there were no somatic mutations detected by NGS. In setting of ring sideroblasts, particularly if there is no clonal evidence, I'm always very suspicious of copper deficiency. And indeed, what this patient had was severe copper deficiency that unfortunately was unnecessarily treated with azacitidine for 6 months. We replaced the copper and the patient counts improved. The other patient had ring sideroblast more than 15%, but had a somatic mutation of the splicing SF3B1 gene. The third patient actually had ring sideroblast as well, but the myeloblasts were 10 to 15%, complex karyotype, including deletion 5q and -7, and a TP53 somatic mutation was detected. So as you can see, the first patient has a condition that can mimic dysplasia on the bone marrow, particularly ring sideroblasts. The second patient had a lower risk MDS, that the main problem was anemia. And the third patient actually had a higher risk disease that probably is a life-threatening disease. And obviously, the first patient treatment would be copper, the second patient will be treated as lower risk, and the third patient will be treated as higher risk. So myelodysplastic syndrome are really a very wide spectrum of neoplastic stem cell diseases. They are characterized by bone marrow failure and the resultant complications, with a tendency to progress to acute myeloid leukemia. Not every patient will progress. Around 30% roughly will progress to acute myeloid leukemia. But unfortunately, more than half of the patients will die from complications of the disease. It is the most common myeloid malignancy, actually. Roughly in the United States, the incidence is estimated around 50,000 per year. Average age is around 70. And if you look at AML in adult population, or particularly above age of 60, nowadays we think probably more than half of the AML we see is really coming from MDS, whether it had a known history of MDS or not. The entry criteria for diagnosis of MDS, that you have to have some level of cytopenia. There are a lot of conditions, nutritional and other things that can mimic MDS, so it's very important always to rule those out. And then obviously by bone marrow assay and biopsy, the diagnosis is confirmed. One is demonstrating that there is dysplasia, abnormal morphology as shown here, and so different examples. A hematopathologist ideally would count 500 cells in each cell line. Most of the time they settle for 200. If there is 10% or more of the cells showing dysplasia, then that's diagnostic for MDS. Or if the myeloblasts are increased more than 5%, the gold standard is really to use the aspirate. Flow cytometry could be delusional or overestimate. And then nowadays, if we have certain cytogenetic abnormalities, even in absence of dysplasia, one can make diagnosis of MDS. So for example, patient who's anemic, has deletion 5q, or patient who's pancytopenic, has complex karyotype, those can be used to make diagnosis of MDS. Now, the classification of MDS is really evolving, and this had really been recently a subject of debate because for the first time now we have two classifications. In the world of lymphoma, we are used to have more than one classification, but historically in myeloid diseases, we had one classification. But recently, the WHO and the international consensus classification split on the classification of MDS. We tried to look at this during this last ASH meeting and try to publish, harmonize the data between both. I think there are, advancement and there are similarities between the two newer classifications, but there are subtle differences. What we are moving into is really a molecularly defined classification. So now we have common genetically defined groups in both the classifications, patients with deletion 5q, which we've historically had already, SF3B1 mutation, and TP53 mutation, particularly what we call multi-hit or biallelic P53. We still have also morphology-defined groups, low MDS with no blasts, MDS with excess blasts. The WHO included or introduced MDS with fibrosis as well as in MDS with hypoplastic MDS because of its therapeutic implication. Obviously, the access to somatic mutation sequencing is not readily available. Even in the United States, sometimes it takes us 3 to 4 weeks to get those results. So sometimes we have to wait, and this had created a little bit a backflow on signing the bone marrows based on this classification. There are few things one could use or infer to predict those abnormalities. So for example, if there are ring sideroblasts, there is almost and no increased blast, there is probably 80-90% chance that this is an SF3B1. Similarly, for P53, there are studies looking at immunohistochemistry staining. If the ring sideroblasts are increased and there are increased myeloblasts, actually that becomes an association with P53. So there are certain, pathological findings that can lead you to know or predict the molecular profile. Similarly, if you have a patient with a complex karyotype on cytogenetics that includes deletion 5q, then you probably have 80-90% chance of having P53 mutation. The ICC also introduced this, entity now, MDS/AML, if the myeloblasts are more than 10%, where those patients can be treated either as MDS or AML, and they have different subsets among those. Similarly, also the risk stratification or the staging has been evolving. Historically, we used the IPSS. Now we have, and most recently, we've been using the revised IPSS. The idea after establishing the diagnosis is really estimating the risk of the disease, because currently our only therapeutic option for those patients remains allogeneic stem cell transplant with cure rates roughly of 40 to 50%. However, the transplant-related mortality is around 20%. So the question is always, do we have enough risk of disease to justify the allogeneic stem cell transplant? And those patients that we label as higher risk, the maximum gain of survival is to consider allogeneic stem cell transplant earlier on, while if patients are lower risk, our goal of treatment is alleviate cytopenia and the related complications. So the revised IPSS is what we've used for many years. It's a sum score where we look at the blast percentage, the cytopenias and their depth, and the cytogenetics, and we put the patients in one category from very low to very high, as you can see here. And you can see the survival varying from almost 9 years average to less than a year. And this is an important point because we don't think of MDS often as bad disease, but when you get to the high and very high risk disease, you can see that the median survival for patients with MDS is unfortunately sometimes worse than currently a metastatic lung cancer or any other solid tumor. Now, what we are moving into is molecularly based risk stratification. So there is now a model that had been proposed called IPSSM or IPSS molecular that actually integrate both clinical, cytogenetic, and molecular features to better predict the risk of the disease. So it kept all the variables from the revised IPSS with the exception of the neutrophils, but then it adds genetic variables. This is a calculator available online that you can plug those information in, and you will come with a risk score. And even if you are missing some data, it will give you the best and worst case scenario. It's really very useful to refine the prognosis or the risk estimate for the patients. What were the most important findings in terms of molecular mutations? That obviously if you have a TP53 mutation, particularly what we call a multi-hit, and that's defined if the variant allele frequency is more than 50%, if you have more than one hotspot or abnormality, or if you have a complex karyotype with a P53 that's considered multi-hit. That's usually probably the worst subtype of MDS. There is this new abnormality called MLL, partial tandem duplication, that most actually of the current NGS profiles don't include. That's rare, but it's really associated with worse outcome. And if you see FLT3 in MDS, which is not common, that's also associated with worse outcome. The best outcome is with SF3B1 splicing mutation. However, that also can be variable. So those patients that have deletion 5q plus SF3B1 don't do as well. There are certain other mutations, if present with SF3B1, they don't do as well again. But the idea here, we come with a score where we put the patients in 1 out of 6 categories. 0 is an average risk. And you can see how patients are going to do compared or relatively to an average risk patients. So if patients are, very low or moderate low, we are considering those are lower risk. The other group we are considering as a higher risk. And what they showed, almost like half of the patients were restaged. Almost 10% of the patients were staged or stratified more than one strata. And the question now, if we have a patient that you considered as a very low risk by the revised IPSS, but they are coming as a higher risk by the IPSSM, should we be considering allogeneic stem cell transplant? I think we need more data, but I believe so, because this is probably a better estimate of the risk of the disease. So once we labeled the patient into a lower risk, how do we manage those patients? The first question is like, what's the natural history of lower risk disease? And I think, obviously those patients, especially, in place like Jordan, many times don't get to the cancer center because they are treated or hematology oncology because they are treated for anemia. And the question is like, what happens to those patients? This is an attempt from our group trying to look at the natural history for lower risk MDS. So most of the patients, actually 70%, will stay as lower risk. There is 1/3 that will progress, and there are different patterns of progression. So some patients will go to higher risk MDS and never progress to AML. Some patients will go to higher risk MDS, then AML, and some patients will progress directly to AML. And we can see some variation in the clinical and molecular profile for those patients to predict that. However, even if you look at a patient that are lower risk, that stay lower risk, more than half of the patients will die from complications of the disease, mostly complications related to cytopenia or the interplay of the cytopenia and other comorbidities. So many of those patients are in their 70s, they have coronary artery disease, congestive heart failure, and if they are profoundly anemic, there is no doubt that MDS is going to be contributing to the morbidity and mortality of those patients. So, obviously what we are moving into in the lower risk is trying to prevent MDS. We are trying to change our goal of therapy, not just a palliative or alleviation of cytopenias, extending benefit of current therapies and using newer approaches for those patients. Now, we recognize recently that the spectrum of myeloid neoplasm is even actually broader, and both ICC and the WHO introduced those pre-MDS conditions called CHIP and CCUS. So now we know that myeloid malignancies are spectrum. This is similar to what we've known in myeloma or B-cell lymphomas, where you have MGUS, then smoldering myeloma, then myeloma. This is almost the same story. So obviously, we have an entity called CHIP now, clonal hematopoiesis of indeterminate potential. Those are patients that actually have no cytopenia, normal blood counts completely. But if you do somatic mutation sequencing, you will find that they have a mutation. Typically, the size of the mutation or the variant allele frequency is in the range of 10 to 20%. The most common encountered are either DNMT3A, TET2, or SXL1. If we sequence 100 people walking in the street above age of 70, 20% of them will have this. And I'll talk a little bit about the implication. If patients have low blood count, but no dysplasia or increased blasts, that's called clonal cytopenia of unknown significance. Typically, they will have an average of couple of somatic mutations. So the line between CCUS and MDS is really very fine, where in MDS we can demonstrate dysplasia. Why is this CHIP story important? So those patients are at higher risk of hematological malignancies, around 0.5 to 1% per year, very similar to MGUS. Majority of those patients actually will not develop heme malignancies. But interestingly, the number one cause of mortality among those patients is actually atherosclerosis compared to somebody that will not have CHIP. And there are mice models suggesting that some of those mutations, like the TET2, will lead to accelerated atherosclerosis mediated through inflammatory pathways. The only thing that CHIP is protective for is actually dementia. The other important aspect, we published on this a few years ago, and the MD Anderson group had the same publication, that if patients had CHIP and they receive chemotherapy for other diseases like lymphomas or breast cancer, they are at 6 to 12 folds higher risk of developing therapy-related MDS. And I think this is very important, because if you have a patient that you are giving adjuvant chemotherapy for breast cancer, and your absolute survival advantage of that is 2%, but now you know that this patient have 5% chance of developing mostly a fatal therapy-related MDS or AML, that may change our decision on the benefit of adjuvant chemotherapy in solid tumor. The other area of interest is really after transplant, where we are seeing donor-related CHIP and donor-related disease that develop in those patients. So now actually we are establishing a clinic of CHIP or CCUS, where we sequence all the patients coming for solid tumors, and we counsel with those patients about the cardiovascular risks, as well as the risks of developing therapy-related MDS. Patients with CCUS almost have natural history like lower risk MDS, and if they have more than one mutation, certain mutations, almost 80% of those patients will develop frank MDS in short time. And there are data on treatment for those patients similar to what we treat with lower risk MDS. And there are some ongoing studies about prevention or trying to prevent the progression of CCUS to frank MDS as well. Now, once we establish the MDS, if we said this patient is lower risk, the question is always, do we need to treat those patients or not? If somebody have moderate cytopenia, let's say their hemoglobin is 10 or 11 and they are asymptomatic, there is really not yet, other than in clinical trials, principle of very early treatment if somebody have adequate hematopoiesis. In 90% of the time when we are treating in lower risk MDS, we are treating for anemia. Sometimes the concomitant thrombocytopenia or neutropenia will dictate your choice of therapy, but most of the time we are not treating neutropenia or thrombocytopenia. And if the patients are anemic, erythroid stimulating agents, whether it's erythropoietin, now the biosimilars, or longer acting darbepoetin, it's really a matter of dosing, and all of them are acceptable choices. The dosing is equivalent somewhere to 40 to 60,000 of erythropoietin. Usually we do 8 to 12 weeks trial. If the patient is responding, then we continue. You can simply check endogenous serum EPO level for the patients and look at the magnitude of transfusion burden and predict the chance of response. So if somebody's endogenous serum EPO level is more than 500, or if they are receiving more than 2 units of blood per month, their chances of response are really less than 10%. In the past, if patients will have suboptimal response to EPO, we added GCSF. But in further meta-analysis, probably this is matter of dosing of the erythropoietin. So this had dropped out of fashion, adding GCSF or GMCSF to erythropoietin for an erythroid response. So if patients had low chance of ESA response or ESA failure, the next step we ask, do they have deletion 5q? And if they do, obviously lenalidomide is the standard of care for those patients. Typically the response is, almost 70% of those patients will become transfusion independent with durable responses in terms of 3 to 5 years. Now, there had been movement to try to introduce this therapy because lenalidomide is active in deletion 5q earlier. This is a study recently from the Spanish group called the Centra-Rev study. So lenalidomide was approved by the FDA for patients that were transfusion dependent with deletion 5q. Typically, obviously, we treat patients with anemia when the hemoglobin is less than 9 or if they are transfusion dependent. So the Spanish group treated patients with a little bit more moderate anemia. Once they are between 9 to 12, they actually did a 5 milligrams, so it's a lower dosing of the lenalidomide that we use. They did it only for 2 years. And their primary endpoint was really looking at the transfusion-free survival or time to transfusion dependency. And they showed with this probably cost-effective approach that the time to become transfusion dependent was almost 6 to 7 years, if you treated those patients only for 2 years with 5 milligrams of lenalidomide, compared to, like, you know, obviously a year or so with the observation or placebo approach. They also were able to show that the clones remained stable or decreased in size, particularly TP53, that's usually present in almost 20% of patients with deletion 5q. So this is something we are starting to consider in patients with deletion 5q, earlier, smaller dose, and shorter term of treatment, not indefinite treatment for the patients. If patients don't have deletion 5q with the lower risk, the next question we ask, do they have ring sideroblast or SF3B1? Because now we have this treatment called luspatercept that was FDA approved for this subset of patients. Luspatercept is a fusion trap protein that binds to the TGF-beta ligands, neutralizing them in the serum. TGF-beta ligand actually regulate terminal erythroid differentiation negatively. So this will release the block on the terminal erythroid differentiation. We actually developed those drugs years ago looking at a compound called sotatercept, and then we moved to luspatercept. There was a study we published in the New England Journal called The Medalist that looked at MDS with ring sideroblast, lower risk, using luspatercept, which is an injection once every 3 weeks, showing that 1/3 of the patients became completely transfusion independent. But if you use this treatment earlier on, when patients are not getting more than 4 units of blood every 2 months, the responses can be as high as 80% and durable, exceeding a couple of years. It can work also in patients with MDS with MPN ring sideroblasts. This is going to probably move forward to frontline. There is a randomized clinical trial that finished accrual called COMMAND study that randomized all patients, not just with the ring sideroblast, between luspatercept and erythropoietin. The press release on this study that it met the primary endpoint, and this will be presented at ASCO and EHA. I think we'll have to look at the results of this study. Obviously, there are worries about the cost and the availability of this treatment. So probably not every patient upfront with MDS will be treated with luspatercept. There is going to still be a role for erythropoietin, but there are subset of patients that probably will benefit from this treatment as first line. The other treatment that will probably become available at the end of this year is a drug called imetelstat. This is a telomerase inhibitor. Telomere is shortened in MDS patients, and by further inhibiting the telomere, the idea that it's almost the principle of synthetic lethality, that we eradicate or kill those cells that have short telomere. And this drug has been tested in MDS and in myeloproliferative neoplasms. There was a phase 1 and then phase 2 part of this drug. It's an IV infusion given once a month. And in the phase 2 of this study, around 40% of the patients became transfusion independent, 1/3 of them more than a year, particularly those ones with ring sideroblast again or SF3B1. And the appealing part that in patients that had documented SF3B1 and serial monitoring, 9 out of the 11 patients had serial reduction in the SF3B1 mutation, suggesting that this treatment can alter the natural history of the disease. The phase 3 concluded, and also the press release of the results was out, showing that it met the primary endpoint in both patients with ring sideroblasts and non-ring sideroblasts, in patients that also were heavily transfusion dependent, and again, a signal that this could alter the natural history. The full results we will be presenting at ASCO and EHA meeting, and I anticipate this drug will be approved in the United States by the end of this year or early next year. The main adverse event is myelosuppression on target, so this is not going to be for patients with pancytopenia, namely for anemia use in lower risk MDS. In patients that don't have deletion 5q or ring sideroblasts, if they are in the younger age or they have hypoplastic MDS that we see in 10 to 20% of the cases, ATG cyclosporin could be a reasonable option. This is one course of ATG that can lead to more than 50% responses and durable. So in our institution, if patients don't have deletion 5q or ring sideroblast after ESA failure or they have pancytopenia, they are young, early in the disease course, then we do actually ATG cyclosporin regardless even of the cellularity of the bone marrow. And then the rest of the garden variety of the lower risk, in the United States, we do use lenalidomide plus ESA if patients are purely anemic. And in the rest of the patients, if they are cytopenic, if you have significant thrombocytopenia or neutropenia, or they've gone through all the lines of therapy, we use hypomethylating agents. But we've been trying to pioneer this low-dose hypomethylating agents where only 3 days of azacitidine or decitabine seems to be adequate in lower-risk MDS. Rarely we will encounter patients that are having isolated thrombocytopenia or neutropenia. For isolated thrombocytopenia, TPO stimulant are reasonable choice, like eltrombopag. This is a study from the Italian group showing more than half of the patients achieve the response, and they are durable with really no signal of increased risk of progression to AML or fibrosis. Severe neutropenia, if it is isolated and the patient never had recurrent infection, we rarely treat in lower risk MDS, because obviously those patients are not getting chemotherapy. There is no mucositis, no risk of infection. But if patients have recurrent infection, then we treat. There are really not many good options for treatment of neutropenia. Recurrent or continuous use of G-CSF had not been shown to be of a value. Hypomethylating agents only have 20% response. We've been interested trying to look at the mutation spectrum in those patients, and we found that those patients are highly enriched with the IDH1, IDH2 mutations. So if that's present, our approach has been trying to use IDH inhibitors among those patients. But I will only treat for severe neutropenia and the lower risk MDS if patients had recurrent infections. So moving to higher risk MDS, I think obviously the only curative option for those patients is allogeneic stem cell transplant. So if we label patient higher risk, the maximum gain is really moving to transplant early on. This is recent study, again, emphasizing the role of allogeneic stem cell transplant, where the randomization was based on donor availability, showing that still allogeneic stem cell transplant is the only curative option. Roughly, again, 40% of the patients will be cured. The offset is the 20% transplant-related mortality, but the maximum gain of survival in higher risk MDS patients is moving to transplant. In our center, we transplant patients sometimes even up to the age of 80 if they have no comorbidities and excellent performance status. However, I think the margin of benefit of the transplant is definitely way smaller in patients above age of 70. Nowadays, with availability of different donor sources, I think we can almost identify a donor for all the patients. The question is, do we take those patients to transplant directly? What do we do before transplant? I think obviously what dictates the outcome is the percentage of the blasts going to transplant, the cytogenetics, and now the molecular data. Although there is no consensus, if patients don't have increased blasts, one could go to transplant directly, but most people feel that some treatment prior to transplant is reasonable. In our center, if patients do have P53 mutation, that's the highest predictive of outcome in transplant, particularly if it was multi-hit. I feel that those patients should be treated prior to transplant to try to clear the mutation, because when you look at the risk of recurrence, if they go with detectable, especially high allele burden, almost 80% of those patients will relapse within a year. I find it ethically hard to push through that. But if we treat those patients with hypomethylating agents or on trials and clear the P53 or bring the allele burden at least less than 10%, then you can see that those patients can have better outcomes. In the group of patients that we could not clear the P53, their outcome with or without transplant actually was not different. Now, in reality, even with aggressive intent to transplant patients, a lot of the patients will not be able to be transplanted. Our backbone or mainstay is using hypomethylating agents, either azacitidine or decitabine. Those drugs have been around for a while. Azacitidine phase 3 trials, demonstrated survival advantage. Decitabine did not, but in reality, they are really interchangeable. It was really more study design. The original studies showed around 24-month average survival with those treatments. The reality, what to expect with this is somewhere around year and a half overall survival, around 20% complete responses, and half of the patients responding for a year and a half, and then they stop responding. It takes on average 4 to 6 months to get the response. If patients are responding, we continue. If we start those treatments and patients' baseline is cytopenia already, we push through the first rounds and we don't delay the treatment. Now, decitabine in the United States became available as oral, where it's bound to cytazirudine. This will inhibit CDA enzyme that usually degraded decitabine and didn't allow its absorption. Oral decitabine or cytazirudine decitabine is 100% bioequivalent to decitabine, so it can be used interchangeable, which is easier option for patients. But even in the USA, the copays had been an issue for those patients. But the responses and the data looks very similar to decitabine, maybe even suggesting some higher responses, but also probably a little bit more myelosuppression. Now, can we improve on the backbone of hypomethylating agents in the higher risk MDS? So as you know, Venetoclax now had become the standard of care for patients with AML. And we are trying to see if we can borrow or use that in MDS, higher risk MDS, where the blasts are increased. The phase 1-2 data have been published. The phase 3 finished accrual, but we are waiting for the results next year. What's clear in MDS that the dosing is different from MDS. From AML, sorry. So you don't do the continuous 28 days, even the cycle 1. It's only 2 weeks of Venetoclax treatment. And the responses looks promising, where we double the complete response rates. The adverse events are more, so you get more profound myelosuppression. So if we are using the combination AZA Venetoclax, whether it's MDS or AML, it's very important to repeat the bone marrow after the first cycle. If the bone marrow is hypocellular and the blasts were reduced, we pause or give holiday from both the hypomethylating agents and the Venetoclax till the counts recover. And then we start the next round when we have some count recovery, and we typically back off the Venetoclax dosing even further. Most of the patients actually will end to have 1 week of the Venetoclax. So it's really not necessarily to have the continuous Venetoclax 28 days, even in AML in most of those patients. This is our data looking at the AZA-VEN in MDS. We treated a small cohort of almost like 40 patients and compared them to more than 1,000 patients we treated with HMA alone. And indeed, we see higher responses. The overall survival for the whole group doesn't look different so far, but particularly for patients going to transplant, this looks like promising approach. Certain mutations like P53, we don't see really impact for the adding of the Venetoclax. An SXL1 mutation that typically does not respond to hypomethylating agents, we see higher responses. So where do I use Venetoclax currently in MDS? In patients with excess blast, obviously. If we are going to transplant, particularly if they have ASXL1 mutation. In patients with P53, even in AML, there is really no survival advantage. There are some studies that are trying actually to pioneer a very cost-effective way of doing hypomethylating agents and Venetoclax, where they get once a week Venetoclax on day 1, and then on day 2 they get very low dose, like almost 0.2 milligram per kg of decitabine, but continuously. We call it metronomic. And the initial results with that looks, that the responses, particularly on older patients, is very similar to the regular decitabine Venetoclax we do. So that could be a promising cost-effective strategy in the near future that we will be using. The other drug that finished phase 3 trial is magrolimab. This is an anti-CD47. CD47 is known as the don't eat me signal. So it's usually expressed to prevent macrophages engulfing the cells, and it's overexpressed in MDS AML. So this is an antibody that will bind the CD47, allow the macrophages to engulf the leukemia or MDS cells. And in the phase 1-2 studies, it had shown promising activities, again, doubling the complete response rates, and it seemed to be agonistic of mutations. So the responses in the mutant P53 are very similar to wild P53. The main adverse event with magrolimab is hemolysis on target that we see the first round, because CD47 is expressed on mature red blood cells, but after cycle 1, we don't see this hemolysis. And the data from the phase 1, phase 2 looks promising, particularly in the P53. So this had finished a randomized phase 3. We are waiting for the results, but there are several ongoing combinations, AZA-VEN compared to AZA-MAGRO in P53 AML, triplet AZA-VEN MAGRO in MDS and AML, and there are other CD47 monoclonal antibodies in clinical trials. So after hypomethylating agents, what to do for those patients? Obviously, this is an area of unmet need. The survival for those patients after HMA failure in the higher risk is poor. The best outcomes are achieved if we could get those patients to transplant or on clinical trials. What we do is always we advocate to reassess the disease status at time of failure. When patients have HMA failure, there are different patterns. Some of the patients would have progressed to AML. Some of them will see the blast had increased again. But in some patients, we only see this bone marrow failure. And it's probably, if we have access to do somatic mutation analysis, it's helpful because sometimes we'll see emergence of mutations that almost in 1/3 of the patients make it targetable, such as if we have IDH1, IDH2 mutations. In the rest of the patients, if we have no target and no clinical trial, we sometimes, if they have normal karyotype, consider this mini-CLA chemotherapy, which is cladribine RSC. Nowadays, we are starting to add Venetoclax for that. Or we shift the hypomethylating agent. So if patients were on azacitidine, we shift to decitabine and add Venetoclax. And there is data, this is again from our own Dr. Zidan phase 1/2 study where he looked at adding VEN in patients with HMA failure and showing around 20 to 30% responses. And this is again our data from Moffitt showing that we see almost 13% complete responses by adding Venetoclax. So Venetoclax could be a strategy as add back at time of HMA failure. I think in the future, in the higher risk, we are gonna move to a backbone of doublets or triplets. We are gonna be looking at MRD status to guide treatment. Allogeneic stem cell transplant is important. And also we will be looking at maintenance post-transplant. I think with that, I would stop. Thank you very much for the kind invitation and thank you for listening.
Thank you, Rami. Can you hear me?
Yes, thank you.
Thank you so much for this excellent presentation. I'm sure there will be a lot of questions. If from the audience, I'll start with the audience. If no questions,
Yes,
I'll
please.
start asking my questions.
دكتور بصير نسأل؟
تفضل.
يعطيك العافية دكتور رامي.
خليك هلا.
My question, we have a lot of patients with RIPE2 MDS. Do you think that this patient have a role of induction chemotherapy in the management of such patients? And I wonder why not to start with induction chemotherapy as with acute leukemia? Because we have a lot of patients with a 15% blast. And what differs between this and acute leukemia? I think it is should be managed as acute leukemia. What do you think?
So historically, it's been looked at. So yes, to your point, there are cases where you'd consider them, and some places actually do consider that if the blasts are more than 10%, that you could follow a strategy of induction. There is a drug called CPX that's approved for secondary MDS AML in the United States. There had been studies trying to look at 10% and above. However, I would say there are different couple of things. In the past, when they looked at like a classical 3+7, the responses are really suboptimal. Your chances of achieving a complete response are probably 20% or less. Because in the RAB or the excess blast or the MDS group, many of those patients are enriched with poor cytogenetics, P53, and they have the background of underlying MDS. So the bone marrow is sick, not like in de novo AML. So your outcomes are not going to be as good as even de novo AML when you use induction chemotherapy. And when we looked in the past at that approach, doing azacitidine versus intensive chemotherapy, even going to transplant, there was really no difference. Having said that, sometimes obviously if you have limited resources or somebody is younger, doesn't have complex karyotype doesn't have P53, I think it's reasonable. Our approach, we don't do 3+7 garden variety. We do like CLAG-M, or we do nowadays CLAG-M Venetoclax. But there is definitely a role, but that's why we don't use it commonly, because the background for the RAB is, MDS, more defective hematopoiesis, and also typically more complex karyotype mutations that predict inferior response to chemotherapy.
Thank you. Unfortunately, we ran out of time, so we'll allow one more question.
أسامة محمد سلامة بحكي.
أهلا.
كيفك؟ Rami, thank you for such a wonderful presentation. My question to you, do you think nowadays, what's the role of the CAR T cells as a replacement for allo transplant for those patients?
Thank you, Dr. Salami. Thank you, and it's a pleasure to have you on the meeting. Yeah, so it's still early, very early. The role of CAR Ts are very primitive in MDS and AML. It's been really a challenge because we've not been able to duplicate what we've seen in lymphomas. There are a few trials ongoing. So far, very early and very modest activity. One of the challenges had been really the delivery of the CAR T to the bone marrow, the concerns about the ablation. We have 3 CAR T trials, and I think those are the most had been presented on, one against CD33, one against CD123, and then we also did off-shelf NK CAR T. The best we've seen was CD33, but it was really in the arm where patients got conditioning with flu mel. So I'm not sure that even the whole thing is related to CAR T. I think in the future, we are trying to look at how can we better deliver the CAR Ts to the bone marrow, use off-shelf, but it's very, very early. So at this point, it doesn't seem that it's going to be replacing allogeneic stem cell transplant. There are some attempts also to look at bispecific antibody treatment like CD3, CD33. And again, those may be a little bit more successful in AML, but not much in MDS.
Thank you very much.
Quickly, Rami, for the take-home message that P53, probably nothing works, right? In neither transplant or medication. Any role for checkpoint inhibitor in any MDS in your experience or in your research?
Thank you. Yeah, so the P53, obviously the book answer if there is a clinical trial. If not, hypomethylating agents alone probably are still the best option. If cleared the mutation or like decrease the burden, then transplant. Checkpoint inhibitor results had been kind of disappointing in MDS, so there is really no clear role. There had been studies looking at ipilimumab or Nivo, really very modest activity. So label or like out of the box, we don't use them. The magrolimab is considered in a way a checkpoint inhibitor against the macrophages. That's our most promising thing, but it's still, we are waiting for the phase 3 data.
Thank you so much.
It's good to see you all, and thank you for the kind invite. Thank you.
Thanks.
واحد يعزمك تفيدك Can I start? Assalamu alaikum. Good evening, everybody. Our speaker now, Dr. Gianluca Gaidano. Dr. Gaidano is a professor of hematology at the University of Eastern Piedmont, Novara, Italy. He started his medical career at the University of Turin, where he received his MD and PhD from 1990 to 1994. He was at Columbia University, New York, where he trained in molecular hematology. His research interests relate mainly to precision medicine of lymphoid malignancies, with a focus on CLL molecular predictors and targeted treatments. Other fields of interest concern hematological neoplasia in immunodeficient patients. He has been a board member of EHA and is currently chair of the EHA Global Outreach Program, vice chair of the Membership and Community Engagement Committee, and serving as a member in the EHA Educational Committee. He is a board member of PHIL and of the JMIMA Working Party on chronic lymphoproliferative disorders. He has been president of the Italian Society of Experimental Hematology. He is a member of EHA, ERIT, ASH, ASCO, SCI, and CES. He has published over 650 scientific articles and contributed to several textbooks. Dr. Gianluca talk will be about CLL management updates and the use of pathways inhibitors. The mic is yours, Dr. Gianluca.
Thank you. Thank you very much. And I hope you can see my slides and you can hear me. Thanks.
Yes, we can.
Okay. So, Anasa Jeddan Litewajuri Makum Alion. I'm very happy to be with you all today, but this is where my Arabic goes. So it's a bit limited. So these are my disclosures, and I will talk to you about the management of CLL and the new options that we have today. There are also a few disclaimers for you to read. The presentation is only to ensure consistency with approved indication within HICMA's local product information, and some of the mentioned products might not be registered in your country. Now, as you all know, and this is an important slide to set the frame, CLL may derive from B cells that have been transiting through the germinal center, and while transiting through the germinal center, they have acquired mutations of immunoglobulin genes. You may have a phase of monoclonal B-cell lymphocytosis, and then what we call mutated CLL, mutated for IGHV mutated. But we also have a fraction of CLL that instead of originate from B cells that have undergone T-cell independent immune response, they have not been transiting through the germinal center, and these will be unmutated in the immunoglobulin genes. And we'll see that this makes a huge difference when we get to prognosis, but especially to treatment indications. So with this in mind, what I'm going to do is trying to review with you the management of asymptomatic CLL, and then the treatment-naive first-line patients, young and fit, and then the largest category of our patients, treatment-naive but elderly or unfit, and finally, a few words on relapsed refractory. Well, for asymptomatic CLL, we need to stick to the so-called HALEC guidelines that were published a few years ago. So there are specific indications for treatment that are listed here, but in the absence of these indications for treatment, the option is watch and wait, and this is strongly recommended by guidelines. We have to be very careful because sometimes we misregard constitutional symptoms that in fact are very rare in CLL, and I would also argue that lymphocyte doubling time should be carefully rechecked. One single determination would not be sufficient, and very rarely lymphocyte doubling time would be the only reason for the only indication for treatment. So we have to be very careful, and watch and wait would be the main strategy for these patients outside of clinical trials. We have prognostic scores that can tell us and can identify patients at imminent risk of progression. This was published
in blood by our collaborative group in a few years ago. It's called IPSE, International Prognostic Score Early, for early stage CLL. And you see it is based on very simple parameters: the absolute lymphocyte count, palpable lymph nodes, and unmutated immunoglobulin genes, as I told you before. And you see that patients who have a high risk, 2 or 3 of these variables, have a relatively imminent risk of progression compared to patients with low risk. You can improve this score by also including the mutations that have been identified by next generation sequencing in CLL, and this cloud represents many of them, but one is important for treatment requirement in first line, and these data are not yet published. They've been presented by Ricardo Moy of our group at ASH, and the gene is called XPO1. It codes for X-protein 1. It's an important target because there's also a class of drugs that target XPO1, in fact. Selinexor is one of them. And as you see here, patients carrying XPO1 mutations with BNA or Y0 CLL, they have much earlier probability of time to first treatment compared to wild-type patients, and this has been validated in several cohorts, and there are also biological reasons for that, but we don't have time to go into that. Now, moving to treatment-naive, young and fit patients, this obviously will be a small fraction of patients in our cohorts, and we have to keep in mind the very important role that the B-cell receptor plays in CLL pathogenesis. And this is very important both in terms of autoantigens that stimulate the B-cell receptor, but also the so-called autonomous signaling that is given to homotypic interactions through different B-cell receptor molecules. And we do have therapeutic targets in CLL that allow us today to spare chemotherapy to our patients. On one side, we have BTK, Bruton tyrosine kinase, a component of the B-cell receptor that can be targeted by the so-called BTK inhibitor, BTKI, either covalent BTK inhibitor, and ibrutinib has been the first in class, and non-covalent, these are more recent, pirtobrutinib and nemtabrutinib. There are obviously biochemical differences in the mechanism of action and also in the resistance to these drugs. But on the other hand, you can also target the apoptotic pathway that is represented here. Just let me remind you that deletion 13q14 is the most frequent molecular alteration in CLL, and it deregulates the expression of BCL2 that will be overexpressed and can be targeted by a BCL2 inhibitor, and Venetoclax again has been the first in class. Now, BTK targeting, what it will do, it will shut off the downstream pathway like NF-kappa B activation, AKT and mTOR activation, the MAP kinase pathway, so that then finally in the nucleus, the target genes will no longer be expressed. And this is just to summarize very quickly what will happen, the shut off of these downstream pathways. One concept that we should keep in mind is that these agents especially are active in the lymph nodes, because the lymph nodes is the site of CLL growth, not the peripheral blood. And by so doing, the BTK inhibitor induce a redistribution, lymphocytosis, so the CLL cells will be squeezed out of the lymph node by the BTK inhibitors and will migrate into the peripheral blood. So you may have at the beginning of treatment, and this is something that we should be very cautious about, especially when discussing it with the general practitioners, you may have an increase in the lymphocyte count, but then it will slowly go down. And this is important to explain, as I said, to the patient that sometimes get worried, and especially to the general practitioners who may not be familiar with this phenomenon. The different BTK inhibitors have different selectivity for kinome, and please keep in mind that not always being highly selective means improvement. So you see the first generation, and ibrutinib is obviously the first in class. It targets several other tyrosine kinase apart from BTK. Acalabrutinib appears to be more specific, but if you look at zanubrutinib, again, the profile is rather different. And we'll see then what this translates into the clinical practice. Another important concept that I would like to discuss with you before entering in the clinical results is that in CLL we have many, I would say too many prognostic biomarkers. But what we instead really need are predictive biomarkers. Predictive biomarkers will be useful for treatment tailoring, while prognostic biomarkers may perhaps help us in defining the patient counseling, but will not really tell us choose drug A or drug B for that patient. And the need for molecular predictors is obviously a requirement for precision medicine. And this is where hematology and also oncology are aiming to, obviously. And CLL, I think, is a very good model. The most robust biomarker that we have available for CLL is represented by abnormalities of the p53 gene. p53 is a tumor suppressor, also called the guardian of the genome. And I would, from a diagnostic point of view, I would like to stress that p53 abnormalities in CLL are a very potent predictor of chemorefractoriness to chemoimmunotherapy. And these alterations may be present in two forms. On one side, deletion of the short arm of chromosome 17, and you can see it here well. This you will be able to detect by FISH. But there are also cases that carry mutations of p53 that are here. And these point mutations target the DNA binding domain of the gene, and they will not be recognized by FISH, but only by DNA sequencing, which can also be Sanger sequencing, so traditional Sanger sequencing, or otherwise also next generation sequencing. Now, this is important because, as you see, there are patients here that carry mutated p53, but no deletion. These patients would be missed if you perform only FISH. So the guidelines recommend to perform both tests, FISH for del17p and DNA sequencing for p53 mutations. Another important concept is that these mutations or deletions may be acquired over time. If you look here in the left bottom panel, you see that p53 disruption occurs in approximately 10% of CLL requiring treatment, but then the figure rises to 40% in patients who are refractory and up to 60-70% in Richter syndrome. So that means that you should retest p53 disruption at each treatment requirement, because even if the patient was negative before, it may now have acquired a p53 alteration. And in fact, the guidelines, the IWCLL guidelines that we all should stick to, recommend to test del17p always in the general practice, but also p53 mutations always in the clinical practice. And we shall also spend also a few words on immunoglobulin gene analysis. That is also very important as a predictor for treatment choice. And you can see here the value of IGHV mutation status for defining the outcome after chemoimmunotherapy. In the case of FCR here, you have the MD Anderson data, the CLL8 study, and our own study. And you can easily see that patients with unmutated immunoglobulin genes here, they have a very poor response to chemoimmunotherapy compared to patients with mutated immunoglobulin genes. And this is true for all studies that have been. These three were the very first ones, but more have appeared over the years. And you can see that with FCR, and this might also be an important concept if you don't have pathway inhibitors available for first line, for IGHV mutated patients, FCR can confer an overall survival that is overlapping to that of the matched general population for sex and age. And these are our data that we recently updated with a 15-year follow-up. So this is an important concept. FCR benefits the most young and fit patients with mutated immunoglobulin genes and without p53 disruption. But certainly chemoimmunotherapy is not an option today, or should not be an option today, for patients with unmutated immunoglobulin genes, because these patients, and you can see it here very well, again, they will have unsatisfactory prognosis. And we have now drugs that can overcome this predictor. In fact, ibrutinib improves both PFS and overall survival compared to FCR in young and fit patients, and this is represented here for both progression-free survival and overall survival. This trial was run by Dr. Schanafeld in the US, and you can see at 3 years, ibrutinib rituximab for PFS 89.4% compared to 72.9% for chemoimmunotherapy. And again, you also see a significant difference in terms of overall survival. Now, this is particularly true for patients. This difference between ibrutinib and chemoimmunotherapy is particularly true for patients with unmutated immunoglobulin genes. And you can see here the two curves that diverge for ibrutinib rituximab in red versus FCR, the dotted black line. While instead for the mutated patients, the curve tend to be similar, even though with a longer follow-up, we know that they will diverge, but not as much as the IGHV unmutated patients. Now, this trial, ibrutinib rituximab versus FCR, also showed that the ibrutinib rituximab arm was characterized by a lower incidence of cytopenias and infections, and this, I think, could be expected, and by a rate of cardiac adverse events, and you can see here 4.5% of atrial fibrillation in this cohort of young and fit patients. But we shall come back to that, to this concept. The FLAIR trial has been comparing FCR versus ibrutinib and rituximab. It's also randomized phase 3 trials, and you can see it here run in the UK. And again, you can see the superiority of the ibrutinib rituximab arm first line versus FCR here in red. And I think the results comment themselves. And again, what is important is that the IGHV mutation status has an impact not only in mutated versus unmutated, but also in the specific B-cell stereotype subset that we are considering in the patient. And in fact, one subset that is called subset 2 has a very poor outcome. Here you see clearly the difference between ibrutinib rituximab versus FCR in the IGHV unmutated patients, where instead for mutated patients, the two curves tend to relatively overlap. So just to summarize at this point, who really can benefit from FCR? Well, many patients with CLL may never require treatment. Another large fraction are too old for FCR, above 65 years of age, or have comorbidities that prevent FCR application. Another fraction of the remaining patients have unmutated immunoglobulin genes, and I showed you that these patients do not benefit from chemoimmunotherapy. A fraction remains MRD positive. So finally, it's only a small 7 to 8% of patients who really benefit from chemoimmunotherapy out of a consecutive series of CLL patients that we would see in our clinics. The majority of our patients are in fact treatment elderly and unfit in the context of treatment naive. And I think this is true certainly in Italy, which has a very long life expectancy, but I suppose also will be similar in Jordan and all over the world. And as we very well know, the population life expectancy is continuously increasing. The RESONATE-2 trial in the context of elderly patients or unfit patients with CLL showed the superiority of ibrutinib versus chlorambucil, and you can see that well in the left top panel here. We now have the 8-year update that confirms this important result. And what is again important is that ibrutinib is able to overcome the negative prognostic significance of unmutated immunoglobulin genes, because you see that the two curves in fact overlap, and you can see it here. One other important issue is that ibrutinib is obviously favored in patients with high-risk genomic features like p53 mutation, unmutated immunoglobulin genes, and in this cohort also deletion 11q. The long-term safety of this trial has also been documented, and if we just look at the adverse events of clinical interest with BTK inhibitors, you certainly see a fraction of patients who develop hypertension over time, but we have many drugs that can control hypertension, so usually this is not a major clinical problem. Atrial fibrillation is restricted to a fraction of patients, as you can see here, between 5 and 10% in different years. And major hemorrhage is overall a very rare event. And this might be explained by the fact that ibrutinib, but all the other ones may also target TEC, that is a kinase important for platelets. Now we also have second generation BTK inhibitor, and the ELEVATE-TN trial addressed the efficacy of acalabrutinib in treatment-naive CLL, and they compared acalabrutinib or acalabrutinib obinutuzumab, the anti-CD20 antibody, versus obinutuzumab chlorambucil. And you can see here that both arms containing acalabrutinib showed superiority versus obinutuzumab chlorambucil versus chemoimmunotherapy. And this, in a way, was certainly expected. This is PFS. And importantly, you can see that in high-risk patients, including patients with del17p and or mutated p53, the combination of acalabrutinib and obinutuzumab or acalabrutinib single agent are ineffective, as we already said for ibrutinib. The cardiac adverse events incidence was low in acalabrutinib-containing arms, but I will provide you with a bit more data very soon. Now, BTK inhibitors as a class of drug have an increased risk of bleeding, but something that for major bleeding is really rare. This increased risk of bleeding is related to the role of BTK and TEC kinases in platelet activation downstream of the collagen receptor glycoprotein. And obviously, the different TKIs that I talked about have a different kinase profiling in that may also have a difference in bleeding. Another important concept that we should keep in mind is the risk of atrial fibrillation. One suggestion that I would give all of you once you are planning to give a BTK inhibitor to your patient is to have an evaluation by a cardiohematologist or cardio-oncologist. So not any cardiologist that is in your hospital, but somebody who is in a way specialized in the management of these drugs. In our center for many years now, we have opened a cardiohematology center where the cardiologists come to our department and together with us will evaluate all patients, not only for BTK inhibitors, but also for other drugs, novel targeted agents that are used in hematology and that may have cardiac relevance. How should we manage BTKI-associated atrial fibrillation? Well, first of all, you should manage it together with the cardiologist. The DOAC are preferred over vitamin K antagonist due to the superiority of efficacy and safety, and also more experience with anti-factor 10 DOACs in cancer patients. We tend to use apixaban in our center because it has a bit less interaction with glycoprotein P. And then again, the rate control with beta blockers is preferred because of the multiple interactions between BTK inhibitors and other anti-arrhythmic agents. But as I said, this is something that we, as hematologists, we do in close collaboration with the cardiologist in the cardiohematology clinic. And so the cardiology will take over at that point. In elderly patients, obviously, we should not forget that the CLL11 trial has shown the value of obinutuzumab chlorambucil over rituximab chlorambucil, even though I have to tell you that in our center, and I would say in general in Italy, we're not using chemoimmunotherapy any longer for CLL, either for the young or for the elderly. Is chlorambucil plus an anti-CD20 still a valid option? And this question has been addressed by the Illuminate trial that compared ibrutinib obinutuzumab versus chlorambucil obinutuzumab in first line. And you see the superiority, the red curve of ibrutinib plus obinutuzumab versus chlorambucil plus obinutuzumab. And this is particularly true in patients with high-risk features. The Alliance trial on the same line compared bendamustine rituximab versus ibrutinib or ibrutinib rituximab, and I will show you the results in a moment. And again, you can see that ibrutinib plus or minus rituximab is superior versus bendamustine rituximab. And this is particularly true for patients with IGHV unmutated genes that, as I said, are the patients at higher risk. The Elevate TN trial compared acalabrutinib obinutuzumab or acalabrutinib monotherapy versus obinutuzumab chlorambucil. I already showed you the results. Acalabrutinib plus minus obinutuzumab improves PFS compared to chemoimmunotherapy, obinutuzumab chlorambucil. and it has certainly an impact in patients with mutated p53, and you can see it here, the value of acalabrutinib containing arms, and also for unmutated immunoglobulin genes. So acalabrutinib containing arms significantly improves PFS in IGHV unmutated and in p53 disrupted patients. The prevalence of atrial fibrillation and hypertension were low, and they did not differ among the three arms, and you can see it here in this slide. I told you before that another important pathway in the context of CLL pathogenesis is represented by the BCL2 pathway, and that is the rationale for targeting CLL with venetoclax-based regimens. The CLL14 trial of the German CLL study group compared venetoclax obinutuzumab fixed duration for 12 cycles versus chlorambucil obinutuzumab. And you probably already know the results, the superiority of obinutuzumab venetoclax versus chemoimmunotherapy. However, and this is an important concept in view of precision medicine, venetoclax obinutuzumab mitigates, but does not completely overcome the negative prognostic impact of p53 abnormalities and of unmutated immunoglobulin genes. And this is rather clear here because patients with unmutated immunoglobulin genes do not perform as well as patients with mutated immunoglobulin genes. And same thing you can see here, patients treated with venetoclax obinutuzumab and with p53 abnormality, they have an inferior outcome compared to patients treated with venetoclax obinutuzumab, but with a normal p53 gene. The general idea is that this is due to the fixed duration, 12 months, and that p53 disrupted patients, in fact, require long-term treatment with BTK inhibitors. And this is an important concept. Obviously, you may also think of combining ibrutinib plus venetoclax. And the phase 3 GLOW study addressed this question, comparing ibrutinib plus venetoclax for fixed duration, 12 cycles, versus chlorambucil obinutuzumab. And you can see clearly here, this obviously was a randomized study, you can see clearly the superiority in terms of progression-free survival and time to next treatment for patients treated with ibrutinib venetoclax versus patients with chlorambucil obinutuzumab. And you can see here at 30 months, progression-free survival 80.5% for ibrutinib venetoclax versus 35.8% for chlorambucil obinutuzumab. There is a strong biological rationale for combining ibrutinib venetoclax, something I could not mention because we didn't really have time to go into these details. Now, as I said, we now have very clear evidence that BTK inhibitors are able to overcome the prognostic impact of unmutated immunoglobulin genes, and this has been shown by the RESONATE-2 trial, the E1912 trial, ECOG trial that I already discussed with you before, and also in trials that exploited acalabrutinib. So this is very important because unmutated immunoglobulin gene patients will not respond adequately to chemoimmunotherapy. And we also clarified that venetoclax plus anti-CD20, it is able to mitigate, but not to completely overcome the negative prognostic impact of unmutated immunoglobulin genes. So this, again, is something that we should keep in mind in light of precision medicine. And the ESMO guidelines that will be renewed recently, updated, but for patients treatment naive with CLL, they clearly make a distinction. First molecular decisional node is p53 disruption. And you see for these patients, a BTK inhibitor is the very first choice. And I told you that with fixed duration, these patients will not do well. And then for the remaining patients, a decisional node will be the mutation status of immunoglobulin genes. If it is unmutated, no chemoimmunotherapy is strongly recommended unless the pathway inhibitors are not available. And this is why chemoimmuno is still there in the ESMO guidelines, because we are very well aware that in some regions of the world, pathway inhibitors are not yet available for first line. For the IGHV mutated patients, you actually have the choice of the pathway inhibitors, either BTK inhibitors or venetoclax-based regimens or chemoimmunotherapy. Even though, as I told you, the patients, when these drugs are available in first line, would certainly not choose chemoimmunotherapy. The last 5 minutes I would spend on relapsed refractory patients that are obviously still there in CLL, despite the many advances that we have been experiencing during the last few years. Now, one important concept is the timing of the relapse, at least after chemoimmunotherapy. And patients who relapse early, within 2 to 3 years, these are patients that should not be treated again with chemoimmunotherapy because they will not respond. And we now have several evidence from several clinical trials for pathway inhibitors in the context of relapsed refractory. The RESONATE trial, and that was several years ago at this point, it was initially published in the New England Journal of Medicine and then updated, compared ibrutinib versus ofatumumab in relapsed refractory patients. Ofatumumab at that stage was an option for second-line patients, and you clearly see the superiority of ibrutinib versus ofatumumab, especially in the high-risk population with unmutated immunoglobulin genes, p53 disruption, or deletion 11q. And the final analysis from the RESONATE has clarified, and you can see here for IGHV mutation status, that both mutated and unmutated will respond similarly to ibrutinib in this context. So these long-term results confirm the robust efficacy of ibrutinib in relapsed refractory CLL and also small lymphocytic lymphoma, irrespective of high-risk clinical or genomic features. An important concept is when to use BTK inhibitors in relapsed refractory patients. And you can see here that the number of prior lines will make a difference. And the sooner, the better. So in patients who have been treated in the past with chemoimmunotherapy and their first relapse, the indication is to go certainly for pathway inhibitors without reassessing chemoimmunotherapy. And as I said, ibrutinib in this context is active regardless of p53 or IGHV mutation status. And you see here for IGHV mutation status, the two curves are overlapping. Other BTK inhibitors has also been proven to be effective in the relapsed refractory setting. The ASCEND trial has compared acalabrutinib versus rituximab idelalisib, something that we would not do anymore today, and to rituximab benda. And you see there have been strong superiority for acalabrutinib monotherapy in this context. Now, the cumulative incidence of atrial fibrillation has also been compared in the ELEVATE relapsed refractory trial that compared acalabrutinib versus ibrutinib. The two drugs are efficacious if you check in terms of PFS. The rate of atrial fibrillation is somewhat different, and it is lower for acalabrutinib, but I think again, we should keep in mind that this is a class effect. Venetoclax targeting, BCL2 targeting with Venetoclax is also an option in relapsed refractory patients, and we are very well aware of the results of the Murano trial that compared Venetoclax rituximab versus bendamustine rituximab with a fixed duration regimen, 2 years in this context, with a clear superiority of Venetoclax rituximab versus bendamustine rituximab for PFS and also for overall survival that you can see here. So this is certainly an option, even though Venetoclax rituximab does not completely overcome P53 disruption. And this is something that you can see here very well in the curves, patients with deleted or mutated P53, and you see here, do not as well as patients with a wild type P53. This is why at the beginning of my talk, I suggested to test for P53 disruption at each treatment requirement, because this may have treatment implications in the view of precision medicine. What about allogeneic transplant? Well, if I have to think about our center where we are following more than 800 patients with CLL, I do not really recollect an allotransplant during the last 2 years. However, it may still be an option for patients who have failed multiple pathway inhibitors with high risk features. And we know, as of today, that certainly it will not be an option for second-line treatment, because if you fail, let's say, Venetoclax rituximab, then you can go to ibrutinib. But then in the second relapse, it's something that perhaps you should carefully consider if you don't have other options available. Again, the scenario is evolving. We now have the non-covalent BTK inhibitors like pirtobrutinib, for example, that is able to will be efficacious even in ibrutinib or BTK inhibitor resistant patients. So the ESMO guidelines for relapsed CLL, again, an important decisional node will be the P53 status, and BTK inhibitors will be the very first choice, either ibrutinib or acalabrutinib. Venetoclax plus rituximab in P53 disrupted patients will not be the very first choice. And then otherwise, in P53 wild type, you may consider the duration remission. In patients with a short remission duration, then again, pathway inhibitors would be the very first choice. So just to summarize, first-line therapy with biological agents improves outcomes of CLL patients compared to chemoimmunotherapy, irrespective of age and comorbidities, and I showed you both young and elderly patients. Continuous therapy with BTK inhibitors overcomes the adverse prognostic impact of disrupted P53 and of unmutated immunoglobulin genes, and are associated with different incidents to specific adverse events. That is a class event. BCL2 inhibitors, both in treatment-naive and in relapsed refractory CLL, mitigate but do not completely overcome the negative prognostic impact of P53 abnormalities and of unmutated immunoglobulin genes. We tend to reserve the fixed duration with BCL2 inhibitors and anti-CD22 mutated patients. The combination of Venetoclax and ibrutinib induces high rate of complete responses in both phase 2 and phase 3 clinical trials. The cardiovascular events caused by BTK inhibitors are manageable and rarely lead to therapy discontinuation. We have many new potential targets for CLL. Obviously, we have also the bispecific antibodies that may have a role. CAR T cells are still a bit lagging behind. We have the non-covalent BTK inhibitors, as I said, new targets. You can see here XPO1 that I mentioned at the very beginning of my talk may also be a new target in this case. And with this, I would stop sharing my screen, and I would be certainly open for questions. Thank you very much.
Thank you, Professor Gaidan, for your interesting and comprehensive talk. And the floor is open for 1 or 2 questions.
Ahmed,
Yes.
Ahmed Salam بيحكي.
Yes, Dr. Hamad Salam, please.
Thank you very much for such excellent presentation. I have 2 questions to you. The first question is, if you have the chance to use venetoclax-based versus ibrutinib-based therapy for treatment of CLL, which one you will choose, since we know that the duration of the venetoclax-based therapy will be only lasted for 2 years and the others will last it forever? And my second question, I know that doing MRD for those patients is invisible. Did you ever do those as a trials where you find whether the patient still have low MRD or still he has no MRD at all?
Okay, thanks. Shukran Jazila. Both questions are very important, and I will start from the first one. So if we have the option of both BCL2 inhibitors and BTK inhibitors, which one should I choose? So my choice will be guided, because this is also what the evidence says, obviously, and the guidance is saying, it would be guided by the molecular predictors. So if the patient has p53 disruption, I would choose a BTK inhibitor, long-term treatment, because I showed you that BCL2 fixed duration regimens will not be effective or will not be as effective in the context of p53 disruption. If I have IGHV unmutated patients, I would certainly discuss it with the patient, but my preference as a clinician, again, would be BTK inhibition, long-term BTK inhibition, because we know, as I showed you, that fixed duration with BCL2 and inhibitor and an anti-CD20 mitigates but does not really overcome the value of unmutated immunoglobulin genes. Instead, for patients with mutated immunoglobulin genes, I would certainly consider fixed duration as first option. I would discuss it with the patient, and this would be my preferred context for this, this fixed duration regimen. Things may change with the I+V combination that is already available in several areas of the world, and this is something important to consider. Your second question instead concerns MRD. With BTK inhibitors as single agents, MRD has no clinical value, obviously, but instead it might be relevant with the BCL2 and an anti-CD20, and also with I+V. However, as of today, minimal residual disease assessment is not indicated by guidelines. So I would, in the clinical practice, I would stick to guidelines and I would not test MRD, because then I would not take a clinical decision based on that. Instead, in clinical trials, certainly yes, and MRD at that point may guide decisions like, for example, in the Captivate trials. But in the clinical practice, the recommendation is not to test MRD. I don't know, I hope I've been answering your questions.
The only thing which I said that if the patient I have one patient who is on ibrutinib for the last 7 years, and she financially, she cannot offer it. She start to reduce the dose. Instead of taking 3 tablets, she started to take 2 tablets. So if you have an MRD for those, I know that this is not a practice. This is only in research things. And I'm sure that once you have more than 700 patients with CLL, you will have, I'm sure that you are studying it in your lab. So
yeah.
what are the percentage?
So yes, we do have patients.
If you're having MRD log of 4 or 5.
Yeah. So it's true that we do have patients who have a reduced ibrutinib because of toxicities or side effects. So that's two. But we are not measuring MRD outside of clinical trials.
Thank you, Dr. Gaidano. Thank you, everybody. We can move to the second, to the next session, please. Thank you.
Thank you very much.
حضرتك يعني خلاص نجهز؟ لا تفرق. لا والله يا دكتور اهلا وسهلا فيك. شكرا. لا
Okay, Assalamu alaikum. It's my pleasure to introduce our next speaker, Professor Mustafa Jantir. And on this occasion, I would like to express our deep condolences for our brothers and sisters who died in the earthquake. Professor Mustafa, he finished his medical school from Ankara University, and he did his internal medicine residency at Jordanian Technical University and his hematology fellowship from Marmara University. Currently, he's the director of the hematology department at Ajibadim Maslak Hospital, and he worked in different hospitals like the American Hospital Department, Marmara University, and other places. He ran hematology and immunology lab at Jordanian Technical University, and he has leadership and professional experience, like he's official doctor and member of the United Nations, and he's founder and vice president of the Cancer Survivor Association, the chairman of the subcommittee of the bone marrow failure in Turkey, multiple myeloma, lymphoma. And he did the PMT fellowship in Chicago. He is member in Turkish Association, American Society of Hematology, European Society of Hematology, and European PMT. And he has more than 34 manuscripts in peer-reviewed journal, many abstracts, and he's author of book chapters. Professor Mustafa will be talking to us about update in the diagnosis and treatment of aplastic anemia. So welcome to Professor Mustafa.
Thank you so much. I'm very happy to be with you. But honestly, nowadays we are going through very difficult days. Even in my country, I mean Turkey and Syria. Turkey is experiencing the worst disaster in its history, and unfortunately not taking adequate precautions beforehand and delay in reaching the earthquake area and disorganization increase our losses. Of course, for me, it's too difficult to talk in such a difficult time. I respectfully commemorate those who lost their lives in Turkey and Syria. May their place be heaven, and I wish patience to all survivors, all the people living in Turkey and Syria. Today, I will talk about the treatment of aplastic anemia mainly. In fact, there is nothing new in the treatment of aplastic anemia, but I will especially focus on the practical treatment and give some practical information for the clinicians. As we all know that acquired aplastic anemia is an immune-mediated hematopoietic disorders, and it's characterized by pancytopenia and hypocellular bone marrow. It's as I said before, acquired stem cell disease, and more than half of the patients are idiopathic, immune, but we don't know the really etiological factors, and it is diagnosed by exclusion the other etiological factors. And the frequency in the world, in Western countries, 2 per million, and in Asia, 4 to 6 per million. And the disease has two peaks, one of them in young age and the other is in elderly. The characterization of the bone marrow is so typical by hypocellularity, no blast increase, and we don't find any dysplasia or fibrosis. And the number of the stem cell, CD34 cell, is less than 3 per 1,000. And we also observe decrease the number of the white cell, red cell, platelet precursors, and normal lymphocytes. Most of the patients has normal chromosomes, but sometimes find some abnormalities that we discuss later. The diagnosis is not so complicated, but the treatment of the disease is a little bit difficult. We should evaluate all our patients and exclude the other causes before starting the treatment. For example, we need to focus on inherited bone marrow failure syndrome, especially the patients who are less than 40 years of age are maybe related with inherited bone marrow failure syndrome. And the prior cytopenias, some somatic findings, genetical analysis. We can also check the myeloid malignancies. And another critical disease, and we should differentiate from aplastic anemia, is hypoplastic myelodysplastic syndrome. Is a kind of autoimmune disease at the same time. And we need to evaluate the other reasons, such as some drugs, drug reactions, some toxic chemicals, some infections, some immune system disorders. And we categorize all patients before starting the treatment as severe, very severe, and moderate aplastic anemia. The definition of severe aplastic anemia is characterized by at least two of the following characteristics. The first one is the absolute reticulocyte count, which should be less than 60,000, and the platelet count, which should be 20,000, and the absolute neutrophil count, which is less than 500. And if the absolute neutrophil count is less than 200, then we categorize the patient as very severe aplastic anemia. And the other category is moderate one. These patients are not fulfilling the criteria for severe and very severe aplastic anemia. Today, we use four therapeutic approach for the aplastic anemia. The first one is supportive care, especially the frail patient or elderly patient, and sometimes the moderate aplastic anemia. The backbone of the treatment, especially higher than 40 years of age, are immunosuppression. We use triple immunosuppressive treatment nowadays. I will discuss later. And L-Thrombopac is another treatment option. Sometimes even by alone, we can use that treatment options for the patients. And the most curative and radical treatment is allogeneic stem cell transplantation if the patient is available for the transplantation. As you see here, it's a very brief summary of the aplastic anemia. You see if the patients are not frail, then And if the age is less than 40, then the best way is doing allogeneic transplantation. The other critical point before starting treatment is the ECOG performance of the patients, I mean the medical fitness of the patients. We should categorize also these patients as medically fit, unfit, and frail. For the frail patients, we use mostly supportive care, L-Thrombopag by alone, or maybe combination with cyclosporine. And we also need to evaluate the chance of the transplantation. I mean, try to find the donors match related or maybe related, maybe much unrelated, and some other options. We should evaluate the patients from the fertility and pregnancy point of view. The best approach for the patients in aplastic anemia who are higher than 40 years of age are triple immunosuppressive treatment. And some other experts sometimes advise 50 years instead of 40. And we also use anti-thymocyte globulin. It should be horse type ATG because it is more effective than the rabbit one, plus cyclosporine and plus L-Thrombopag. The response rate is about 70%, maybe higher according to some other studies. And when compared with the double immunosuppressive treatment, the studies shows us clearly that the outcome and the toxicity, the outcome is better in triple immunosuppressive treatment and the toxicity is not changed. So we prefer to use triple treatment instead of double one. Allogeneic hematopoietic stem cell transplantation in a very rare case should be an option, but don't forget that the allogeneic hematopoietic stem cell in older patients is associated with excessive morbidity and transplant-related mortality, especially the GVHD, sometimes graft failure, infection, bleeding, and organ dysfunction. These are very critical. So we really need to check it all before deciding to send the patient to the allogeneic transplantation. And the long-term survival is approximately 50% in older patients, which is worse than the triple immunosuppressive treatment. As I said before, that the response rate of the triple immunosuppressive treatment is 2 to 3 patients, and long-term survival is about 3 to 4 of all adults patients. Some of the patients, I mean, the failure of the treatment is associated with the refractory to treatment. I mean, the primary refractory patients or late relapse or clonal progression. But on the other hand, I need to inform you that we don't have upper age limit for the treatment for the triple immunosuppressive treatment if the organ functions are sufficient to tolerate the treatment. So we can use in very elderly patients if the organ function is okay, because we know that the triple immunosuppressive treatment is the best option. Some of the patients after the triple immunosuppressive treatment can be relapse, as I said before, or some of the patients live with the dependence on cyclosporine. And when you try to reduce the dose of the cyclosporine, the disease can come back. Because of that reason, at least 2 years, we need to continue the cyclosporine treatment. Other option, I mean, the intensifying, for example, immunosuppressive treatment with some other drugs have failed, and any study shows that any treatment options other than triple immunosuppressive treatment is not better than this treatment. And near 10 to 15% of all patients will develop myelodysplastic syndrome or PNH within 5 years. As I said before, that we have no age limit, but sometimes if the patients have some cytogenetic abnormalities, you know that cytokines sometimes induce the progression of malignancy in hematopoietic system. So maybe you can avoid to use L-thrombopac, and maybe you prefer double immunosuppressive treatment instead of triple in a patients with some cytogenetic abnormalities. The main problem during the treatment is serum sickness disease, especially within a first to second week, characterized by joint ash, muscle ashes, rash, and fever. Sometimes rigor, sometimes fluid retention, but anaphylaxis is very rare, and we can also treat this disease by using intravenous hydrocortisone. This is the list of the studies with doing by immunosuppressive agent. As you see at the end of the list, which is done in 2012 to 2015, triple treatment seems very, very effective in aplastic anemia. And this article was also published in New England Journal of Medicine this year, clearly demonstrated that the triple approach is the best one. What should we do before starting horse ATG? We, in our clinic, we routinely doing acetaminophen and diphenhydramine before infusion and stop the beta blockers because ATG has an hypotensive effect. We use also prednisone, 1 to 2 milligram per kilogram per day within the first dose of horse ATG, and continue at this dose for at least 10 days and start to rapid the dose of the rapid taper the dose of the prednisone, and discontinue it by the end of the 21 day. The mortality rate is very critical, and it will be more critical, especially in older patients. We generally use infusion within a 12 to 16 hours, just for 4 days. And before using the treatment, we don't need to do a skin test. This is the classical use of ATG, as you see here. And please, for the obese patient, you should calculate the ideal body weight of the patient and give the dose by using the ideal weight of the aplastic anemia patient. This is the protocols. This is the detail of the protocols. 4 days, as you see here, IV methylprednisolone, and try to keep the platelet level up to 20 to 30,000. Chlorpheniramine, as I said before, to reduce the reaction of ATG, and cyclosporin, we continue it, prednisolone, as I said before, and some prophylactic antibiotics. And I would like to give some basic information about the triple immunosuppressive treatment right now. First, early discontinuation leads to high rate of relapse, and the long maintenance, at least maybe a year, maybe 2 years, delays the relapse. And full dose of cyclosporine targeting the therapeutic dose of such as 200 to 300 microgram per liter in first year is very critical, and we should taper the dose of the cyclosporine very carefully and never more than 10% dose reduction at a time over the course of first year. And the outcome, if we will check the outcome of the triple immunosuppressive treatment, you see here 80% of the patient has overall response rate for about 6 months, and 68% for 6 months, and 32% for complete remission. According to the single institution and the multicenter studies, the range is different, but these are the most long-term duration of the therapy in aplastic anemia. And the resolution of the severe neutropenia and transfusion independence takes 1 to 2 months, and triple immunosuppressive treatment achieve superior response with equivalent toxicity, as I said before. And this is the cumulative incidence of PNH, which is 1% at the end of the second year. And the cumulative incidence of relapse at 1.5 years is about 19%. We can also observe some somatic mutations in patients at baseline, which is about 30%. And during the treatment, it can be increased up to 55% at the end of the 6 months. Some of the studies doing with additional treatments such as mycophenolate mofetil or sirolimus or some other did not improve the response parameters, and still, as I said before several times, that the triple immunosuppressive treatment is the gold standard. Alemtuzumab will be another option, but we don't use alemtuzumab in our daily practice. We've totally honestly forgot this drug. And some of the studies were done before using alemtuzumab, but the response rate is not so high. And the cyclosporine is too critical. The duration of the use of cyclosporine is critical, at least 1 year, maybe 2 years, as you see here, that the relapse rate can be decreased by the duration of the long duration of the cyclosporine. And another critical point, please start your L-thrombopac on day 1 and please continue at least 6 months. When you continue L-thrombopac from the beginning to at the end of the 6 months and use cyclosporine at least 1 year, maybe 2 years, and use ATG, the overall response rate was very, very high. As you see here, this is the data of EBMT. As you see here, first-line immunosuppressive treatment response, which is about 80% and decreased by the age. And we have some prognostic factors regarding triple immunosuppressive treatment. The first one is the age of the patients. Young patients' response is better than the old one. If the patient's absolute reticulocyte count is higher than 25, is another good prognostic criteria. Absolute lymphocyte count is higher than 1,000 per cubic millimeter, which is another good prognostic factors. Some abnormalities, including trisomy 8 or deletion 13q, and the presence of the PNH clone. These are the prognostic factors. What is the risk of the immunosuppressive treatment for the long follow-up? The first one is delaying the bone marrow recovery. It takes maybe 6 months sometimes. And please wait for the response and don't be panic. Risk of the relapse is about 25 to 40% at 5 years. Primary refractoriness is another critical issue. The percentage is about 10 to 20. The risk of the clonal progression to PNH and risk of the clonal progression to MDS and AML is not so low, as you see here, about 25% for long-term follow-up. So these are the risk factors. And another option, of course, hematopoietic bone marrow, hematopoietic stem cell transplantation, even the patients who are younger than 40 years of age. In this group of patients, first, we need to check match-related donors and directly, and we know that the allogeneic hematopoietic stem cell transplantation in young patient is better than immunosuppressive treatment. In patients who has hematopoietic stem cell transplantation improve more faster than triple immunosuppressive treatment, and it is rapidly normalized. And also we can avoid the possible clonal progression or disease relapse by using hematopoietic stem cell transplantation. The relapse of the disease is very, very low. And if the patient has no donors and it is not easy to find it within 2 months, then you can start immunosuppressive treatment and don't wait for finding a donor more than 2 months. Age and, as I said before, medical fitness are important. Outcome and adverse event with allogeneic hematopoietic stem cell transplantation are increased by the age, as you supposed. And long-term survival after hematopoietic stem cell is about 50%, which is low in older patients. So because of that reason, we prefer triple immunosuppressive treatment. But honestly, in literature, we don't have randomized studies which is directly compared with immunosuppressive treatment versus hematopoietic stem cell transplantation. My advice, if you have a very expert center in the area of hematopoietic stem cell transplantation, maybe you can be relaxed when you choose the patients. Maybe it is not the rule of the God, you know. You can choose your patients even in elder patients if the medical situation is available for the transplantation. This is also an EBMT results. As you see here, the result is very high. Even in unrelated donor transplant, the result is very good and similar. And another critical point is, what should we do for less fit or frail patients? First of all, if the patient has severe or very severe aplastic anemia and non-candidates for a triple immunosuppressive treatment or hematopoietic stem cell transplantation, what should we do? Try to relieving these symptoms first and try to improving the quality of life and try to limit the treatment-related adverse events and avoid yourself to use aggressive treatment in that group of patients. Maybe you can use cyclosporine by alone. Maybe you can use L-Thrombopac by alone. There are some results. There are some studies shows us that the L-Thrombopac by alone can improve the survival in frail patient. You can combine with cyclosporine and L-Thrombopac, and sometimes the only option can be supportive care such as transfusion. Moderate aplastic anemia is the third group. You remember the classification. It's a very heterogeneous group, and the patients range from ongoing transfusion needs and or severe cytopenias to those with persistent mild cytopenias and that do not require transfusion. Substantially increase the risk of the serious infections, sometimes bleeding, depends on the clinical situation. You can select your treatment. Sometimes patients only need to follow and wait. Sometimes the spontaneous remission can occur in some of the aplastic anemia patients. And sometimes the cause of the pancytopenia is maybe viral infection, some medication. Before starting the treatment, waiting for a while is a good option, I think. No need to be in a hurry to start immunosuppressive treatment. Blood transfusion is important. This is the most critical indication for starting the treatment, because you know that if the patient's needs for red blood cells transfusion is increased, then you don't have any option other than using immunosuppressive treatment. Over iron load sometimes can be a problem, and most of the authors advise us that begin immunosuppressive treatment for moderate aplastic anemia after transfusion of 6 to 10 units of erythrocyte. Maybe you can obey this rule and start immunosuppressive treatment at the end of the 10 unit of transfusion. Please try to keep your platelet count over 10,000 and try to keep the hemoglobin 7 to 8 gram per deciliter. And please try to limit the transfusion, especially in fit patient and transplant eligible patient. And please avoid blood transfusion from sibling or family donor because of the risk for the transplantation. And if the patient has a fever or higher, please increase your cutoff up to 20,000 for thrombocyte. And as I said before, that routine transfusions are not recommended for stable aplastic anemia. And if you use anti-thymocyte globulin, please, the platelets cutoff should be upper than 20,000. And please doing some antibiotics prophylaxis, especially for pneumocystitis carini. In the literature, pentamidine recommend rather than bacterem, but we also routinely use bacterem instead of pentamidine. But don't forget that sometimes bacterem can suppress the bone marrow recovery and sometimes may increase the level of L-Thrombopac. Fungal prophylaxis can be needed, is needed with voriconazole and posaconazole, especially the patients who are their absolute neutrophil count is less than 200. But we really do not know the real efficacy of using fungal prophylaxis. We can also use, we use also viral prophylaxis with valacyclovir 500 to 1,000 milligram per day, at least 1 month after ATG treatment. But we should be careful because of the nephrotoxicity. We don't use bacterial antibiotic prophylaxis. We use usually antiseptic mouthwash, including chlorhexidine or saline. The vaccination is another debatable issue in aplastic anemia patient. Most of the authors do not recommend to use standard vaccination, and they recommend to avoid vaccination within the first year of the beginning of immunosuppressive treatment, especially if the patients are still on cyclosporin treatment. And the cytokine use is also a very critical issue. We don't use, most of the authors in the world and the center do not use routinely administration of G-CSF and erythropoietin because there is no critical data which shows us that there is a differences between with cytokines and without cytokines group. And also we maybe provocate the clonal disorders such as MDS or AML by using G-CSF and EPO. Even L-thrombopac, some of the authors believe that, especially with the abnormal chromosomal abnormalities, some patients may be triggered by using L-thrombopac from the malignancy point of view. And response assessment, the monitoring of response is another issue. We use some definition such as hematological response, which means independence from transfusions, improvement of cytopenia that they no longer meet the criteria for severe aplastic anemia, and response occur within 3 months to 1 year. The complete response means totally transfusion independence. Hemoglobin level is higher than 10 grams per deciliter. Platelet count is higher than 50 or 100,000. Excellent response defined by the increase of platelet upper than 1,500, 150, higher than 150. What about the partial response? It is defined by clear improvement in blood counts and or transfusion requirement, and did not reach threshold that defined complete hematological response. Refractory disease and relapse disease, as you suppose that refractory disease means lack of the significant improvement in blood count and transfusion requirement, relapse and decline in blood count after achieving a hematological response. And if the patients are refractory to triple immunosuppressive treatment, it is a very critical clinical situation. The best way is recommend them clinical trials if possible, or choose the other options, including hematopoietic stem cell transplantation by the help of the degree of the cytopenias, understanding the medical fitness and availability of the donors. If the patients are eligible for hematopoietic stem cell transplantation, you can increase the age of the patients up to 65 years of age because you don't have any option. So allogeneic transplantation is the good option. If the patients who do not have suitable donors, try to search and match unrelated matched donors, maybe haploidentical donors, the parents or child. Maybe you can use umbilical cord blood donor, unrelated donor. And some of the data shows that near maybe L-thrombopac monotherapy sometimes will be helpful for the thrombocytopenia. This is another option, but we should be realistic. If the triple treatment, immunosuppressive treatment has no response, don't waste your time by using L-thrombopac by alone. A patient previously treated with horse ATG, you should change your ATG to rabbit, and please do not treat again by again using horse ATG because of the high risk of the serum sickness disease. You should be careful. Romiplostim sometimes effective, but we don't have romiplostim in Turkey, so we don't have any experience with romiplostim. Alemtuzumab as a single agent or combination with cyclosporine A is another option, but we don't have any experience. High-dose cyclophosphamide is another option, but don't forget that it will be a very toxic. And relapse is another problem. Sometimes the patient can relapse, and the triple immunosuppressive treatment does not prevent relapses in aplastic anemia patient. The percentage is about 40% at the end of the 4 years. And please assess your patients to progress to MDS or acute myeloid leukemia. One of the approach is reinstitute the dose of the cyclosporine. If the relapse can occur during the cyclosporine treatment, you can increase the dose of cyclosporine and see what happened. Most of the cases, the cytopenia, the decline of the cytopenia is stopped and improved the cytopenia by the increase of cyclosporine within 2 months. You can, as I said before, for the relapse patient, maybe hematopoietic stem cell transplantation. I'm very close to hematopoietic stem cell transplantation for the relapse and refractory patient if possible. Maybe some patients also respond to second course of the triple treatment. It will be another option. What will we do for the elderly patient? Immunosuppressive treatment may be an option, is considered the treatment of choice. As I said before, that we don't have upper age for triple treatment. Maybe you can use double treatment according to the situation of the patient. ATG and cyclosporine result in more rapid recovery of blood counts. Sometimes you can use cyclosporine by alone, or oxymetholone may be considered, depend on the clinical situation of the patient. SOURCE study is one of the options. Cyclosporine and L-thrombopac is a good option for not for the elderly patient, but the other patient who are very frail and has no chance to use triple immunosuppressive treatment or hematopoietic stem cell transplantation. And pregnancy is another critical issue. Supportive care is the backbone of the treatment during the pregnancy. Try to keep the platelet counts up to 20,000. You can use cyclosporine, which is safe in pregnancy if needed. And pregnancy and good obstetrical outcome are possible for that woman who treated with immunosuppressive treatment by using cyclosporine. PNH is another problem, not a problem, but we can observe together. You should check by flow cytometry at the diagnosis. And if positive, then continue to test every 3 months for 2 years. And you can reduce the controls frequency if the patient's stable. A small clone detected half of the patients and does not change the management. But don't forget that the large clones can cause hemolysis and also thrombosis in that patients. Clonal evolution we can observe, and some of the patients progress into the myelodysplastic syndrome. But don't forget that the presence of even a subclinical PNH clone has been found to correlate with improved response to immunosuppressive treatment. And in the COVID era, what should we do for that patients? We don't have any consequences of infection in aplastic anemia. We are not so clear. And we know that the patient receiving immunosuppressive treatment are considered high risk for COVID-19. So we can also, most of the authors recommend to use COVID vaccines in patients with aplastic anemia, especially especially carrying the other risk together, such as elderly age or obesity. This is my summary, as you see here. If you can find the pancytopenia, doing a bone marrow biopsy and exclude MDS and the other reason, you can take the aspirate and do cytogenetics and check the peripheral blood. If the patient diagnosed acquired aplastic anemia, doing a HeLa typing and choose the treatment according to the patient's situation. And as you see here, if the patient has less than 40 years, sibling bone marrow transplantation is the best option. If the patient has no options, then you can start triple immunosuppressive treatment. And if relapse or refractory, then switch to bone marrow transplantation by using unrelated donors or haploidentical donors. If the patients are less than 20, do bone marrow transplantation. If the patient has no chance, then you can use triple or double treatment and send them to transplantation if necessary. This is my last slide. And my last verse, please pray for Turkey and Syria nowadays. Thank you for your attention.
Thank you, dear doctor, for your excellent, informative talk. We do appreciate your presence with us, knowing what you are facing in your country from the rough situation now. Thank you so much. We do appreciate that. I believe we have time for one question maybe. So we will see who has a question. Yeah. Okay.
Thank you, Mr. Chairman, and thank you, Professor Mustafa, for your presentation. I have a question, just practical. For those patients who are getting immunosuppressive therapy, ATG-based therapy, how you would recommend following or screening for viruses, especially the ABV and CMV?
Excuse me, I cannot hear you. Would you please say it again? I have some problem with the voice.
ما بسمعني. Yeah, thank you, Chairman, and thank you, Professor Mustafa, for your nice presentation. I have a practical question. I think to my knowledge, there is no specific guidelines following viruses during or after immunosuppressive therapy. Is there any guidelines you're aware of, or you're suggesting some of the guidelines how to follow viruses after immunosuppressive therapy? in particular CMV and ABV? Thank you very much.
Yes, there is no consensus, as you said, for using the prophylaxis even in CMV and EBV. Maybe we can, for example, in Turkey, near 90% of all Turkish people has the history of CMV, you know, and it is a big risk for reactivation. Maybe we decided to use, but you know that these drugs is not so easy to use, and the patient has very frustrated sometimes. In our clinical practice, we don't use any prophylaxis against EBV and CMV, but maybe some other centers. I really would like to know what about you in your center. By the way, how are you? I hope that you are okay. I recognize you. And we don't really forget our excellent Jordan travel, you know. We met face to face at that time.
Thank you, dear doctor. We have a question from Dr. Mustafa, I believe. Go ahead, doctor.
What is the effect of Ribonate starts?
What is the effect of?
When the effect of Ribonate starts?
He wrote it?
Yes.
Okay. When the effect of the Revolate starts.
Revolate?
Start, yeah. This is the last question, yeah. Did you hear me, doctor?
Time of start.
The effect of which drug?
What time when the thrombobag, you'll see the effect of the thrombobag after you start the treatment?
Yes, you know that a study published in New England Journal of Medicine nowadays, a very, very new one, and they documented that adding L-thrombopag to the treatment may be helpful and increase the response rate. So our aim to add L-thrombopag to cyclosporine and ATG, if I understand the question. I don't know if it is the answer or not. I don't know. Am I?
Okay, thank you very much. We have to stop here. Thank you again, and have a nice day. Thank you.
Nice day. Bye bye.
Okay, good afternoon, everybody. We're running a little bit late, not too much late, but a little bit behind time. Recently, Jordanian Society of Hematology, JSH, has made contact and approach to the EHA in order to find ways and means of collaborating in these fields. And it has been established that the Amman Center will be a center designated by the EHA for the EHA exam, which will be in June of this year. We have already 16 candidates who have committed themselves to the exam. We hope in the future there will be more candidates and there will be more collaboration. And in this regard, we are being the next neighbor to Europe. We feel that we need to have more collaboration and cooperation in many aspects, especially the clinical trials, especially the exchange of scientists and technical people. It's Elizabeth McIntyre, who is the chairman who is the president of the EHA, and Professor McIntyre was trained in internal medicine in Newcastle, UK, back in 1975, and then she was trained in hematology at the University College in London. And then she moved to a different language, maybe slightly different people. So she did her PhD in Paris. She seems to have liked it there, so she continued after going to Harvard, back again to France, where she headed the diagnostic hematology at Necker Infant Malade Hospital from 1999 to 2018. And she co-chaired the INSERIM, as well as the team in Necker Infant Malade Research Institute. And her research interests are mainly in the immature T-cell leukemia lymphoma and molecular diagnostic in lymphoid malignancy. She is also, in addition to being the president of the EHA, she is the president-elect of the Biomedical Alliance in Europe and is a coordinator of research and innovation, part of the Circle U European University Alliance. Professor McIntyre has prepared a short video which will be shown soon. Please welcome Professor Elizabeth McIntyre and the
Hello, I'm delighted to be with you today online for your national meeting in Jordan. I'm Elizabeth McIntyre, I'm currently president of the European Hematology Association, and I'm extremely happy to join you today following our initial contact from the European Hematology EHA exam, which you're considering joining. And it's led to a further discussions which led to my being with you in beginning of what I hope a joint session between your society and ours. So I'd just like to very briefly mention some of our activities. Now, most of you probably know us for our Congress, and we hope that some of you will be able to join us either in person or online in Frankfurt in June of 2023, where there will be over 15,000 hematologists from various different community members and their Congress. Now, in addition to organising the Congress, we do many other things. In fact, we're a membership of clinicians, diagnosticians and researchers with interest in both benign and malignant hematology in Europe and beyond, who work to promote excellence in patient care, education, research and advocacy. And I'd just like to very briefly mention one or two examples of each category within what we do to connect hematologists, to support career development and research, to develop and harmonise education, and to advocate for hematologists and hematology. Now, as I
Sorry, we can't hear anything.
Tired, and I will leave the floor now to Dr. Rami and Dr. Arafat for to present the next session. Please, Dr. Riyad, Dr. Rami.
Assalamu alaikum. Good morning, everybody. Do you hear me?
Yes.
Oh, yes, we do. Yes, please.
Okay. How are you, everybody? It's my pleasure to present Dr. George Lenz in the lymphoma session. Dr. Lenz is the professor of internal medicine at University Hospital of Münster in Germany. He also served the president of German Lymphoma Alliance, and he speaker of high-grade lymphoma working group in Germany Lymphoma Alliance and the scientific director since 2020 of lymphoma. He had multiple research and received multiple awards in the cancer research, and he's gonna talk today about double hit lymphoma. So welcome, Dr. Lenz.
Thank you very much. Can you hear me?
Yes.
Perfect. Thank you. So first of all, I would like to thank everybody for the invitation, and I just want to share my screen. Can you see my slides?
Yes.
Thank you. So again, thank you very much for having me. It's an absolute pleasure. I greatly enjoyed the previous talks, except the last one, which I couldn't hear, but otherwise they were fantastic talks, and it's really an honor to be here. I think I have a difficult task today, talking about so-called double hit lymphomas. Before I start, in the next 25, 30 minutes or so, just to also leave some room for discussion, I will introduce double hit lymphomas to you, and I hope that I could convince you that this is a very heterogeneous group of lymphomas and not really well defined. Because I think that's very important when we talk about therapy, and this will be the main part of my talk, because I think no one in the world really knows how to treat these lymphomas. It's really puzzling, and therefore, as I said, I think this is a difficult task, and I'm also looking forward to the discussion. So these are my potential conflicts of interest. Obviously, none of those has any influence on the content of the following presentation. So in general, when we speak about aggressive lymphomas, we speak about diffuse large B-cell lymphoma, de novo DLBCL. And we treat DLBCL, we have treated it for years with a combination of an anti-CD20 antibody rituximab plus CHOP chemotherapy, and this is still in many parts of the world the standard. There has been, or this standard has recently been challenged by the introduction of polatuzumab into R-CHOP without vincristine. So Pola R-CHP is in subgroups potentially better than R-CHOP, at least with respect to progression-free survival. But I would summarize, using an R-CHOP-like standard of care, you can cure roughly 65, maybe 70% of your patients, depending on your prognostic subgroup. However, I want to show you that there are some subgroups that do significantly worse when you treat them with R-CHOP. So, and that's how I want to introduce aggressive lymphomas with the double hit characteristics. So, as I said, I briefly want to introduce these lymphomas to you. So, starting with the term double hit, I think this is really an ill-defined term. So how do we use double hit, this term? So it's defined as an aggressive lymphoma with a MYC and a BCL2 translocation, or less frequently with a BCL6 translocation. In the current WHO classification, the BCL6 translocation have essentially been dropped. So it's really about MYC and BCL2. However, within this mixture of double hit lymphomas, we also count the triple hit lymphomas. However, in many studies, BCL6 hasn't been looked at all. So as I said, it's not well defined. And then again, double hit lymphoma implies different things. However, when we currently say double hit, it's MYC and BCL2. However, you can have a MYC translocation with another partner. However, this is not referred to double hit, even if you have two translocation. And I really don't like the term double hit because it somehow implies that these lymphomas would only have two genetic aberrations, but this is not the case. Next generation sequencing studies have clearly shown that these lymphomas harbor many different abnormalities, so not just the MYC and the BCL2 translocation. So starting how we detected that there are lymphomas harboring MYC and BCL2 translocation. Obviously, for years, we know that Burkitt lymphoma, and I would say all Burkitt lymphomas, are characterized by MYC translocation. However, when we look at aggressive lymphomas, other forms of aggressive lymphomas, roughly 8 to 10% of the DLBCLs also carry a MYC translocation. So the question was, are these DLBCLs with a MYC translocation, are they just Burkitt lymphoma or high-grade lymphomas that have not been detected as Burkitt lymphoma? And the answer is no. If we look at gene expression profiling, we can distinguish certain molecular subtypes. I will talk about that in the later part of the talk, in the introduction. And when we perform gene expression profiling on DLBCL and Burkitt lymphoma, you can easily detect they have completely different gene expression profilings. And when we look at DLBCLs with a MYC translocation, they are very, very different from Burkitt lymphomas with a MYC translocation. So these are indeed aggressive lymphomas and non-Burkitt lymphomas with a MYC translocation. Roughly 15 years ago, Carrie Savage from the Vancouver group did a retrospective analysis, and this was published in Blood. And there she found, with respect to progression-free and also overall survival, that aggressive lymphomas, non-Burkitt aggressive lymphomas with a MYC translocation are characterized by inferior survival if they have a MYC translocation. And interestingly, in this group, the incidence was 8.8%, and these lymphomas were characterized by high proliferation, and these patients having these lymphomas had an increased risk of CNS disease. So this sounded very easy. However, now it gets complicated because 1/4 of these cases didn't just have the MYC translocation, but they also harbored a concurrent 14/18 translocation, which is a BCL2 translocation. Very similar results were subsequently published in the JCO by Behrens and colleague. Again, DLBCLs with a MYC translocation had inferior survival when treated with R-CHOP compared to lymphomas without a MYC translocation. And in this case, 75% of the cases that had a MYC translocation also had a 14/18 translocation, and 26 of the cases had a BCL6 translocation. So it's really, if you look at these data, it's really unclear. Is it only MYC? Do you need a BCL2 translocation? How does BCL6 influence it? So a lot of questions. And this was even more complicated by this study, which clearly showed if you have only a MYC translocation, maybe your survival is inferior, but it's really bad if you harbor a MYC and a BCL2 translocation. And this led to the term of defining double hit lymphomas. And our first thought was oh, if you have a MYC and a BCL2 translocation, your survival is really, really bad. In this study, virtually no patient survives longer than 2 years. So much worse compared to what I've shown you for the normal R-CHOP cohort. Getting it more confusing, it seems to matter how MYC breaks. So looking at progression-free and overall survival, you can see for both only MYC translocated, but also double-hit lymphoma patients, you can see that the breakpoint matters. If you have a non-IG partner, this translocation doesn't influence your prognosis. But if you have an IG partner, your prognosis gets bad. So again, heterogeneity even within double hits. And now to make it even more complicated, David Scott and Inishi, and they published that in JCO, detected that these double-hit lymphoma cases are characterized by unique gene expression profile. However, this signature is also expressed by other lymphomas not harboring these these translocation, and in general, this signature is associated with poor outcome. So it's really, really a difficult scenario. So how do we solve this problem? And I think at least some clarification was done by a very, very nice study by the Lüneburg Consortium and published by Andreas Rosenwald from Würzburg a couple of years ago. They looked at more than 5,000 patient samples. And I think you need these large data sets to really bring light into this. And there were, in the end, they came up with roughly 2,400 samples, and 264 of them had a MYC translocation, and they were closely monitored. So looking at survival of these patients, we see something that we have seen before. Having a MYC rearrangement is bad. Your prognosis is inferior compared if you don't have the translocation. However, the single translocation not as bad as having a double hit or a triple hit, so BCL2 besides MYC or BCL6. And then even solving the problem is really if you look at the translocation partner again. So the normal double hits, if it's non-IG, doesn't seem to be worse when you treat them with R-CHOP. Also, MYC single hit, if you treat them with R-CHOP, it's not that bad. But if you have a double hit with MYC and BCL2, and if you have a MYC IGH partner, then your prognosis is inferior. However, when you look at the curve, and this is a large cohort of patients in the end, prognosis is not as bad as we initially thought, at least. It's definitely worse compared to a normal R-CHOP cohort treated patient cohort, but it's not as bad. It's in the ballpark of roughly 50% overall survival. So not as bad as shown in early retrospective analyses. So just to distinguish double hit now from double expressors, because that's often confused, it's not only about having a translocation, because if you look at MYC, roughly 1/3 of patients also expresses MYC. And this is based not just by translocation, but you can have MYC amplifications, and you can have other means of upregulating MYC. And if you use a generally used cutoff of 40% positive tumor cells or lymphoma cells, roughly 1/3 of patients has a MYC expression, and patients with MYC expression and BCL2 expression, and this has nicely been shown by Johnson and colleagues 10 years ago in JCO, are characterized by poor outcome. However, they are really different from double hit lymphomas because it's not caused by translocation. And in the current WHO classification, I think we felt when we worked on the classification that really double express is probably not a way to go. So I just want to briefly mention that here, but don't want to go into detail. I've shown before that diffuse large B-cell lymphoma is heterogeneous. You can distinguish ABC, GCB, and other forms of subtypes. ABCs, as you know, are characterized by poor outcome, whereas GCBs treated with R-CHOP seem to do better. So how do we combine that now in the new terminology of double-hit lymphomas? Because in the 2016 WHO classification, double-hit kind of was law or shouldn't be used. Now we call them high-grade B-cell lymphoma with MYC and BCL6 and or BCL2 translocation and or BCL6 translocation. So if you put ABC and GCB in that ballpark. So how does that relate? So if you have a BCL2 and a MYC translocation, virtually all cases are GCB. So this is counterintuitive because GCBs are characterized by better outcome. However, this subgroup, at least in part, is characterized by a more adverse outcome. If you have a BCL6 translocation, you're probably more likely to be an ABC subtypes. So this is the situation. As I said, very, very complicated, but I think with the new terminology, focusing predominantly on MYC and BCL2, I think we have a clearer picture. So what about therapy? So overall, if you look at all the R-CHOP cohorts, we would agree, hopefully, that R-CHOP does not do as well compared to other treatment regimens. So the question really is, and this has been tried to address in many retrospective analyses, we are really lacking prospective trials. It's very hard because it's it's only roughly 5 to 6% of all lymphomas, of all aggressive lymphomas. So the question is, are more intensive regimen better than R-CHOP? So a very nice retrospective analysis by the French group was published a couple of years ago in the American Journal of Hematology, and looking at progression-free survival, comparing R-CHOP or R-CHOP-like to more intensive chemotherapeutic regimens. So what were these intensive chemotherapeutic regimens? This was, among others, R-ACVBP. So this is a French regimen that also uses cytarabine, high-dose methotrexate consolidation, so an intensive regimen. Then patients were also treated with dose-adjusted EPOCH. I will talk about that in the later part of the talk and go into more detail. It's essentially CHOP with etoposide, but done on an infusional manner. I'm sure you're all aware of that. And also in these treatment regimens were patients that were consolidated with autologous stem cell transplantation. So looking at the curves, there is a separation. However, it's not statistically significant. And when you look at overall survival, there's clearly no difference. So in this retrospective analysis, no benefit with the important endpoint overall survival for more intensive regimens. So looking at another big analysis, which was performed by Landsberg and colleagues and published in the JCO, they asked the question, do we need to consolidate by autologous stem cell transplantation? And you can see here relapse-free survival on the left-hand side. There is a discrepancy, and it seems to be favorable. This analysis was quite large, 160 patients. However, it's not statistically significant. And when you again look at overall survival, not even a trend anymore. So autologous stem cell transplantation doesn't seem to work. However, they also looked at more intensive regimens, and these are the results. When you compare intensive regimens, and these were again dose-adjusted EPOCH, these were hyper-CVAD and other Burkitt-like protocols. We will go into detail on the next slide. There is a benefit for relapse free survival, and this is statistically significant. This is interesting. However, when we look at overall survival, again, no overall survival difference. However, maybe you could argue the numbers were not high enough to reach significance. So there might be some evidence that more intense regimens are better. When we separate these different intensive regimens, these are, as I said, are hyper-CVAD, dose-adjusted EPOCH again, and R-CODOX M-IVAC, which is a classical Burkitt treatment regimen. You will see they do equally well. So this study suggests, although I have to say patient numbers get small, only 11 patients treated with R-CODOX M-IVAC, doesn't seem to matter with so they all give the same relapse-free survival. And when you look at overall survival, again, no difference to R-CHOP, and also no clear benefit for one or the other. I think we have to be, as I said, very cautious with the results for R-CODOX M-IVAC. Yes, they have a very good overall survival in this analysis, but as I said, based on only 11 patients. So when I summarize these two large retrospective analyses, there is really no clear evidence that more chemotherapy, more intense chemotherapy is really better than R-CHOP. So coming to dose-adjusted EPOCH, because there we have a prospective study. So again, just briefly, for those of you who maybe don't deal with lymphoma patients on a daily basis, it's very similar to R-CHOP, but you add in the etoposide and you apply etoposide, vincristine, doxorubicin on a permanent 4-day infusion, and you apply prednisolone and cyclophosphamide, obviously as a bolus agent, and you apply rituximab in the normal way. Interestingly, dose-adjusted epoch, you adapt the doses of your chemotherapy based on the nadir of the first and the subsequent cycles. So in theory, at least, it seems to be an intelligent treatment regimen. So what data are out there besides the one that I've shown you that support the use of dose-adjusted epoch in patients with a high-grade B-cell lymphoma with a MYC and BCL2 translocation? So the first data set were presented by Kieran Dunleavy at the Lugano meeting, at the ICML meeting in 2011. And they retrospectively looked at roughly 110 patients treated at the National Cancer Institute in Bethesda and analyzed them by FISH, and then correlated the FISH results to clinical outcome. And in this case, they only looked at MYC single hit, and they differentiated MYC translocated and MYC non-translocated cases. And you can see, based on this small analysis, there's no difference if you have a MYC translocation or not. And now we have to think that this is probably also true for the double hit lymphomas. Therefore, this led to a phase 2 study in previously untreated patients with a MYC translocation. And if we look at the characteristics of the patient, and the final study was 53 patients that 45%, so 100%, this was an inclusion criteria, had a MYC translocation, but 45% of those also had a BCL2 translocation. So looking at the results, event-free survival, overall survival looks good, obviously, yes. I think we have to be cautious. It's a small study again, as I said, 53 patients. However, overall survival in the ballpark of 80% is really quite good. And then when we differentiate single and double hit, you can see, obviously, we get really into small patient cohorts. There is no difference if you have a single MYC hit or if you have a double hit constellation. So these results, and it's only 24 and 19, therefore be very cautious with these results. It seems that dose-adjusted epoch does quite well. However, it's really hard to evaluate based on these data. And therefore, we need a meta-analysis, and this was done. And it does not include every data because it was already published in 2015. And I'm looking here at progression-free survival. And this meta-analysis compared 3 different regimens. R-CHOP as kind of standard, dose-intense Burkitt-like protocols, and dose-adjusted epoch-R. And what you can see with respect to progression-free survival is that dose-adjusted epoch-R is better than R-CHOP, kind of confirming some of the previous results. More intense regimens, Burkitt regimens, are not better, at least when you take the stringent criteria of a p-value of 0.005 compared to R-CHOP. However, I'm not showing the data. When you look at overall survival, again, no difference. So clearly, the evidence for using dose-adjusted epoch is not as good as we would like to have it. Nevertheless, I have to say, in many parts of the world, the UK, the US, dose-adjusted epoch is in many sites and many very experienced sites the standard of care. In Germany, we take a little different approach. We adjust our treatment according to the IPI. And if we have a younger patient with a high IPI and double and B-cell lymphomas with MYC and BCL2 translocation, high-grade B-cell lymphomas often travel with an increased IPI. We add in etoposide. However, we don't apply dose-adjusted epoch, but we use CHOEP, which has been shown in other high-risk population as being beneficial compared, at least retrospectively, to R-CHOP. So this is our standard of care that we adopt according to clinical parameters. So what happens if patients relapse? And a lot of patients relapse, obviously. Patients with relapsed refractory high-grade B-cell lymphoma with MYC and BCL2 translocation are characterized by poor outcome. This is, again, a very nice analysis by Landsberg and colleagues, published in British Journal of Hematology. And these patients were treated by different means, predominantly by chemoimmunotherapy. And you can appreciate that these patients are really characterized by adverse survival. So probably chemoimmunotherapy really doesn't work well in the vast majority of patients relapsing. So we clearly need novel therapeutic approaches. Again, it's very hard to to really look into these trials. Some trials incorporate these patients, others, such as, for example, the L-MIND study that investigated tafasitamab and lenalidomide, excluded patients with double and triple hit lymphomas. So in some studies, they're actually excluded. However, so what can we do? What novel therapies could we apply? I think one approach, and this was very nicely shown at the recent ASH meeting, so the recent meeting of the American Society of Hematology, showed the results for CAR T cells. Obviously, the numbers are not that big, but they confirm other analyses. And you look at the left-hand side, when you look at the PFS, and three groups were differentiated: the double expressors, which I only briefly covered, then double hit lymphoma patients and others. And if you look at the PFS, there is no difference. So double hit lymphomas do not seem to have inferior survival when you treat them with an anti-CD19 CAR. So I think this is promising, and that's also what we do in our center. If possible, if patients with a double hit lymphoma relapse, we try to get them into a CAR T cell therapy. Overall survival was also not different in this analysis. But what happens when you relapse after CARs? This is shown on the right-hand side, and it's clear you have a dismal outcome. So the median survival was only 2.7 months. I have to say, in general, when a diffuse large B-cell lymphoma, even without the double hit constellation relapses, overall survival is poor, but it seems to be specifically poor for double hit patients. So clearly what we need, I think, and we heard that the Jordanian Society would like to collaborate with EHA. I strongly can encourage that. I think we have to do international trials in this rare subtype of lymphomas. I think retrospective analyses are helpful, but they really cannot address these critical questions. So we need more data. We need prospective data. We need to test novel approaches. So that I want to conclude. Double hit lymphomas, with respect to their biology, but also with respect to their classification, are still not completely defined and understood. It seems really, I think this is consensus, that patients affected by these double hit lymphomas are characterized by adverse outcome. I think best treatment is really unclear. Many physicians tend to use more intensive regimens. Dose-adjusted EPOCH is frequently used. I'm skeptical that it really can overcome the therapeutic dilemma. We need better therapeutic approaches. Maybe bispecifics can help here. I think CARs, if patients relapse and if you have access to CAR T cells, are a good approach. And these data that have been presented, that have been collected, are promising. But as I said, we need prospective trials in this rare subtypes. With that, I want to conclude, and I'm really looking forward to the discussion. Thank you very much.
Thank you, Professor Hassan, for your excellent and comprehensive presentation. Now, any question? Some question?
Could I ask a question?
Sure.
Thank you, Doctor. Do you usually test for BCL and make for all specimen for DLBL? Or do you consider some clinical features?
Yeah, so that's a very good question. So what we do in Germany, we don't test everyone for MYC and BCL2 and BCL6 because it's not reimbursed. So what we do, we have and that's done by many centers. So we look at Ki67 and we look at MYC expression. If we have high Ki67 and especially if we have MYC expression, we test for MYC translocation. If we detect a MYC translocation, we look for BCL2 and BCL6 translocation. But if at some point it's negative, we stop. So we don't actually, at least in a routine setting, we don't look for every specimen if there is a MYC or BCL2, BCL6 translocation.
And some clinical features like the mediastinal DLBL, do you think it's higher rate of double hit than in other? Or some clinical feature that do you think this is a higher risk of getting double hit?
So when I look at, not really. I think what I said, so these double hit lymphomas tend to have a more aggressive disease. So higher IPI, advanced stage. There, I think if you are interested, you should really look at that. With the mediastinal, which are frequently primary mediastinal B-cell lymphomas, they are not more double hit. One feature that is important when you detect a double hit lymphoma, so a high-grade B-cell lymphoma with MYC and BCL2 translocation, is really that they have an increased risk of CNS disease. Then I would actually do additional testing. I would, if possible, do an MRI and do a lumbar puncture.
Rami? Thank you for such a presentation. My question to you, what do you think about the role of Venetoclax for double hit?
So that's a very good question. So there were some data, the Cavalli study actually looked at that. So they added Venetoclax to R-CHOP. And what they saw is that if you have at least high BCL2 expression, that this worked much better. So as I said, obviously, the double hits have high BCL2, so this might be very interesting to really study Venetoclax in this setting, but I think you really have to do it prospectively. So I think this would be a good candidate to study Venetoclax.
Can I have a question?
Salamat, next question.
Can I have a question?
Sure.
Thank you for this interesting lecture. I work in the field of BMT at cases at King Hussein Cancer Center. We face a lot of such challenges. So for double hit lymphoma relapsing after standard high intensity treatment, and we don't till now we don't have an access to CAR T cells. Do you think allogeneic transplant is an option for these patients?
Yeah, that's a very good question. So absolutely, yes. So in Germany, we have a tradition of also doing a lot of allogeneic transplantation in lymphoma patients. And if you don't have access to CARs, I would absolutely consider an allogeneic transplantation in a suitable patient, which is younger and can tolerate allogeneic transplantation. I would definitely go there. I think if someone relapses, especially early after your frontline treatment, this patient has a very, very poor outcome. So absolutely, if you get the patient into somehow a remission, I would try to do an allogeneic transplantation if suitable.
Thank you.
Question? Okay. Thank you, Professor Lenz, for your participation in our event. Thank you. And now we'll leave.
Is there any role of immunotherapy in that treatment of double hit, do you think?
So, sorry, I didn't get that question. Sorry. Could you repeat, please?
Is there any role of immunotherapy in the management of such lymphoma?
So if you think immunotherapy checkpoint inhibitors, I'm skeptical because they don't work very well overall in DLB, in aggressive lymphomas. If you consider immunotherapies bispecifics or CARs, then I would say absolutely. I think that is something where I really have great hope. I showed you the CAR data, but I also think that bispecifics should be something that are tested frontline for these high-grade B-cell lymphomas, because I think they could really be efficacious in this setting.
Okay, thank you, Professor Lenz.
Thank you very much. It was a pleasure.
Thank you, Dr. Lenz, for the excellent presentation.
Thank you.
مساء الخير. We will continue our session. We will talk about the innovation, the innovative approaches in the management of hemophilia A by Dr. Charles Hay. My colleague will present Dr. Charles Hay.
Assalamu alaikum. It's my pleasure to introduce Dr. Charles. After training in Sheffield and London, Professor Charles Hay spent 7 years as a senior lecturer in hematology at the Royal Liverpool Hospital, specializing in thrombosis and hemostasis. Professor Charles has been director of the Manchester Hemophilia Comprehensive Cancer Care Centre since 1994. Professor Charles is active in research into the management and complications of treatment of bleeding disorders. He was principal investigator of the international randomized immune tolerance study conducted in 28 countries worldwide. Professor Charles is on the editorial board or a reviewer for a number of journals and has published over 160 papers, reviews, and chapters. He has been director of the National Hemophilia Database since 2002, working within the NHS and abroad. He was chair of the UK RCDO between 2005-2011, and he is a regular advisor to the Department of Health. Dr. Charles, the floor is yours.
Hi. Can you hear me and see my slides?
Yes, Doctor.
Okay, fine. Right. Well, I'm going to be talking mainly about the changing approach to prophylaxis in severe hemophilia A. These are my disclosures. As you can see, they're fairly balanced. Right. Now, in the United Kingdom, prophylaxis has been the standard of care since 1996, when we first produced a guideline on prophylaxis. This is administered between 3 times a week and every day. At one point, I had 30% of my patients who were administering prophylaxis every single day. And that is pharmacokinetically quite a cheap way to treat them, actually, and they were all bleed free, because although they treated themselves every day, they used quite small doses. But that approach is not for everyone. You need to have good venous access, and you need to understand the pharmacokinetics and be sold on it. The commonest regime in use was 3 times a week. Since we swapped a lot of the patients to the extended half-life products, many of those were using extended half-life factor 8 every 3rd day or twice a week. Prophylaxis was personalized and optimized, and the aim of the treatment was to render the patients bleed-free. The peaks and the troughs were managed to permit exercise and sport. But despite prophylaxis, some patients still have progressive arthropathy and synovitis, and we regularly saw patients presenting with intercurrent bleeding. And even if we managed to prevent arthropathy in most of the joints, we still had a problem with ankles. This shows you the bleed outcome with standard factor VIII prophylaxis in the UK in 2016. When we had a more recent look, we discovered that things had not really improved. And you can see that if we look at our patients with severe haemophilia, this is data from the National Hemophilia Database, by the way, we found that only 28% of them were bleed-free. 34% had 4 bleeds or fewer, but 20% had more than 5 bleeds and 18% more than 10 bleeds a year. And this is frankly a very poor outcome. I mean, more than 10 bleeds a year, you'd ask yourself, is the patient complying with treatment? We see patients who are managing themselves on demand with better results than that. I would say about 85% of the patients with severe haemophilia treat themselves prophylactically. And the ones who don't are generally the older patients. Many of them have poor veins, never quite got used to the idea of treating themselves to prevent bleeding, and were reluctant to take prophylaxis on board. They're an important group because if you can improve their interface with the treatment, you can persuade more of them to go on to prophylaxis. The severe end of moderate haemophilia also often have a severe bleeding phenotype, and you can see that only 22% of them were bleed-free. These are patients who've got a factor VIII level of 2% or less by and large. So the most popular regime in the UK was still 3 times a week, but this is suboptimal for many patients. Peter Collins showed must be 15 years ago that on a regime of 3 times a week, you spend a significant proportion of the week down at your baseline level. This panel here shows the median annualized bleed rate broken down by age group. The orange bars are on demand, the blue bars are on prophylaxis. You see the same trend with both groups, and that is the older patients bleed more. That's no surprise. These patients have more arthropathy, partly because of the treatment that they've had in the past and partly just because of the passage of time. But even with prophylaxis, you see that prophylaxis doesn't completely correct this trend, and these patients still continue to bleed, albeit at an apparently low level. This slide shows you data taken from Marilyn Manco Johnson's randomized trial of prophylaxis published in the New England Journal of Medicine back in 2007. And this bubble diagram, the size of the bubbles is proportionate to the number of patients involved. And up the side, it shows you the MRI score or joint score. And along the bottom, it shows you the number of treated bleeds. And you can see several things. One is patients with a perfect joint score, some of them are bleeding quite frequently. So there is no correlation here between the frequency of bleeding and the severity of the joint disease. The other thing you see is that there is this group, relatively small group, who are reporting no bleeding at all, but who have progressive arthropathy. And that they're an important group because not only is there a poor correlation with joint score, but there is undiagnosed microbleeding going on that is leading to progressive arthropathy and arthralgia, because the treated bleeds are just the tip of the iceberg. Those are the bleeds that present clinically, but there is a lot more subclinical bleeding going on that the patients and the doctors can't diagnose. You know, the patients may think, oh, my joints are aching a bit today, and they put it down to arthritis, but some of it is probably bleeding. And to eliminate this, you need to render the patients truly bleed-free. And we have certainly seen that as we intensified factor VIII prophylaxis, because we started with a sort of Dutch-style minimal prophylaxis, and over the years became more aggressive, because to render the patients bleed-free, we may require a trough factor VIII levels of more than 5%. And that may be unachievable in some countries. It certainly requires far more aggressive prophylaxis, but when you achieve that, some of the patients turn around and say, well, actually, my joints bleed less. And they bleed less because the synovitis has settled, there is no bleeding going on, no microbleeding. So when they come to me and they say, my joints hurt less, and all you've done is intensify their hemostatic treatment, then I make a retrospective diagnosis of microbleeding. It doesn't happen with every patient, but sometimes it can be quite dramatic. So the limitations of conventional factor VIII prophylaxis is, firstly, the quality of the prophylaxis varies. It varies from centre, it varies between patients, and some patients have relatively low expectations. They may not realise that the objective of prophylaxis is not just to reduce joint bleeding, but to eliminate it completely so that they're bleed-free. And most patients, as you've seen, from the UK data are not bleed-free, and they may suffer progressive arthropathy and pain. The second limitation is that factor VIII has to be given intravenously, and venous access may be poor, particularly in older patients. And the patients may find this burdensome, and some find it difficult. When I sit down with my patients and I talk them through this, many of them will admit that they were reluctant to try prophylaxis because they still struggle to inject themselves intravenously. And for all of these reasons, compliance may be a problem the world over. The last point to point out is that I think patients with haemophilia look after themselves to avoid minor trauma. And this bleed avoidance behaviour may actually limit their quality of life. And that's worth considering. So there's an unmet need. More recently, we have introduced Emicizumab, a factor VIII mimetic bispecific antibody. It replaces the hemostatic function of factor VIII by binding factor IX to factor X. It has a long half-life of greater than 30 days, which is an enormous advantage because you don't get the peaks and troughs that you get with factor VIII. It's unaffected by factor VIII inhibitors or activated protein C. So we use it in inhibitor patients and those with severe hemophilia A. Prophylaxis with Emicizumab is equivalent to having mild to moderate hemophilia A, at least that our clinical observations suggest that. There are differences between factor VIII and Emicizumab in its mode of action. Factor VIII has multiple sites of interaction, whereas Emicizumab has a single site of interaction. Emicizumab has a relatively low affinity for enzyme and substrate and makes no distinction between the zymogen and the enzyme itself. It has only partial cofactor activity in contrast to the full cofactor activity of factor VIII. It has no on-off mechanism, and there is a low level of self-regulation with Emicizumab. Whether these differences are clinically relevant or not is difficult to determine. It's not as effective as full dose factor VIII in correcting coagulation, but it, as I say, converts the patient effectively into having mild haemophilia. This summarizes the medium-term outcome from all the Haven studies of Emicizumab, and shows you what happens after switching to Emicizumab. You get a dramatic reduction. In fact, it depends on age, but I'll show you the UK data in a moment, which mimics what has been seen in the clinical trials. Sorry, there's some sound coming through. This shows you that the immediate effect is to reduce the annualized bleed rate overall to about 1.9 per year, and over the next few months it reduces so that you have something like an 80–90% reduction in annualized bleed rate, and then it stabilizes. So after an initial period during which the joints settle down, it stabilizes at a relatively low level. The percentage of participants with 0 treated bleeds increases over the first year and remains above 80% thereafter. So about 80% of the patients become completely bleed-free, which is a considerable increase from the approximate 30% that we observe with factor VIII prophylaxis. After 24 weeks, at least 97% of participants also had fewer or equal to 3 bleeds in each treatment interval. To cut a clinical cutoff of more than 95% of target joints in evaluable patients resolved. 95% of target joints in these clinical trials resolved, and 89.4% had 0 target joint bleeds. Emicizumab drug monitoring. When we first introduced Emicizumab, we monitored it quite intensively. We used to measure the factor VIII equivalent activity, and the patients liked it because you could give them a figure, but then we realized that that figure didn't actually correlate with anything, so we no longer do this because that doesn't correlate with efficacy. We do monitor for factor VIII inhibitors in patients with a past history of inhibitors because we're interested to see whether the inhibitors recur or not. And I'll talk more about that later. But we don't do it generally. If you don't monitor for it, you won't see it, because if the inhibitors do come back, the patient's bleeding pattern doesn't change. They still remain bleed-free. Drug levels, we used to monitor those in everybody. It doesn't correlate with clinical efficacy. If you monitor the trends of drug levels, it may indicate development of anti-drug antibody, but we're seeing clinically significant anti-drug antibodies very rarely. We've only had 1 or 2 patients in the whole of the UK over 3 years whose anti-drug antibodies have actually stopped the Hemophilia from working. So you could argue that you don't really need to monitor drug levels either, perhaps limit it to those who just, the small group that have poor efficacy. When we introduced Emicizumab into the UK, we introduced it in a cost-neutral way. I'm aware that this is very different from many other countries, and that's the purpose of this slide. What we did was we couldn't share the prices of the products that we're using because they're commercially sensitive. So we worked out how much it costs to treat patients, and here is the distribution. The blue bars are non-inhibitor patients. The orange bars are those with inhibitors. You can see the 2 groups overlap. and that gives us a median cost for an inhibitor patient of about £3,000 per kilogram per year, and for non-inhibitors, a median cost of £795 per kilogram per year. So when the drug was licensed for inhibitor patients in 2018, we paid the equivalent of about £3,000 per kilogram per year. And when the license was extended to include non-inhibitor patients, the cost came down and we paid the equivalent of the average right across the haemophilia community. So that worked out a lot cheaper than the cost of treating an inhibitor patient, but a little bit more expensive than the average cost of treating a non-inhibitor patient. So because the overall cost for the haemophilia community was neutral, it meant that we could prescribe the drug at the clinician's discretion. Okay, so let's go back a slide. So we're currently conducting a post-marketing study. This was mandated by the European Medicines Agency and conducted on behalf of Roche for this purpose, and it's being run by the UK National Haemophilia Database. The advantage of a national database doing this is that you have a large cohort of patients with long-term follow-up. They're relatively unselected, so you get real-world data. It reflects clinical practice. The data is collected prospectively. You've got prior treatment data on their previous product for the purpose of comparison. You've got patient-reported outcome data, and it reflects a near-complete population. And we can cross-check the treatment issued. Next slide. Right. So this diagram shows you the flow of data. We've got the HemeTrack electronic patient diary, and the patients use that to report in all their bleeds and what treatment they use for it. And if they're using prophylaxis, that's also reported. That comes into the Hemophilia Centre, where it goes into the Hemophilia Centre information system, and it's sense checked and double checked by the nurses to make sure that it's not nonsense. Then that's reported onto the National Haemophilia Database. We analyse the data and report anonymised data on to industry, the UK Haemophilia Centre Doctors Organisation, the regulators, the Department of Health. So we've got, we're collecting treatment and bleeds. We've also collected haemophilia joint health score, Uroqual, EQ5D, a brief pain inventory. That data is still being analysed. I have to say, these are not very sensitive markers of quality of life, and the data is not looking very conclusive one way or the other. All adverse events are reported to the National Haemophilia Database and adjudicated by an adverse event panel. This shows you the adverse event reporting process. The adverse event panel meets once a month. I chair it. We report drug-induced adverse events on to the manufacturer, the regulator, and our membership. This shows you within-person analysis of bleeding outcomes broken down by age. The median age of those under the age of 18 was 10, and over 18 was 38. The median follow-up before switching was 113 weeks, both above and below the age of 18. And we have about 18 months follow-up after switching. The annualized bleed rate, as you can see, went down significantly from 1 0.16 in the children to a median of 0 after switching, and in the adults from a median of almost 3 down to 0 over the age of 18. And you have similar reductions in the annualized joint bleeding rate and the annualized spontaneous bleeding rate. And the proportion of patients who were bleed-free went up from 40% in the children to 80%, and from 29% to 65% in the adults. We did a sub-analysis in the people who continued to report bleeding after switching to Emicizumab. Amongst other things, we found that they were generally a little older than the ones who didn't bleed, and they generally had a higher pre-switch annualized bleed rate before they switched. So they're perhaps the severer end of the bleeding spectrum, but nevertheless, they did have a significant bleed reduction. So after switching, the under 18s had a 53% reduction median, and the adults had a 69% bleed reduction. We have some experience that in those that continue to bleed, increasing the dose of Hemlibra may make the patients bleed free. So that's worth considering. We've only been able to do that in a fairly limited way because a higher dose is not licensed in the United Kingdom. It's quite difficult to change it without the commissioners complaining about the cost. We looked at target joints. Now, bearing in mind that this is a group that were on prophylaxis before switching, we have very few target joints. The definition of target joints from the ISTH is quite tough. More than 3 spontaneous bleeds into a single joint within a consecutive 6-month period. So relatively few target joints. And here we compare the patients who have switched to Hemlibra and those who have not switched. The follow-up period is similar. It's about 18 months in both groups. And you can see that 74% had a reduction in target joints if they changed to Emicizumab, compared with only 42% that continued on factor VIII concentrate. 6% of the Emicizumab patients had an increase in target joints compared to 33% managed with factor VIII. So the musculoskeletal joints, to generalize our data and my personal experience, is that those with a 0 joint score who are genuinely bleed-free with no reported joint pain report no change after switching to Emicizumab. You can't improve on perfection. Those with established arthropathy may report a reduction in pain and an improvement in joint stiffness and range of movement. Target joints tend to settle. The symptomatic improvement may be confined to some but not all of the patient's joints. So what we often find is, for example, the patients say that their knees and their elbows have got much better, but they say their ankles are no different. Because, of course, if you're left with arthritis, you've still got arthritis. And ankle arthritis is often quite symptomatic. So the musculoskeletal response is very variable from patient to patient. Some are dramatically improved with a major reduction in pain, and many are in between. There's a general tendency, however, for the patients to increase their activity and participation in sport and just activities in general, because they learn that they're less likely to get a bleed from minor trauma, and that's good. So their quality of life improves for that reason. I'd briefly like to give you a case study which illustrates this. I had a patient who was 25, he had severe hemophilia A, and he lived with his parents. He was using a Loctor prophylaxis every third day and had an annualized bleed rate of approximately 3. He had mild arthropathy of the ankles and his left elbow, and he was very anxious about bleeding. He was just generally a very anxious patient. He said he was unable to work because of his hemophilia. This was something I never really understood. I couldn't see why he couldn't work. And it was really because of his anxiety about hemophilia that he didn't seek employment. I tried to persuade him that he might be better on Hemlibra, but he was very anxious about the change of treatment, and he thought about it for well over a year and was unable to make a decision. But eventually, in fact, his mother persuaded him to try it. Once he was on Hemlibra, he became bleed-free. He had no joint pain. He discovered that mild trauma no longer made him bleed, which was quite an important milestone. He started to email me because all the patients have access to the email address of their doctors. I have mixed feelings about it, but there you are. And he emailed me saying, "Can I go to the gym?" So I encouraged him to go to the gym. 2 months later, he emailed me again asking if he could take up basketball again. So I encouraged him to do that. That didn't seem too traumatic. And in general, he became much happier, more confident, and more outgoing. And a year later, he actually got a job in a hotel and he left home. In my view, that's a life transformed. The uptake of haemophilia, despite these advantages, is very variable. And this shows you data from our annual report, and it shows the percentage of patients in each of these haemophilia centres who have switched to Hemlibra. The green or turquoise bars are centres that only manage children. And you can see it varies. There's some centres where only 18% have switched, and there's some centres where 83% of the patients with severe haemophilia were treated. And bear in mind that this data is from last April. Some of these centres now manage 90% of their patients with severe haemophilia on Emicizumab. The average back in April of last year was 57%, but it's drifting upwards. All of these centres are switching more of their patients. So why is uptake so variable? Well, it's a novel paradigm shift. Both colleagues and patients may have difficulty taking this on board. It's a big change. There's a lack of trial data in the very young and the very old. There is a different side effect profile, and some worry about the theoretical concern of increased thrombosis and recurrence of previous inhibitors after immune tolerance induction. And I know there's one large centre in the UK that won't switch any patients with a past history of inhibitors. And I'd like to put those risks into context. The other very big question is, should we switch bleed-free patients who are using factor VIII prophylaxis? And I think, again, that depends on individual opinion. There is one large paediatric centre that is very good at factor VIII prophylaxis and whose patients probably are genuinely bleed-free. They're far more aggressive than any other centre. And so they're a little reluctant. They say the patients are doing very well. I would argue, on the other hand, that factor VIII prophylaxis can be quite burdensome, and it's much easier to treat them with Hemlibra, but it's a matter of individual opinion. And of course, in some countries, are we running out of time? Sorry, in some countries, the cost of treatment is a significant issue. So the side effects, most of them are minor. You get minor local reactions, particularly early on in treatment, some pain at the injection site. We have been monitoring for thrombosis, and we have many reports of thrombosis, but almost all of them are in patients with von Willebrand's disease or hemoglobinopathies, fibrinogen disorders. We haven't seen any with Emicizumab. So as far as we can see, this is largely a theoretical risk. We've been monitoring the patients with a past history of inhibitors, and 85 out of 673, 85 out of 673 when we last looked at it, had a past history of an inhibitor. We have had a recurrence in 4 of those, that's 4.7%. And these have occurred between 4 and 15 years after immune tolerance induction. So it may occur many years after the inhibitor's gone away, but to put it into its context, it's less than 5% of the patients with a past history of inhibitors. So it's not a common thing to occur. I'll skip the rest of this. So in conclusion, we have significantly improved bleed control in all age groups, with between 65 and 80% of patients with 0 treated bleed rates. We've got a significant reduction in annualized bleed rate in subjects who do report bleeding. Target joints resolve more frequently than in people who continue on factor VIII prophylaxis, and recurrent inhibitors are relatively uncommon. So we think this is a significant step forward. The treatment's given subcutaneously. We usually give it once a week or once a fortnight. It can be given as infrequently as once a month. We think that once a week patients are less likely to forget it. So at that point, I'll thank you for your attention. And are there any questions?
Thank you, Dr. Charles. I think we have time for some question. One question. What about the use of other factor VIII extended during of life, engineering of the gene, many type of factor VIII actually, and still in studies.
Extended half-life factor VIII is very widely used for factor VIII prophylaxis. It probably would have been even more widely used, but we have national procurement, and at one point, extended half-life factor VIII costs twice as much as ordinary factor VIII, and extended half-life factor VIII prophylaxis with some of those agents is actually more expensive than Emicizumab prophylaxis, which I think has limited its uptake a little bit. When we switched to, we did a similar sort of analysis when we switched a lot of patients to extended half-life factor VIII, and we found that it reduced the bleed rate because I think the patients spent less time at baseline than they did with standard half-life products.
Thank you, Dr. Charles. I think it was very informative lecture, and hoping to see you in Jordan next time. Thank you very much.
Thank you. Bye.
Okay. Good evening, everybody. مساء الخير, Professor Marwan. So it's a pleasure for me to moderate this
مساء
session.
الخيرات.
Can you hear me now?
I hear you very well. I hear
Okay.
you very well.
Okay, I am Dr. Tulfah, medical oncologist at King Hussein Cancer Center. It's a pleasure for me to moderate this session. Our lecture will be about recent updates in the management of triple negative breast cancer, role of immune therapy. Will be presented by Professor Marwan Ghosn. He is a distinguished speaker for us. Professor Marwan acquired his medical degree and his postgraduate expertise in hematology oncology at St. Joseph University, Faculty of Medicine in Beirut, Lebanon, as well as from the University of Paris Institute Gustave Roussy Cancer Center in France. He is the director of Hematology Oncology Program and the chairman of the Public Health and Health Management Department at St. Joseph University, Faculty of Medicine in Beirut. He acquired his master and hospital and health management from the Higher School of Business in Beirut and a master in the quality management of units of care production from the University of Paris, France. He is currently the director of the Cancer Center and the head of Hematology Oncology Division at Clemenceau Medical Center, affiliated with Johns Hopkins International in Beirut. Professor Ghosn also served from more than 12 years as chairman of the Hematology Oncology Department at Beirut de France University Hospital in Beirut, where he is actually continuing his clinical, medical, and research activities, as well as managerial activity, acting as Medical Affairs Director for Quality and Patient Safety. He is author and co-author of more than 65 peer-reviewed articles. He also published and gave an extensive number of communications, posters, and abstracts at regional and international meetings, as well as several chapters in books in the field of medical oncology and care management. So I will summarize the CV of Professor Ghosn for the sake of time. So welcome, Dr. Ghosn.
Thank you very much, Mr. Chairman, for this very nice introduction. And thank you for the Jordanian Society of Hematology for inviting me to participate. And thank you for MSD, who is sponsoring this activity. I was listening to some hematology presentation just before, but now we're gonna pass to something very important in medical oncology, and this is triple negative breast carcinoma. So today my task is to give you some landscape on an overview on why is triple negative breast cancer important, and this is a very complicated issue and patients usually when we see in our clinics. What are the current treatments paradigm in the treatment of metastatic breast cancer, triple negative breast cancer, and recently more and more, what is the indications and more recent indications mainly of immunotherapy in early risk, in high risk, early stage triple negative breast cancer. We'll have some few words about toxicity and how to monitor the toxicity at the end, and we're gonna have some conclusion. Of course, everybody knows the importance, everybody knows the importance of breast cancer because it is the #1 cancer among women, and it is one of the most, number of cancers among both sexes and ages. As you see, breast cancer is around 7% of all cancers. If we compare them to other cancers, we see lung cancer is around 18%, and colorectal cancer, for example, is around 9%. So lung cancer is responsible of a great number of patients and also great number of deaths. Also, breast cancer incidence depends on the location. We are in Western Asia, and we have around 40 to 50 new breast cancer patient per year per 100,000, and we have 16 per 100,000 deaths. As you see in Western Europe or in Northern America, you have 90%. So they have the double of the incidence of breast cancer in their region compared to our region. I'm trying to move my slides. I don't know why we are not able to move the slides. Okay. As also we know, for the last more than 10 years, and due to the molecular biology approach and evaluation and differentiation of the histology of the disease, we know that breast cancer is heterogeneous. And we know that we have the luminal A, luminal B, we have the patients who expresses the HER2, we have the basal-like, and we have the normal breast-like. So the most important part to which we are targeting our presentation today, it is for the patients who are triple negative breast cancer. These are patients with both estrogen and progesterone receptors negative, as well as HER2 negative. These patients are usually high grade. These patients are only 15 to 20% of the breast cancer, new breast cancer cases diagnosed in the worldwide. If we look into our local data in Lebanon, first publication on triple negative breast cancer that we published in 2011 evaluated 9% the incidence of triple negative breast cancer in the Lebanese population. But worldwide, it is between 15 and 20%. It is usually hard to treat. It is an aggressive form. It is associated with worse prognosis, including distant metastasis and including shorter survival after recurrence. The risk factors which we can classically see associated with basal-like or triple negative breast cancer are patients younger age, pre-menopause status, younger age, who have increasing parity, younger age as first-term pregnancy, short duration of breastfeeding, and some other presentation. We know that the triple negative breast cancer are patients who will relapse in visceral organs. So here we see, if you look to bones versus non-bones, triple negative breast cancer will recur less than non-triple negative breast cancer. But if we look into viscera versus non-viscera, you will see that 74% of the patients will recur in the viscera if they are triple negative breast cancer versus only 63%. And if we look the comparison and the survival and the recurrence-free survival of all our patients, you will see here in blue, the curves in blue, that the probability of survival is very low. It's the lowest for patients with triple negative breast cancer, and the probability of recurrence-free survival is also the lowest among triple negative breast cancer. So if we go and see the wide variety of treatment that we have developed through the years in order to treat triple negative breast cancer, we will call this approach traditional approach. You see that we have used the taxanes, you have used the anthracyclines, we have used the antimetabolites, you have used microtubule inhibitors, and we have used platinum agents. the drugs which has more emerged in the treatment, the first-line treatment of triple-negative breast cancer have been the anthracycline, as well as the taxanes, as well as the platinum analogs. If we look, what is the risk of, of relapse of the patients according to the achievement of pathologic complete response? And this is a study taken from the neoadjuvant approach for the patients. If you have a patient with breast cancer, you give her a neoadjuvant treatment. Everybody knows that if you are able to achieve a pathological complete response at the time of the surgery, these patients will have better disease-free survival. But among them, if you look and you see, you will see that the patients who have basal-like breast cancer, so these are the triple-negative breast cancer, and here these are the blue patients. As you see, they are a little bit better than the HER2 positive, but they are much worse than the liminal A and liminal B breast cancer. So what is the rationale? So indeed, we need new drugs. We need new approaches in order to increase the pathological complete response for the patients in early stages, and we need new means and we need new treatment for patients in metastatic situation, because of course all these figures are very, very, very poor in regard of these patients. Is there a rationale to include immunotherapy in triple-negative breast cancer? We know from some studies that the combination of immunotherapy with chemotherapy, the combination of immunotherapy with combinotherapy can increase the immunogenicity and activate the immune response by increasing the antigen shedding and the presentation, and by stimulating the T cell infiltration, making the use of immunotherapy, the rational use of immunotherapy, at least at a pathophysiological level, very logical. We know that there are multiple ways of targeting the cancer cells. So among the ways how you can target the cancer cells, you have the immune activation of the anti-CTLA4 monoclonal antibody, and this is an immunotherapy. You have also the activations of selection of anti-inflammatory drugs, and you have other targeted ways in targeting your treatment. But you can, patients are avoiding the cancer cells, are avoiding the immune destruction through a pathway and an interaction with CTLA4 receptors. And this is where different approaches to immunotherapy has been investigated, including the use of immune checkpoint inhibition, where the goal is to inhibit the inhibition of the T cell mediated responses. I tell to my patients, usually your cancer is blocking your immune system. Your cancer is blocking the immune system. We need to unblock the blockage. So we need to unblock the blockage. We need to inhibit the inhibitor in order to release your immune reaction and release your interaction. Do we have other way of doing it? Yes, we can also increase the role of the cytokines, including interleukin-2 and interferon alpha. We can enhance the antigen presentation, and we can also think of ways of developing, vaccination for our patients. So yes, we can inhibit the inhibitors, we can induce activation of cytokines, we can enhance the antigen presentation, and of course we can think of ways of doing some vaccination in order to sensitize our immune cells and generate an active immune response against the tumor antigens. Whenever you are, sorry, I'm sorry, whenever you are giving me the annotation, I'm not able to say the next slide. So please, can you delete the annotation so I can move my slides? I'm really sorry, I'm not able to move the slides. Please, can you delete the annotation, please? Yes. So, as I said, there is interaction between our activated cytotoxic T cell and our cancer cells through the interaction between PD-1, PD-L1, PD-L2, and through the interaction of CDK4 of CDK4. So here we have the interaction between PD-1, PD-L1, and PD-1 and the PD-L1, and you have also the interaction with CTLK4A. Is it rational, very rational to use the checkpoint inhibitor in triple-negative breast cancer? Yes, as you see, if you have triple-negative breast cancer, you will have most probably more tumor infiltrating lymphocytes. You will have most probably more PD-L1 expression, and you will have most probably non-synonymous mutations. And we know that if you have more PD-L1 expression, if you have more mutation, you are more likely to respond to any activation, any use of checkpoints inhibitors. And this is where the role of Keytruda can act, as Keytruda is an anti-PD-1 drug. Keytruda is a humanized monoclonal antibody. It blocks the interaction between PD-1 and its ligand, which is PD-L1 and PD-L2. Keytruda can release PD-1 pathway-mediated inhibition of the immune response, including the anti-tumor immune response. So we have some rationale on using an anti-PD-1, and we have some rationale on using immunotherapy. Let's see what are the current guidelines for the treatment of triple-negative breast cancer, and can we introduce immunotherapy in the landscape of the treatment of triple-negative breast cancer. This is the NCCN guidelines. You see breast cancer subtype, triple-negative breast cancer. For the patients, this is FDA approved, and they are included, of course, in the NCCN guidelines. For patients who have PD-L1 expression with a threshold of combined positive score CPS of more than 10 on immunohistochemistry, you have an FDA approval of pembrolizumab plus chemotherapy, and you will see what kind of chemotherapy. This is a category 1 NCCN category of evidence, and this is a preference first-line treatment for the recommendation. So we have this recommendation. How we arrived here and how did we get this recommendation? So here you see, if you need to use pembrolizumab with chemotherapy, it can be used with albumin-bound paclitaxel or weekly paclitaxel, or in combination with gemcitabine and paclitaxel. So let's see how we can put this indication in practice. Let us take this first clinical presentation. This is a 52-year-old white female, previously diagnosed and treated for stage 2A breast cancer. She had her surgery, then she received her adjuvant, she received lumpectomy plus radiotherapy plus adjuvant dose-dense adriamycin and cyclophosphamide, as well as paclitaxel weekly for 12 weeks, plus a whole breast radiation therapy. And after 3 months, she was on the follow-up in complete remission. Then 14 months later, patient came with a palpable mass in the right blast, and the metastatic workup revealed some liver metastasis. We had a new biopsy to confirm that her triple negative breast cancer status is still the same, and patients was HER2 negative, ER negative, PGR negative, PD-L1 expression, CPS was 12. This was a stage 4 metastatic triple negative breast cancer. So what do we have in this situation? And here comes the study Keynote 355. What is the study Keynote 355? The study Keynote 355 is a study where the inclusion criteria are measurable disease of metastatic breast cancer, completion of treatment with curative intent more or equal to 6 months, good performance status, adequate organ function. The inclusion criteria were if the patient had any previous therapy targeting PD-1, PD-L1 or whatever, and an active autoimmune disease, or patient diagnosed with immunosufficiency and had immunosuppression, and if the patient had active CNS, non-controllable active CNS metastasis or meningitis. And the patients were stratified according to the combination of chemotherapy as well as the expression of PD-L1. In this study, all patients, PD-L1 negative or PD-L1 superior to 1 or PD-L1 superior to 10 were included. It's very important to see the design of the study. So 566 patients were randomized. No, 847 patients were randomized 2-to-1. Patients who were randomized either to receive Keytruda with the physician choice of paclitaxel weekly, or protein-bound paclitaxel or gemcitabine plus carboplatin versus placebo plus the same chemotherapy, and the patient continued the same treatment until disease progression or toxicity. Please note that 38% of these patients had 38% of CPS more than 10%. Please remember this magical number. And this is without any delay the progression-free survival of this patient. It's obvious that the patients who received the combination with pembrolizumab did better than the patients who did not receive it, with a hazard ratio of 0.65, and there were 4 months differences from 9.7 months to 5.6 months differences, 4 months differences for the patients who received the pembrolizumab. So then we had major impact on the progression-free survival of the patient. Was there any differences among the subgroup of patients? No, nearly all the subgroup of patients, number of metastatic site, disease-free interval, previous neoadjuvant or adjuvant treatment, previous same class of chemotherapy, performance status, nearly there were elderly versus non-elderly, nearly all subcategory of patients were positive and benefited from this treatment. If we look, and this is for all comers, you see, this is, no, the PFS is for more than 10, and this is for the more than 10 also, sorry, excuse me, and this is the objective response rate also for the CPS more than 10. As you see, 53% of the patients are objective response rate versus 40% for the patients who did not receive Keytruda, and the median duration of response for this category of patients who are CPS more than 10, these are metastatic patients, not early disease, metastatic patients. We had 19.3 months versus 7.3 months. So you have a more than 12 months difference, more than 12 months difference for the patients who received Keytruda. And also, if we look at the endpoints for the patients who had CPS more than 10, you see at the progression-free survival, 9.7 versus 5.6. Overall response rate, 53% versus 40%. Disease overall response, duration of overall response 19 versus 7. So as you see, patients continued to respond for a very long period of time. Why did the patient discontinue or interrupt the treatment? Mainly the patient interrupted the treatment for reactions more related to their chemotherapy more than the immunotherapy. Okay, neutropenia, leukopenia, as you see, decreased white blood cell count. Patient stopped their treatment more because of the chemotherapy than the targeted therapy, than the immunotherapy. And if we look to the patients comparison between Keytruda patients and non-Keytruda patients, you will see that nearly all the side effects except the rash, for example, or except the rash, nearly the side effects were nearly the same between the two groups. So what happened with our patient? Our patient received Keytruda plus weekly paclitaxel. She responded very nicely to the treatment. Her only side effect were some rash, where we withheld a little bit the treatment. Then we resumed the treatment after giving her some post-topical and systemic corticosteroids. Patients is still 9 months on Keytruda, experiencing a good partial response. Do we have an impact on the overall survival? You will tell me, it's okay you have a progression-free survival. It's okay you have a better overall response rate. It's okay you have a more duration of response, but do we have an impact on the overall survival? Yes, this is the publication and the update which came few months later at ESMO 2021. And this is the overall survival curves for the patients who were included in this trial and who were CPS superior or equal to 10. So for these patients, you have a median overall survival of 23 months versus 16 months. So it's 7 more months of overall survival for the patients who received Keytruda plus chemotherapy versus Keytruda and chemotherapy. So these are the curves of progression-free survival. Again, they were updated at the ESMO. As you see, the best progression-free survival was obtained with patients with CPS more than 10. I told you to remember CPS more than 10. And the patients who were more than 1, also it was statistically significant, 31% at 12 months versus 19.5% progression-free survival for the patients with CPS more than 1. And also in the intent to treat situation, also it was statistically significant. It was 29% at 1 year versus 20%. So it was 7.5 months versus 5.6 months. So intent to treat was a little bit less than CPS more than 1, but the big difference was in the CPS more than 10, 9.7 months versus 5.6, although all the arms were statistically significant. Did we have a statistically significant overall survival for the patients who had CPS more or equal to 1? No, it was it was 17.6 versus 6 months, but it wasn't statistically significant. In the overall to treat population, also no, it wasn't significant, although numerically it was better, 17.2 months versus 15.5 months, but the hazard ratio was 0.76 and reached more than 1. Did we have any subgroup where we can see that the overall survival were better? I just told you that it was obvious that for the patients who were CPS more than 10, these are the patients who had the best of the overall survival. And it was present in all subcategory of the patients. We didn't have the same in CPS1, although we had a trend for the CPS1. We had also a trend for the ITT, intention to treat, but it was only statistically significant in the subgroups of patients with CPS more and equal to 10. Objective responses also were better for the patients for CPS more than 10. Disease control rate was also better for the patients with CPS more than 10. Duration of response was also better for the patients with CPS more than 10. We didn't really have any new sign of toxicity or immune-mediated side effects when we looked into these drugs. We know that endocrinal side effects are very important to know, including thyroid dysfunction and adrenal dysfunction, but everything was under control and we knew about it. So in summary and conclusion, for this trial and for this category of patients, pembro plus chemotherapy resulted in statistically significant and clinically meaningful improvement in PFS and OS versus chemotherapy in the patients who had PD-L1 positive CPS more or equal to 10 metastatic triple negative breast cancer. This was consistent across all the subgroup, and it met all the secondary endpoints, OR, DCR, DOR. Safety was consistent in what we knew, and this really highly supports the use and as a standard of care, this treatment and this combination for the treatment of metastatic breast cancer, first-line metastatic breast cancer. What about early stage triple negative breast cancer? This is Keynote 522. These are patients where we are tackling them in neoadjuvant treatment. Our objective is pathological complete response. Pathological complete response. So for these patients, we had this Keynote 522. We had patients who had tumor size more than 1 centimeter and less than 2 centimeter with nodal involvement at presentation, or tumor size more than 2 centimeter, regardless of nodal involvement, and patients were enrolled regardless of PD-L1 expression. Here, we are treating patients regardless of PD-L1 expression. And the neoadjuvant regimen was Keytruda or non-Keytruda plus carboplatin weekly or every 3 weeks plus weekly Taxol. So carboplatin, we were able to give it weekly or every 3 weeks, but paclitaxel were given every week, followed by, of course, Keytruda or placebo with doxorubicin or epirubicin and cyclophosphamide every 3 weeks. Then the patients had their surgery. Then the patients had adjuvant Keytruda versus placebo. And what were the results? Baseline characteristics were nearly the same. And this is the result. This is the result. We had a superiority in the event-free survival for the patients who had Keytruda plus chemotherapy versus the patient who received non-Keytruda versus chemotherapy. We'll come to the other endpoints, but it is very important to see the event-free. And the event-free survival was the time from randomization to the first occurrence of progression of disease that comes before the surgery, development of local or distant recurrence, second primary malignancy, or even death due to any other cause. So what about the pathological? So the first objective, event-free survival, was superior with a hazard ratio of 0.63, hazard ratio of 0.63. So it is a 37% reduction in the risk of event. We know that this is correlated in good correlation with how much pathological complete response we had at the time of surgery. And everybody who treats breast cancer knows what is the importance of pathological complete response. So PCR was defined as absence of invasive cancer. Absence of invasive cancer in the breast and in the lymph nodes, and was assessed in this trial by blinded local pathology at the time of definitive pathology. And this is the difference. We had 63 pathological complete response versus 55% pathologic complete response with the patients who received Keytruda. So you had an absolute 8% difference, an absolute 8% difference for the patients who received the combination of Keytruda with chemotherapy. What about the safety profile? I will not come back for the safety profile. We had the same safety profile as expected, with mainly more side effects for the patients immunorelated side effects for the patients who received Keytruda, namely hypothyroidism, hyperthyroidism, and adrenal failure. Please remember that these results are regardless of PD-L1 expression. So the conclusion of Keynote 522 was that the patients who are currently today needs to receive a combination of immunotherapy plus chemotherapy, the chemotherapy as we just decided on it, regardless of PD-L1, in order to obtain a better event-free survival and in order to obtain a better pathological complete response for the patients who are triple-negative breast cancer. You know, I will not here give you a lecture on the importance of multidisciplinary team in the management of all cancers, including triple-negative breast cancer early disease, because we need to identify altogether radiologists, surgical oncologists, medical oncologists, pathologists, and the nurses, and all people supporting our patients. We need to identify what is the most appropriate treatment option, and we need to facilitate to develop the treatment plan. So let's have an example of this kind of patient. This is our patient who is a premenopausal patient who developed a palpable mass in the left breast. On the mammogram, there is a 2.1 centimeter mass confirmed on the ultrasound. Core biopsy confirms that it is a triple-negative, high-grade, grade 3 breast cancer. No clinically or on the PET metastasis on the PET CT scan. So this is a more than 2 centimeter tumor without nodal involvement. You remember that we can include the patients who have more than 2 centimeter without nodal involvement. This was the trial, or the patients between 1 and 2 centimeter without nodal involvement. So she was more than 2 centimeter, multidisciplinary discussion, and patients were decided to be treated according to the neoadjuvant treatment with 4 cycles of Keytruda with carbopaclitaxel, followed by 4 cycles of Keytruda with AC. Of course, we monitored all the adverse events, including blood cortisol, TSH, the symptoms of diarrhea and abdominal pain. We had an immune-mediated colitis for these patients, and she was really rapidly treated by corticosteroids. We stopped the treatment and then we gave her corticosteroids. Then the treatment was resumed after 1 month. At the time of the surgery, patient was okay, and she received a lumpectomy plus surgical axillary staging, and she was in a pathological complete response. So after the surgery, patient received, as per protocol, Keytruda every 3 weeks for 9 consecutive cycles. This is the indication, and this is the conclusion of our Keynote 522 safety. PCR rate was 63% with the Keytruda arm versus 55% with the placebo arm. Number of patients with event-free survival was better for the patients who were receiving chemotherapy Keytruda versus the placebo. The 24 months event-free survival rate was 87% versus 81% with a hazard ratio of 0.63 for the patients who received Keytruda, and there were no really issue for the safety. For the sake of time, I'm not here to remind you that patients who receive Keytruda and the immunotherapy, but mainly Keytruda, have manageable usually profile and side effect, and we know how to monitor this side effect and how to treat this side effect nowadays, and they should be also followed up and treated by a multidisciplinary team. As a take-home message, I hope that I have convinced you of the new role of immunotherapy in triple-negative breast cancer. This new role is indicated in advanced stages, metastatic stages, and in early stages. In metastatic stages, the indication of Keytruda is in combination with chemotherapy, with patients who have either a locally recurrence unresectable or metastatic triple-negative breast cancer, which expresses at the PDL1 of CPS more or equal to 10, as it has been decided and determined by the FDA approved test. And the PDL1 testing used is immunohistochemistry 22T3 FANDX-KIP. And you remember that in the trial of the metastatic patients, 38% of the patients were positive more than CPS, PDL1 CPS more or equal to 10. And also in the second trial, we have showed that Keytruda is indicated in the treatment of patients with high risk early stage between 1 and 2 centimeter plus a axillary lymph node or more than 2 centimeter triple negative breast cancer in combination with chemotherapy as neoadjuvant, as it have a major impact on the pathological complete response, and it has a major impact on the event-free survival. And remember that in the metastatic situation, for the patients who are CPS more or equal to 10, in the metastatic situation, we have also an overall survival benefit. And with that, I thank you so much for your kind attention.
Thank you, Professor Goswin, for this interesting lecture. I have a question, please, if you allow me. For a patient who finished neoadjuvant chemotherapy combined with Keytruda and did not achieve complete pathological response, can we combine capecitabine with Keytruda in the adjuvant setting?
This is a very important question and a very useful question and a practical question. Yes. Of course, as we know that achieving a pathological complete response is our aim, to get a prolonged complete response for our patients as a best disease-free survival and overall survival. In every case, in our multidisciplinary discussions, we discussed the case of the patients who did not achieve this pathological complete response. Personally, I am giving them oral capecitabine. There is no definitive recommendation, or the trial has not published yet if there is a trial doing it. But personally, this is what I am doing. Are you doing it?
No, still just we are using Keytruda alone without capecitabine. But for those who didn't receive the immune therapy, we use capecitabine in the adjuvant setting. Yes, after radiation.
I completely agree with you. There is no strict recommendation or recommendation. On a personal basis, and on my personal point of view, is that we need to add something for these patients, and capecitabine is a very nice drug and easy to use.
I have a question, Dr. Ahmed.
تفضل دكتورة مدينة.
Dr. Marwan for this comprehensive overview. I have a question apart from the immunotherapy. In triple negative breast cancer patients who are BRCA positive, PD-L1 negative, at first line, if they present de novo metastatic at presentation, do you prefer giving them PARP inhibitors, or as the trial mentioned, they should have been receiving Taxotere in the adjuvant or metastatic setting, and they should be given taxanes before PARP inhibitors? Triple negative, PD-L1 negative patients, BRCA positive.
Okay, so I understand from you, because I didn't hear you very well. Metastatic patients first line?
First line. PD-L1 negative, so BRCA positive, de novo metastasis.
You know, the published data is after taxane. So we need to stick to what is published data and recommended in the guideline. Will we be using PARP inhibitor in the future? You know, this is a tricky question, because if you're gonna use taxane and add platinum analogs to the taxanes as a first line, we all know that one of the best PARP inhibitor is platinum analog. So you are practically adding a PARP inhibitor as chemotherapy to your patients, but you are not using the PARP inhibitor, you know, the classical PARP inhibitor. It is a tricky question. Personally, I will add platinum analog, and we'll see in the future how the recommendations and trials will help us incorporate more new PARP inhibitor drugs.
Thank you.
Dr. Abdul Majid. دكتور مروان.
نعم.
دكتور مروان actually will ask a question.
دكتور مروان.
تعالوا.
I would like, awaiting that you arrive, I would like to tell you that I miss Amman and I would have loved to be among you in person and not on
long time no see. Long time no see.
We hope to see you soon.
My question is in the two study 522 and 355. Why the PDL, this discrepancy in PDL in the adjuvant neoadjuvant setting? They did not look at why it is working the drug while in the metastatic setting. There is no explanation. As an oncologist, I don't know why.
Very interesting question, and thank you for this question. But it looks like the dynamic of the disease is completely different, and the dynamic of the immune reaction of the disease is completely different when it is early disease versus when you are advanced disease and metastatic disease. Very important. And there are some studies, looking into the immunoreactivity which exists around an early disease and around the metastasis. And it looks like the immunoreactivity which exists around early disease is high versus a low immunoreactivity when patients have metastasis disease. And this is why most probably immunotherapy will work in all patients with triple negative breast cancer, regardless of the PD-L1, and that it will work much better in metastatic situation with high PD-L1.
Okay, thank you very much, Professor Marwan, and we hope to see you soon in Amman.
Thank you so much. Thank you very much for hosting me. Thank you so much. Bye-bye.
Thank you.
Thank you.
Donald.
بسم الله الرحمن الرحيم. Good afternoon, everybody. Assalamu alaikum. It is my pleasure to have this afternoon Dr. Donald McLaurin. Dr. McLaurin, based at University College London Hospital, where they have the largest combined transplant academic CART program in the UK. His focus is predominantly on allogeneic hematostatic cell transplantation and cell therapy and myeloid disorders. He is delighted to be the current chair of the Chronic Malignancy Working Party of the European BMT and a member of Scientific Councils of European BMT Board. He has been lucky to have been involved in the European BMT for many years, and he was the previous myeloproliferative neoplasm subcommittee chair for the last 4 years. Additionally, he chaired the UK-wide National Cancer Research Institute MPN group, which leads an MPN academic and commercial trial activity and research strategies nationally, and also act as the current vice chair of the EHA Global Outreach Committee. In addition to his, he has focused on allogeneic hematopoietic cell transplant and cell therapy, has a particular interest in myelofibrosis, AML, and MDS-MPN overlap syndrome. Dr. Donald He will talk about optimizing outcome for allogenic stem cell transplant for AML, include pre and post treatment strategies. Welcome, Dr. Donald. The microphone is yours.
So thank you so much, everyone. I would like to thank the Jordanian Society of Hematology for the very kind invite, and Masal here. And I'm going to bring us through over the next 40 minutes some particular points of interest as regards optimization for AML in 2023 and beyond. So really where I thought I would focus my talk is a brief recap on the current landscape in AML management in the UK. I will focus on a more novel agent, Vexios, as regards trial updates and real-world evidence with particular relevance to post-transplant outcome. I'll focus slightly on, all of us are fully aware of the use of Venetoclax and its expanding profile, indeed in the pre-transplant setting. Really is something that faces us clinically day to day is what to do with our TP53 mutated AML patients as regards transplant. And to finish with the slides that I have received from a colleague who presented sequential conditioning in relapsed refractory AML in the plenary session at ASH. So all of us are aware to improve AML outcomes for our patients, considering the transplant eligible population, we can really break this down into the pre-transplant strategies, but really we're moving away from standard backbones of conventional chemotherapy and we're combination therapy with more targeted agents and indeed more immunological approaches. We're getting better at understanding how to manipulate conditioning platforms for our patients who undergo transplant. And most importantly, in the post-transplant setting, we're improving our MRD techniques, so measurable residual disease, pairing that with chimerism monitoring and particularly CD34 positive chimerism monitoring, and really giving thought to our high-risk patients where we think about maintenance, preemptive or prophylactic strategies, and for those unfortunate patients who relapse post-transplant, salvage therapy. Unfortunately, despite all these advances, as all of us in the virtual room are aware, 50% of our AML patients still die. We have much better understanding of biology and genomic architecture of AML, and we're fully aware of how heterogeneous it is clinically, but also importantly from a molecular pathogenesis point of view. Clinically, and for those who are pathologists in the room, we were faced with 2 new disease classifications ramping up in 2022. In the UK, at least, we've had unprecedented recent approvals of at least 4 new drugs in the last 4 years, and with many more emergent targets, including immunotherapeutic strategies. Practically for us in the UK, and I'm sure in your clinical practice, we're very used to the 2017 European Leukemia Net recommendations, basically breaking them down into favourable, intermediate and adverse risk groups. But when you look at this and when you think back to your clinical patients that you meet in your practice, we're fully aware this is heavily based on conventional cytogenetics, but there's significant heterogeneity between these 3 groups. There was certainly room to incorporate more molecular genomics. And this is only a static measurement that's made at the time of diagnosis. And ideally what we need in AML, akin to what we used to with MPN, is a dynamic measurement incorporating treatment responses, including measurable residual disease, and most importantly, taking on board those patients who demonstrate clonal evolution, whether or not that is therapy related. So when we think about the updated 2022 ELN risk categorization, what changes did we see? We saw NPM1 wild type and FLT3-ITD moving into the intermediate category. We saw an additional favorable group, which is the leucine zipin frame mutated CBP alpha in the favorable risk group. And most importantly, from a molecular annotation point of view, we saw the typical MDS associated mutations being present in the adverse group. And these are highlighted in red. So what major changes did the ICC bring to us as practicing hematologists? Importantly, we saw changes with regard to the blast thresholds defining AML, and importantly for AML with recurrent genetic abnormalities, this was consistent with at least 10% blasts. Other categories out with those with recurrent genetic abnormalities, when there was 10 to 19% blast, these are now designated as MDS AML rather than EB2, and blast of at least 20% are AML. We saw the addition of new genetically defined entities with AML with mutated TP53, AML with MDS-related gene mutations, and AML with MDS-related cytogenetic anomalies. And importantly, there was a move away from the antecedent MDS and therapy-related AML. And as a consequence, these are now thought of diagnostic qualifiers. And here in this table, you can see how practically the ICC will lead us to diagnostics in our multidisciplinary teams. And really, if you just focus on the bottom of this, the diagnostic qualifiers of therapy-related, prior MDS or overlap syndrome, and importantly, germline predisposition can be applied to any of the subgroups in the upper hierarchy. So what about changes in the therapeutic landscape in the UK over the last 4 years? Well, really, we saw midostaurin being recommended in June 2018, quickly followed by gemtuzumab for newly diagnosed CD33 positive AML, and also for relapse refractory 33-pos AML in both adults and children. We saw the advent of Vexios in late 2018. If we fast forward to 2022, following the COVID pandemic, we saw the recommendation from our licensing authority, NICE, as regards Venetoclax in combination with a HMA for newly diagnosed AML unsuitable for intensive chemotherapy. We had availability at last of gilteritinib for adults with relapse refractory FLT3 mutated AML. And most recently in the therapeutic landscape in the non-trial setting, in the last 5 months, we've just had approval for oral azacitidine as maintenance therapy following induction therapy in adults who are in CR or CRI, but cannot have or do not want to have a consolidative allogeneic stem cell transplant. So very quickly, just to focus on these drugs before I move into the transplant aspect. As all of us on the call are aware who treat AML, the RATIFY study was published over almost 6 years ago in the New England Journal of Medicine, focused on newly diagnosed FLT3 mutated AML patients with aged between 18 to 60. They had a very large cohort and compared randomization between midostaurin and placebo for 14 days following each cycle of chemotherapy, including maintenance. On the Kaplan-Meier overall survival estimates, you can see the marked improvement for patients who received midostaurin. And most importantly, this was consistent across both FLT3 ITD high and low allelic ratios, and also in the FLT3 TKD setting. When we think about survival censored at the time of transplant for the transplant eligible population, we can see the improvement as regards midostaurin versus placebo for those patients who subsequently underwent transplant. And when we think about this in more detail, thinking about survival following timing of transplant for both mido and placebo treated patients, you can see the marked improvement was seen for patients who received midostaurin in induction and consolidation and underwent transplant in CR1. What about gemtuzumab? So this is cycled round. I remember when I was training, we were using gemtuzumab, then it disappeared, and now it's come back round. NICE reapproved it for us in the UK following this large meta-analysis of multiple national cooperative groups of over 3,300 patients. And here you can see the marked improvement in outcome for patients with either favourable risk or intermediate risk AML who received gemtuzumab in induction chemotherapy. And finally, for us in the UK, as regards additional agents that have been approved, we do now have access to gilteritinib. So this is only recommended for patients who've either relapsed or demonstrate refractory disease with FLT3 adult AML, and is not available for us to give as maintenance therapy following transplantation. This came from the Admirable study where almost 400 patients were randomized on a 2-to-1 basis between gilteritinib and salvage chemotherapy, which is broken down to 2/3 intensive versus 1/3 non-intensive. And despite that, you can see that in this very difficult to treat group of patients, overall survival favored the gilteritinib treated population. So moving on to Venetoclax. So For all of us, the COVID pandemic led to massive changes in our clinical practice. In the UK, we got rapid access during the early stages of the COVID pandemic to Venetoclax-based regimens, and that has really continued for us moving forward. Just as regards a brief update on its mode of action, which I'm sure is familiar to all of us, as you know, Venetoclax is a BCL2 selective inhibitor. BCL2 is a member of the mitochondrial anti-apoptotic pro-survival protein pathway. Overexpression allows AML cells to evade apoptosis, and it is highly expressed in AML in both the bulk and leukemic stem cell compartments. We know that when we focus on BCL2 Bax ratio, and Bax is a pro-apoptotic protein, those patients who demonstrate increased BCL2 Bax expression in AML associate with reduced complete remission rates, high degree of early relapse, and inferior survival in patients receiving chemotherapy. So Venetoclax binds selectively to BCL2. It frees up pro-apoptotic proteins. It leads to mitochondrial release of cytochrome C, subsequent activation of caspase 3 and caspase 8, and induces leukemic cell apoptosis. So in 2020, 2 large phase 3 trials were published within that 12-month period, and these were combinatorial studies looking at Venetoclax plus low-dose cytarabine in newly diagnosed AML, and also azacitidine plus Venetoclax versus azacitidine plus placebo. I won't focus on this in general because I'm sure you're familiar with it, but just to highlight that for VEN and low-dose cytarabine, very admirable CR/CRI rates of 48% versus only 13% for placebo and low-dose cytarabine were observed, and a third of patients achieved that after cycle 1. Again, for AZA plus VEN versus AZA alone, the median overall survival favored the combination at 14 months. And we saw that almost 2/3 of patients in the combinatorial arm achieved CR or CRI rates, with high rates following cycle 1. So for us in the UK, it is reimbursed routinely for newly diagnosed AML in combination with a HMA for those deemed suitable by clinician decision for intensive chemotherapy. But what about VEN in combination and transplant? Really, the data for that is pretty uncertain. We know that in our cohorts, and I'm sure similar to the patients you have treated with Ven/Aza, that there is particular sensitivity in the NPM1 mutated cohort. We know that from a transplant perspective, patients who demonstrate suboptimal reductions in their NPM mutant burden, either in their peripheral blood or bone marrow MRD analysis following chemo, who subsequently undergo transplant, have much higher rates of relapse and worse overall survival. Some early data that is emerging over the last 24 months suggests that Ven/Aza is a very safe and effective bridging regimen for NPM1 mutated AML patients who are highlighting molecular failure. It allows quick and rapid kinetics of facilitation of deep responses with low toxicity. And the Jemima AML 2521 trial will look at Ven/Aza as a bridge to transplant in this particular population. But what about other, not just focusing on the NPM1 mutated AML population patients? So this was work published in BMT last year from a single center in the USA, and they focused on Ven/Aza as their preferred treatment for their initial therapy of non-core binding factor AML patients age 60 or above. This was over a 5-year period, and they had a very admirable cohort size of 119 newly diagnosed patients who received Ven/Aza. 21 of these patients underwent transplant. An additional 31 were deemed as transplant eligible, but actually deferred transplant at that stage. And not unsurprisingly, overall survival was significantly greater amongst the transplanted population. And we can see that from the dark line at the top of this Kaplan-Meier curve for this non-core binding factor older population of AML patients, highlighting the benefits of Ven/Aza for those who did undergo subsequent allogeneic stem cell transplantation. And the other 3 cohorts which have demonstrated much worse survival are those who were transplant eligible but never got to transplant, Those who were not transplant candidates are those patients who may have been eligible but never received a transplant consult, highlighting to us who are not transplanters that early transplant referral is required. And if we focus on the standard transplant outcomes of GVHD and relapse, and this is a North American T-replete predominantly transplant population, there were acceptable rates of both acute and chronic GVHD and expected rates of relapse. So moving on to Vexios. So many of us on the call will have experience with Vexios. Just as a recap, this is a fixed 1:5 molar ratio of daunorubicin and cytarabine within a liposomal formulation. And preclinical data highlights 3 main factors that suggested bringing it forward into the clinic. The fact that the synergistic molar ratio was maintained over a prolonged period of time. There's a high concentration of accumulation of Vexios within the bone marrow. And most importantly, murine leukemia models have demonstrated that Vexios is preferentially taken up by leukemia cells versus normal bone marrow cells. So for us in the UK, we currently reserve Vexios use in the non-trial setting for those patients who have AML, AMRC on old terminology, and those patients who have secondary AML to antecedent MDS or CMML, are those patients who have therapy-related AML. So this all stemmed from the 301 study, which was rapidly accrued in North America in less than 2 years, which focused on over 300 patients who were previously untreated with intensive chemotherapy, aged between 60 to 75, and they were randomized on a 1-to-1 basis between Vexios and DA 7+3. Here we can see as regards the survival endpoint, main outcome, which is the primary endpoint being overall survival. This favored Vexios. There was a 31% reduction in the risk of death for patients treated with Vexios versus DA 3+7. And this was the first licensed chemotherapy to significantly increase overall survival versus our standard backbone of DA 3+7 in high-risk AML. Importantly, the 5-year update at a pre-planned 5-year analysis demonstrated that this improved overall survival favoring Vexios was maintained and was consistent with the prior primary endpoint analysis. So what about the secondary endpoints of the early data from the 301 study? We can see that early mortality rates favored Vexios versus standard DA 3+7. As regards the 60-day mortality due to persistent or progressive disease, this was lower for Vexios versus 3+7 at 3.3% versus over 10% for those receiving DA 3+7. And as regards the 2-month mortality due to adverse events, this was comparable between both cohorts. So what about transplant, which is the focus of my talk? The most interesting data for me from this trial, and this wasn't the primary focus of the trial, was the transplant data. So number one, a greater proportion of adult patients received transplant following Vexios compared to those who received standard DA 3+7. And this was 34% of the Vexios cohort versus 25% of the DA 3+7. So more patients got the transplant. And as you can see from this initial Kaplan-Meier estimate of overall survival from transplantation, you can see the marked benefit of having pre-transplant Vexios compared to DA 3+7. And the trial was not focused on collecting all the transplant outcomes and granularity that we as transplanters would want to see, but this certainly gave us a hint that patients treated with Vexios did much better post-transplant. And what about those patients who achieved a CR or CRI but did not receive transplant? Subsequent data was updated in 2020 from the trial, and we can see that the survival benefit again was maintained in the non-transplant population. And if we focus on those patients who were particularly old in the cohort, so above the age of 70, so from the age of 70 to 75, this median overall survival benefit was seen in both age cohorts. And what about subgroup analysis as regards baseline patient and disease characteristics? Vexios, most importantly, led to improved overall survival in comparison to DA 3+7 across many of these subgroups, including dichotomization by age, cytogenetic risk group, FLT3 mutation status, and whether or not the patient had received prior hypomethylating agent therapy. What about safety? As expected, this is a difficult group of patients to treat, but as expected, the highest rates were for febrile neutropenia and infectious complications, and there was no particular safety signals in the Vexios treated cohort. So that is the trial data, but really the more interesting data is what's happening in the real world. And this table very nicely summarizes data from the 301 study, compares it to 2 UK-based studies, one from France, one from Italy, and one from Germany. You can see that this is an elderly group of patients with a median age of roughly between 65 to 70. Of note, the UK, France, and Germany studies included lots of younger patients. We can see that in the 301 study compared to the real world study, many more patients had prior HMA exposure and rates were much less in the real world. And as expected, the vast majority of patients across all of these studies had either intermediate or adverse cytogenetic profiles. So first of all, just to focus on the CREST UK study, which many centres in the UK were involved in. This was a retrospective non-interventional study looking at patients with AML, MRC, or therapy-related AML who received at least one dose of Vexial liposomal. And this was the first real-world study with close to 40% of patients being younger than the age of 60. Here we can see with a median follow-up of almost 11 months, the median overall survival for this entire cohort was over 1 year. The estimated 3-year overall survival was 34%, which complements the findings of study 301. The focus of my talk is transplant. So a third of the patients went on to receive a transplant. Here you can see the very admirable outcomes from the transplant population. And the post-transplant estimated 2-year overall survival was 71%. When we focus a bit further on response rates, we can see that the overall response rates was 64%, 40% of patients achieved a CR, 13% of patients achieved a CRI, and where MRD data was available, and that was only in a small cohort, 51% of that cohort achieved MRD negativity. So what about the post-transplant survival outcomes? The one question for me as a transplanter is, what about transplant outcomes based on age? And again, even if we dichotomize this large real-world experience of Vexios and transplant into patients younger than 60 in comparison to patients older than 60 years of age, the median overall survival was not reached. So when landmarked from the date of transplant, median overall survival was not reached and was not dichotomized based on age alone, which is a very important point. The French study was published prior to that. It looked at 103 patients from 12 national French studies. Again, they saw very admirable overall response rates of 59% with a median overall survival of 16 months. We can see that patients who got to transplant versus those who were not transplanted did much better, and a third of that cohort made it to allogeneic transplantation. This study importantly had some data on karyotypic and mutational analysis, and it did appear that most of the adverse mutations and chromosomal anomalies had no impact on the response rate that was achieved with Vexios liposomal. And most importantly, in this small cohort, and I do highlight this as a small cohort, Vexios appeared to overcome the poor response rate associated with ASXL1 and RUNX1 mutations. And finally, just to look at the German cohort, we saw again improved overall survival with good follow-up. The transplant, and they are very aggressive transplanters within this community, highlighted the benefit of patients who had induction therapy with Vexios, achieved good MRD negative results, and went into subsequent transplant without further delay, was a very admirable treatment approach, given the highest probability of cure for patients with AML, MRC, or therapy-related AML. And their 2-year relapse data suggested that their relapse-free survival was 71% at 2 years. And again, looking at some of the mutational analysis that they did have some evidence of TP53 mutational data. So only 26 of patients out of 188 were evaluated for TP53. Half of them almost had TP53 mutations. And again, a strong signal that even the presence of a TP53 mutation did not appear to influence the survival rate of patients who underwent treatment with Vexios. The top line message as regards mutations where we do have data is that around 50% of your Vexios treated patients will achieve MRD negativity. So fast forwarding to our gaps in the UK. So where do we have gaps in our current reimbursement? We have gaps. We do not have easy access to IDH1 or IDH2 inhibitors. So that's a gap in our current portfolio. We do not have access to SMO inhibitors such as Glastigib, so the hedgehog pathway inhibitor, for us currently within the UK. We have many ongoing trials through our NCRI AML group, and this gives us an overview of our currently funded UK treatment algorithm. And you can see I'm bringing through there the data on CPX, where Mylotarg is used, midostaurin, where we currently utilize AZA and Venetoclax, and the role, which is a subgroup of patients for gilteritinib therapy. So where does that leave us as state of play for us nationally in the UK as regards clinical trials? We have really, I think, three main trials that I just want to quickly highlight to you, which is the Victor trial, the ACT-001 trial, and the Vexios and Venetoclax trial. So the Victor trial is run by the NCRI AML group. This chief investigator is Richard Dillon, and it is funded by Cancer Research UK. Its main focus is the NPM1 mutated AML FLT3 wild type population with a randomization between standard DA-GO and DA intermediate dose cytarabine versus VEN and low dose cytarabine with very close MRD monitoring. You can see the salvage arms if there's molecular persistence, progression, or relapse for both, and it is actively recruiting across the UK. We've seen the data from ASCO, EHA, and ASH looking at Macromolab, which is a first-in-class macrophage checkpoint inhibitor with high response rates, in particular in adverse risk AML, and it indeed gives a strong signal in TP53 mutated AML. So in our ACT-AML-001 study, this will look at Ven/Aza and Magro versus intensive chemotherapy. It will randomize on a 1-to-1 basis in AML patients who are suitable for intensive chemo, defined as adverse risk by ELN 2022 of all ages, but will also importantly include patients above the age of 55 with intermediate risk AML. And the patients who achieve CR will proceed to allotransplant. So I think this is a very important trial for us in the UK. And that brings me on to the inevitable question about TP53. So depending on where you work and your transplant center, many transplant centers are now refusing to bring TP53 mutated AML patients forward to transplantation, because even if you do bring them successfully through transplant, we know that long-term survival is exceedingly dismal and overall survival can vary between 10 to 20%. And there are exceedingly high rates of relapse. And really for us as transplanters, where should we think about optimizing this? We can think about this in the pre, peri, and post-transplant setting. So this was a very practical session that was presented at ASH in 2022 by Coleman Lindsay and colleagues looking at how we could think about optimization. So the first thing to think about your MDS or AML who's TP53 mutated is to think about the allelic state. We know that data suggests there's a differential outcome between monoallelic TP53 and multi-allelic TP53 mutations. For us in our center at UCLH, if we have a multi-allelic TP53 mutation, particularly in the context of a complex karyotype or a monosomal karyotype, we are now not bringing those patients, even if they're young, through to transplant due to the much higher relapse rates. We know that the type of TP53 mutation, whether it's missense or truncation, does not appear to associate with determining particular clinical outcomes, but clonal hierarchy certainly does. And there's still debate about whether or not we should think about the depth of response. So how deep do we need to go with our TP53 mutated AML patients? Some data suggests that for patients who've received hypomethylating agents, if you get a deep MRD prior to transplant, you see improved outcome. But other data is completely contradictory to that, because even in patients where you achieve a very deep MRD as regards TP53, you're still complicated by high rates of relapse. That leads on then to, is there anything we can do in the transplant field as regards conditioning or in the post-transplant phase? When we think about conditioning intensity, the natural reaction would be to increase your conditioning intensity. So to get the patient undergoing the highest intensity conditioning that you can think of, but actually there is no data to support that approach. Most of it suggests that even if you increase intensity, that is inadequate to overcome the early relapse rates that you see with TP53 mutations. And indeed, from the AML subgroup of EBMT, they did a retrospective study of 179 patients with TP53 mutated AML, and there was no significant difference in overall survival between reduced intensity and myeloablative conditioning. I think where the field should move is about novel conditioning. There's some very nice data that's starting to come out. We saw this at ASH about the addition of Venetoclax to fludarabine and busulfan 2 conditioning platform, and with quite early encouraging results. And there is no data to suggest that increasing HLA disparity, so use of a haplodonor or cord blood donor, will lead to any particular benefit above a SIB or unrelated donor in the TP53 mutated setting. More importantly, what can we do post? There is no data to suggest that routine use of HMA prophylactically will lead to better outcome. Much more importantly, drugs that can restore wild-type TP53, such as prenatoport, in combination with HMA, has demonstrated in some small studies a trend towards benefit, but we need much larger prospective studies. Granular data as regards preemptive prophylactic DLI, either alone or in combination with HMA or HDAC inhibitors, is lacking. And I think for me, an attractive but pretty aggressive approach would be to use PD-1 blockade post-transplant. But as we know, the risks of acute GVHD with that approach are fairly high. And where will the horizon planning be? I think we'll hopefully start to see some studies post-transplant in this population with macrolide and azacitidine, with dual targeting antibodies such as Flotetuzumab, which targets CD123 and CD3. And as you know, the CAR data for AML is in its prematurity, but we are seeing some strong data coming out in phase 1 studies of CD123, 33 targeted CARs and CD70 targeted CAR cells in combination with HMA. And very finally, to finish in the last few minutes, I'd just like to focus on some slides that one of my colleagues, Johannes Schettlig, shared from the German Study Alliance for Leukemia and Transplantation. And as you'll be aware, this was a plenary study at ASH in 2022. So I'd like to thank Johannes for sharing his slides with us this evening. So the question for us in the transplant community is, in the poor response AML setting, so patients who are refractory to induction chemotherapy, should we put these patients through multiple rounds of further salvage chemotherapy prior to transplant? Or if you have an available donor, should we just get on with it and push the patients into transplant? Over the last 2 decades, we've seen many studies, particularly from the German group, showing that allotransplant in aplasia after first induction is feasible and can lead to favorable outcomes. And this is based on sequential conditioning, which is often high-dose cytarabine or melphalan, followed by RIC allotransplant, and that can produce, in certain cohorts, long-term disease control for relapsed refractory AML. So this study was an excellent study design. It were adult patients with AML between the ages of 18 to 75. They defined poor response as at least 5% blasts after first induction in non-favorable AML or first untreated relapse. Importantly, these patients had a HLA-compatible donor and were fit for salvage chemo and transplant. And they were randomized on a 1-to-1 basis between remission induction with salvage chemo, which was predominantly high-dose cytarabine based in mitoxantrone, or actually into a disease control where the vast majority had watchful waiting, very low dose cytarabine or a one-off dose of mitoxantrone, but importantly moved into sequential conditioning with a RIC transplant. Here very quickly is the consort diagram, but actually with their well-designed study, if you look at the intention to treat population, which was 137 for remission induction and 139 for disease control, the patients who actually got the transplant were very significant. So 128 patients in remission induction and 135 in the disease control cohort. The median age of both patient groups was 61. The performance status in the vast majority was 0 to 1. The average bone marrow blast at the time of study inclusion was around 30%, with the vast majority being de novo AML. As expected in both cohorts, the vast majority had intermediate or adverse cytogenetics. And indeed, in both cohorts, importantly from a transplanter's point of view, there was a good availability of donors. Both of these schematics show the number of patients who actually made it to transplant. Very importantly, in this cohort, where it seems paradoxical to watch and wait, 76% of patients were bridged alone by watch and wait to transplant. The median time to transplant was 4 weeks, and by 4 months, 97% of that entire disease control cohort had got the transplant. In the remission induction arm, in contrast, only every other second patient achieved a CR. The median time to transplant was 2 months, and by 4 months, 93% of patients had got the transplant. Here you can see there was no difference in disease-free survival at 2 months post-transplant. And that is highlighted here by the leukemia-free survival curves at day 56 and overall survival from randomization. And most importantly, they had a median follow-up from randomization of over 3 years. The most strongest factor determining outcome in both cohorts was AML biology as defined by ELN 2022 defined karyotypic anomalies. Here you can see the treatment effect was consistent across all subgroups, favoring disease control versus remission induction. And as regards adverse events, just to finish, because I know we're running out of time, the hospitalization days for patients in the disease control arm had a median of 19 versus a median of almost a month and a half for patients who had remission induction. So here, very importantly, the German cooperative groups demonstrated that in patients with poor response after first induction, there was no benefit to put them through salvage chemo versus a watch and wait approach followed by sequential conditioning. Patients spent less time in hospital. They had equal outcomes post-transplantation. The impact of morphological CR at the time of transplant was less important than expected. And it tells us that MRD negativity is not always a prerequisite for good long-term outcome following transplant. So I've now reached my time. I'd like to thank everyone for listening, and I'm happy to take any questions. Thank you so much.
Thank you, Dr. Donald, for your nice, comprehensive, clear talk. And the floor is open for a few questions. We have first questions from the audience chatting. There is any study comparing head-to-head Venetoclax plus AZA versus low-dose cytosol? And why decitabine plus Venetoclax is better, can benefit more than Venetoclax AZA plus AZA?
Yes. So for us in the UK, it's much more easy for us to use Venetoclax and AZA because it's reimbursed, or Venetoclax and low-dose cytarabine. It is more difficult for us from a reimbursement perspective to use it in combination with decitabine. I think it's a very important question because we know even the data for TP53 mutated AML and decitabine alone shows this, the benefit. So for us, Venetoclax and decitabine is an interesting combination, but I think our trial design has been based upon Venetoclax and either LDAC or Venetoclax and HMA with azacitidine.
Any questions? Yes. Go ahead. We have a question from Dr. Khalid Halahli. He is the Chief President of PMT Department at KSCC.
Thank you very much, Professor Donald. Very nice illustrate about AML and transplant. So having, I want to ask just regarding the last study that you showed that's published and presented in the ASH 2022, would you change your practice or would you accept like a standard of care for each and every patient that's having primary refractory disease or induction failure to go with preemptive, I mean, induction therapy and the sequential approach versus just give reinduction and then allogeneic bone marrow transplant, and to go with the transplant if you achieve good CR or MRD negative. So I don't know, would this study change the practice, the standard of care like getting patients with an active disease, the residual disease to transplant? Thank you very much.
I think that's the most important question, isn't it? I think it's a super study that we've seen from the German AML group and the Transplant Cooperative. But even if we think back to the first original FLAMSA studies that were published over 2 decades ago, at least in the UK, we were not able to replicate the outcomes as regards long-term overall disease-free survival in that particular population. And we had a FLAMSA-based approach in one of our prospective studies in the UK in the Figaro study, and it did not demonstrate benefit over RIC or MAC transplantation following standard induction and remission, even with the salvage point of view. I think we will have to have a think about our sequential. We do not routinely do that in our center. I think with the German registry, they're exceedingly lucky because they get access to donors very, very quickly. Often within 4 weeks, they can do a transplant. And for us in the UK, it is slower. But I think that study, the ASAP study I just presented, was exceedingly well designed. They are just submitting it for publication. And I think that will lead to practice change across Europe, yes.
I have a simple question, Dr. Donald. Regarding AML intermediate risk group, there is difference between going for simple chemotherapy, induction chemotherapy, and maintenance chemotherapy versus allogeneic transplantations. If there is any difference in overall survival between these 2 approaches?
Yeah, so I think in the intermediate risk group, it certainly defines on your genetic profile. But I think you saw the Vector trial that I presented from UK colleagues looking at Ven LDAC versus standard chemotherapy in NPM1 mutated population. And actually, I think if that trial is successful, we're seeing such deep responses with Venetoclax-based regimens that actually the number of patients, if the kinetics of the MRD is satisfactory, that need to go to transplant are much lower. But I think we're only within the first 4 or 5 years in the UK of Venetoclax-based regimens. So how that will pertain to long-term disease-free survival, we're still learning about. But I agree, I think in the intermediate risk group, there is a subgroup of patients who can be treated with Venetoclax who do not need to go to transplant.
There are any questions? So thank you, Dr. Donald, for your talk, and you are being with us. We hope to have you next time in person in Jordan here.
I very much look forward to it. Have a nice evening. Thank you so much.
Hello, everybody. This is our last session for today, and it will be about BTK in CLL patient, and it will be presented by Dr. George Fuller from UK.
On behalf of Jordanian Society of Hematology, allow me to introduce Dr. Fuller. Dr. George Fuller moved to Cambridge as LRF Bennett Senior Clinical Fellow and Honorary Consultant Hematologist. In 2007, he was appointed the Lymphoma CLL Clinical Lead for Cambridge at the Anglia Cancer Network. He was a number of appointments at regional and national levels, including the chair of the UK CLL Forum and the clinical lead for research for the West Anglia Cancer Research Network. He chairs the National Hodgkin Lymphoma Guidelines Panel. Welcome, Dr. Fellows, again. Today, Dr. Fellows, he will talk about evaluation of proton tyrosine kinase inhibitor in CLL. The floor is yours, Dr. George.
Thank you. Now, I've just been having a few computer problems, so I'm just checking. Can you hear me clearly? Can you hear me?
Yes.
Yes, yes.
Yes, you can. Perfect. Now, I'm going to share my screen, and do please bear with me if I'm just a bit slow getting going. But you should there have the front slide showing evolution of BTKIs for treating CLL. Is that coming through?
Yes, we see.
Well, thank you ever so much for the invitation. It's very kind of you, Jordan, to invite me, and a great honour. And just as my colleague from London was saying, how lovely it will be to be with you all next time. But anyway, we're presenting over the internet, and I hope I can share some of my enthusiasm for BTK inhibitors in CLL. It's an area we've been very closely involved with in the trial space over the last, well, it's pushing 10 years now with our patients here in Cambridge and the UK. And it's your very last meeting of the day, very last talk, so I'm going to try and make it interesting, hopefully. These are my conflicts. Now, those of you with long memories will remember the terrible days before the new drugs came along. This was the trial when I was a junior doctor with Professor Hillman up in Leeds, and we were recruiting into this trial. Chemotherapy, this was before BTK inhibitors, and look, the average survival, about 5 years out. And these were relatively young people with CLL, age only 65, but by 4 or 5 years out, half of the patients had actually died. And contemporary survival has improved dramatically. And these slides are not to really compare the two different trials, but it's just to give you an idea. We've got older patient trials, median age 70, median age 72, and 5 years out, basically around 80–85% of patients are alive, which is very similar to age match controls. And that top panel I've changed to the GLOW trial. I'll be talking a bit more about these trials in detail, but this is the latest data set from ASH just a couple of months ago showing a similar thing. You've got really long-term survival of patients with CLL. So our world has definitely changed, and right at the heart of understanding why this has changed is this signaling molecule BTK. So the Bruton tyrosine kinase sits in B cells just below the surface. It's taking signals from the B cell receptors, from the toll-like receptors, all of that cytokine signaling that's coming into these cells and keeping them alive is there being channeled through BTK into the nucleus to keep cells dividing and expanding. And targeting BTK has now become such a well-recognized and effective way of treating a number of B lymphoproliferative disorders that we've been moving already from first generation to second generation BTK inhibitors. Oh, can I just check you can still hear me? I think my machine just dropped off. Hot on the heels of the first and second generation BTKs, we've got the non-covalent BTKs coming. It's all very exciting times for us. So let's step back in time. When ibrutinib came along in our clinics, this was remarkable. I remember that ASH in the early 2010, 2011, 2012, seeing that data coming through and being amazed that you had patients with a really difficult multiply treated CLL that were refractory to treatment, but ibrutinib was simply turning them around. And this was the original trial. Patients are randomized to the antibody ofatumumab or ibrutinib, the tablets, median 5 prior lines. And look at that, 24 months out, still 75% of patients were progression free. And I'm going to come back to that figure actually, because this was the original data set with ibrutinib. 75% of patients at 2 years had not relapsed. We rolled this drug out widely internationally, looking at how patients in the real world, non-trial, did with ibrutinib. And this is a big data set I collected when I was chairing the UK CLL forum. So across 60 plus centres in the UK, well, we didn't match the clinical trial, but still it was remarkable. Heavily pre-treated patients with an average survival of pushing 5 years. I had one of our medical students looking at our patients in the clinic who been on BTKIs, predominantly ibrutinib, over the last 8 years, and looking with a multi-state model as to what happens to these patients. And as we know, particularly commonly with ibrutinib, many patients end up on reduced dose to try and tolerate these nagging, irritating side effects, the arthralgias, hypertension, atrial fibrillation, things that can lead to some dose management issues. And also quite a lot of patients stop for adverse events. And the dark green here is patients who stop for adverse events, and the light green patients who stop for progressive disease. And this has been the hallmark of ibrutinib, that actually more people are stopping early on because of adverse events than later, when it tends to be progressive disease. And a number of real-world data sets show this. So our UK data that I've hinted at, US, Danish, all showing the same thing. About 20% of patients stop ibrutinib with adverse events. And we're getting a better feel for why that is. And there's growing evidence it's these non-BTK off-target impacts of the kinase inhibitors. So EGFR, various things here, TEC impacting on platelet function, and also this really important paper looking at the C-terminal Src kinase that we as hematologists and oncologists would of course never have heard of. But it turns out that this is key for cardiac electrosignaling. And you can model this in mice. You can knock down this kinase, and it makes the myocardium unstable. And this seems to be an unfortunate bystander target for ibrutinib. So we've got the common toxicities that we've been seeing in the clinic, along with some of the rarer ones. But we in the UK, I think it was, some of you might remember, we presented our data on the FLARE trial at ASH, just the previous ASH, so 14 months ago. And when we were reporting this data, we found that although these are relatively young patients, we were seeing some very significant cardiac events in the ibrutinib patients. And in fact, when we looked at the cause of death for our patients, this trial was randomized between FCR and ibrutinib rituximab, and we saw that the cause of death was quite different. So FCR treated patients, of course these numbers are all relatively low, but death rates were dominated perhaps by second cancers, AML, ALL, Richter's here, whereas those treated with ibrutinib, the death rates were weighted more towards cardiac disorders. And we delved into this a little bit more. When we looked at patients treated with FCR, we asked the question, well, look, how many of these patients over the 5 years follow-up of this trial had an unexpected cardiac death? And of the FCR patients, it was 2 from 378. So perhaps what you'd expect, that's a 0.5% over this 5-year period. And that was really independent of whether the patient did or did not have a prior cardiac history. When we looked at the ibrutinib patients, it was a little bit different. So the patients who came into the trial with a history of hypertension or prior cardiac problems, well, 7 out of 100 of those people actually died a sudden, unexplained, or a cardiac death. And so, as you can imagine, 7% of patients with that risk factor in what is a relatively young trial group, because remember, FLARE patients had to be fit for FCR, it really made us sit up and had a look. And we looked at across the board with the ibrutinib trials, and we saw actually our data, UK data, was fairly consistent with other data sets that have been published. And again, the GLOW trial, this is the ibrutinib Venetoclax trial in the elderly that's just been published and presented. Again, if you look and say, well, look, why do people actually die in these different trials? This is a relatively small trial, so 106 patients in the ibrutinib Venetoclax arm. And again, you can see the sudden death, cardiac arrest, cardiac failure, cardiac events seem to be a significant issue. And this has been the reason why the ibrutinib label has been updated, so cardiac arrhythmias, failure, and sudden death. And it's something that all clinicians who are managing patients with CLL, mantle cell, Waldenström's, who are using ibrutinib, do have to be aware of. And this leads on to the big question: do the second generation drugs, do the second generation BTKs have a clean adverse event profile? And I don't know if you're familiar with these plots, but these are these kinase activity inhibition diagrams, and the size of the circle indicates the percentage inhibition. So a big circle means you're inhibiting your target, and you can guess where your BTK is right in the middle of these ones where they have the biggest circle. And then the other ones, so we have BTK here, and then all your other circles you're seeing are off-target effects. And when we go from first generation ibrutinib to second generation Acala, Zanu, tirabrutinib, you can actually see how they have a much tidier kinase profile, which is probably the reason that underpins their better side effect profile. It is worth noting, so tirabrutinib, that was the Japanese drug from Ono Pharma that Gilead then bought out, and we used that in a few trials in our trial clinic. It's a remarkably good drug, and it's a great shame that has not been taken forward in development. But acalabrutinib and zanubrutinib have arrived, and they are certainly getting a lot of international attention now in the world of CLL. So these second generation drugs, Acala and Zanu, they've been compared against chemotherapy in various first-line trials. We've got the Elevate TN and the Sequoia, and they've actually been compared against ibrutinib now in the relapsed refractory setting. And some of this data was updated just recently at ASH, so I'll be able to share some of that with you today. So what about the Elevate TN? So I was very grateful to be involved with this trial from the beginning. AstraZeneca, their global headquarters are on our hospital actually, so we've got a good working relationship with AZ, and we've been involved with acalabrutinib trials from the very early days when it was actually originally part of Acerta Pharma and then came into the AZ pipeline. And this trial randomized patients in a three-way randomization to acalabrutinib as monotherapy or acalabrutinib with the antibody Venetoclax, and then the chemotherapy arm of Venetoclax chlorambucil. So the standard arm was fairly old-fashioned, but that was the design of the trial. 17p deleted patients, TP53 mutated, were allowed in. And cutting straight to the endpoint, so progression-free survival, we can see that with 5 years of follow-up, so there's a lot of ongoing experience with this drug, we can see the advantage of the continuous BTK inhibitor is clearly there to see above chlorambucil. We're certainly getting quite interested in this overall survival difference. Is that something that's going to impact on clinical practice? In the UK, we are not actually permitted in the National Health Service clinics to give acalabrutinib with Venetoclax. It's not commissioned, so we don't have that as an option, but it is certainly something that's very interesting. When we look at the adverse event profile, well, what do we see? Atrial fibrillation, bleeding. So atrial fibrillation there at around 6-7%. We've got hypertension, thankfully coming in under 10%, 8-9%, and bleeding. Bleeding, as you know, when you're reporting clinical trials, a bruise, simple bruises, which are very common with BTK inhibitors, will be reported. But thankfully, serious bleeding is relatively low level. So flipping from Acala to Zanu, that's the other second generation BTK inhibitor from BeiGene, and that's been looked at in the first line in a perhaps a slightly fitter group of patients. These are ones who are able to tolerate bendamustine rituximab, and this again was a straight one-to-one randomization of patients. Had to be aged over 65 or the clinician deemed them unfit for FCR. Remember, in this cohort, 17p patients were not allowed because they went into their own cohort. And what did we see? Well, as we'd expect, the bendamustine arm is doing better than the chlorambucil arm in that previous trial because bendamustine rituximab is a more effective chemotherapy for CLL. And you can see there's a clear gap there. So at 24 months, we have an 85% progression-free survival in these patients. So first line, we'd expect the data to be better than relapsed refractory, and also showing a very clear difference between BTK and chemotherapy. The follow-up is relatively short, but we're able to get a definitely feel for a side effect profile. And the one thing I should flag that the zanubrutinib here with a 5% treatment mortality in 2 months, I think some of that was impacted by COVID. I know that one of my patients who's in that trial, who was on the zanubrutinib arm, did unfortunately die from COVID. So that has impacted, I think, on some of these more recent trials. But reassuringly, this is second generation drug, only 8% of patients coming off drug for discontinuation because of adverse events. If we home in on some of the adverse events, side effects. Any grade hypertension is something we'll be talking about a bit later, 14%. Again, thankfully, major bleeding is a bit lower. There's a lot of discussion about a bleeding risk between first and second generation BTK. I'm not absolutely sure it's hugely different. The one thing that is definitely different, of course, is atrial fibrillation, which thankfully with the newer BTK inhibitors, we're seeing very much less of than with first generation. And then we're definitely getting very excited about the randomized data comparing the newer BTKs with ibrutinib. And there are two data sets now that we have in the public domain. The Elevate RR, so we were again closely involved with this trial. We've had a bit of longer follow-up from this one, and the Alpine, which had more follow-up presented at the ASH meeting just gone. And so we have some nice data to look at with both of these trials. So the Elevate RR, this was quite a tough group of patients. So to get in the trial, you had to have poor risk disease that was defined by 17p or 11q deletion. It was open label, and it was a straight randomization, ibrutinib against acalabrutinib. The primary endpoint was progression-free survival, but it was constructed in a way that statistically, multiply adverse events were checked for multiple secondary endpoints. So with ongoing longer follow-up, this is data that was published last year in the JCO. We've got the the progression-free survival investigator assessed, and you can see that at the 2-month part, we've got separation. At this 2-year point, we have separation of the curves, which have coming together again by the 4 years. The overall survival is just sitting above ibrutinib, but that does not meet statistical significance, hazard ratio of 0.82. So basically showing similar long-term progression-free survival events. The adverse events are certainly where we see some differences. So acalabrutinib, those of you who've used the drug, you certainly see more headache. So this is a frustrating symptom in the first cycle or so, tends to be worse in the mornings. It's always worth flagging it to the patients, keep hydrated, drink coffee. It does tend to pass, thankfully. Other side effects, so diarrhea, we see less of that with acalabrutinib, arthralgias, these day-to-day grinding side effects. And definitely the two I've flagged here, atrial fibrillation and hypertension. So undoubtedly with acalabrutinib, we're seeing certainly less of these. And we have got these Kaplan-Meier plots of these adverse events to give us a feel for when they appear. And I think that's quite a useful pictorial separation. So we see with ibrutinib, hypertension does have this quite rapid takeoff, but it does climb as a risk as time passes. And the one thing I've noticed, so in our healthcare practice where we can move patients from one drug to another because that's permitted, we have had some patients with ibrutinib associated hypertension who we've moved across to acalabrutinib, and we've been able to cut out drugs. I mean, even got one patient who's come off all his antihypertensive drugs since making that move, which has made it a bit easier to use. The arthralgia, diarrhea, these things which are, you do notice in your day-to-day practice that it's generally just quite a bit easier to use. Bleeding events, I must say, in my day-to-day experience, I think that bleeding events includes all things like bruising. I haven't really personally noticed a huge difference between acala and ibrutinib. So that was the acala trial. How about the zanubrutinib trial? So the Alpine trial, this is the first presentation of comparison data in relapsed refractory CLL. So these patients were a little bit different from the Elevate trial. So 17p patients were included, but they didn't exclude the better risk patients, so perhaps a better risk group. Again, open label, and it was a straight 2-way randomization. The primary endpoint was a bit different. So this was overall response rate, and that has allowed a bit more flexibility with progression-free survival, which has been investigator assessed rather than IRC as presented. So this is the investigator assessed PFS that was shown at ASH. And there's a lot of excitement about these data sets because it's the first time that there's actually been a PFS difference shown between one of the first and second generation BTK inhibitors. Of course, quite a bit of discussion because the ibrutinib curve is falling a bit lower than we've seen in the past. You may have remembered I flagged with the original Resonate trial that the ibrutinib progression-free survival in that trial was up around the 70-75% mark. And there does seem to be some influence of era and much speculation as to whether perhaps patients in the more modern era with side effects of ibrutinib might be more tempted to come off, might be more tempted to try other drugs. Again, similar to the other trial, we've got the overall survival for zanubrutinib just nestling above ibrutinib, not meeting significance, but tempting to comment on all the same. Median follow-up in this trial is shorter than Elevate, so it's 29 months, but certainly very exciting for our patients. If we're trying to pull out some of the adverse events, so again, this is all from the New England Journal of Medicine paper, you can see important things here, that fewer patients discontinued the drug because of an adverse event, so 15% with Zanu versus 22% with the ibrutinib. Atrial fibrillation, clearly less with zanubrutinib, all grade atrial fibrillation. Hypertension is the one thing that's perhaps less of a difference between zanubrutinib and ibrutinib. In the data sets, they do seem to be consistently quite similar. And again, as I said, I think looking at the Kaplan-Meier plots can be helpful. You can see there zanubrutinib, the red plot clearly has a lower incidence of atrial fibrillation as we track that over time, but hypertension is a bit harder to see any difference between the two drugs. And because I know it's all very naughty to compare trials side by side, but this is a key part of interest that people are asking, so I think it is worth putting up, bearing in mind we're not doing direct comparisons, we're just observing these differences. So it's very similar ages between these two trials, 67, 66, median prior line, a bit more heavily pre-treated in Elevate, and as I mentioned, the 17P patients, there are more of those in the Elevate trial, as you'd expect, because that was part of the trial design. And the Elevate trial has been followed for a bit longer, so adverse event reporting, I've got a bit more time to get a feel for the drugs. If you actually look at, well, what percentage of patients have been stopping for adverse events, zanubrutinib and acalabrutinib very similar here, around the 15%, and ibrutinib seems to be, again, similar between trials. That's a nice reference point. That thing that I mentioned with hypertension, that perhaps that doesn't distinguish zanubrutinib, whereas perhaps it does with acala. But if we flip to atrial fibrillation, you can see that there's this very clear difference between zanubrutinib and ibrutinib. Is Zanu better for AF than acala? I don't know. There's a bit less in the way of follow-up on the trial, but that's a bit of a watch this space. Cardiac deaths, I think this is a point that is now being looked at every time we're doing ibrutinib trials. So these cardiac events are definitely there with the ibrutinib arms in both of the trials. And then this is what I was speaking to about the investigator assessed progression-free survival. So you can see zanubrutinib, acala, pretty similar. The ibrutinib arm is dropping down a bit in one trial. So I think as a CLL doc who's used these drugs, I think the second generation ones are easier to tolerate. What you choose to use in your practice is probably going to come down to your access and what you feel more familiar with, or whether a patient particularly has hypertension or other things. There is a bit of a watch this space that we do need to keep a bit of an eye on. For those of you who are really into CLL will know that patients that start to relapse on BTK inhibitors tend to pick up this pattern of mutations, and the commonest ones we've been seeing with ibrutinib and some smaller data sets with acalabrutinib are the C481 target, which is mutated, and that mutation stops the ibrutinib or acalabrutinib binding and loses the efficacy. Zanubrutinib, interestingly, about half of patients have this novel binding site mutation 528, and that's something we just have to keep a bit of an eye on, because that mutation actually is a resistance mutation for pirtobrutinib. So pirtobrutinib is leading the way in the non-covalent BTK inhibitor space. We've got that going in various trials in Cambridge, and of course a lot of centres are getting access to these non-covalent BTKs, which are very exciting as a next step because they're very well tolerated drugs. So the guidelines generally have been updated now internationally. These the treatment-naive guidelines in the US. Poor old ibrutinib has been moved out from preferred regimens. So preferred regimens, Acala or Zanu. Venetoclax, I didn't have space to talk about Venetoclax because this is a talk on evolution of BTKs, but Venetoclax and Venetoclax is another great regimen with all the caveats of how you use that regimen on the ideal patients. And then in patients with 17p deletion, it's the same story, really. I don't say CLL has become rather straightforward, but we've got the same regimens in terms of effectiveness. I think perhaps Venetoclax, because it's a time-limited therapy, is a bit less favoured for 17p deletion. And in the UK, we're tending to favour Acala, or if we could get access to zanubrutinib. And then in the relapse space, exactly the same thing. So ibrutinib has been moved out into the secondary regimens. So I'm coming to the end. So thoughts for day-to-day practice. Would I start a new patient with a CLL patient on ibrutinib in 2023? I think the most important thing to say here is that you're likely most influenced by access. If in your clinic, in your hospital, you don't have access to second generation drug, well, you're going to use ibrutinib. It is still a remarkable drug. And I know we talk about the side effects, the arthralgias, the frustrations, the mouth ulcers, the rashes, the diarrhea, all these other things. There's a great sort of list of issues using ibrutinib, but it is still a remarkable drug. And I tend to call it an 80-20 drug. About 80% of patients can take it really without too much in the way of problems. I am definitely much more aware of cardiac things and hypertension. And because in UK practice, I always have the option of acalabrutinib, it's just disappeared from our practice. So we don't start patients. So really in our practice, the second generation BTK would be ideal. Second generation, what do we choose? Well, we're very familiar with Acala because we've had access to it for all these years. So that is what I'm tending to use more of. As we get more access to zanubrutinib, will I start using it? I guess there will be some patients. Maybe if patients got cardiac hypertension, I'd be sticking with Acala. That tends to be our one of choice, but you can tell the way I'm phrasing it. Both of the second generation drugs are good. Another crux question, would I change a stable CLL patient onto a second generation BTKI? So it's easy if they're having significant side effects, then of course you can weigh it up with the patient and simply change them. A lot of these low level adverse events, you know, the skin problems, the nail fragility. I've had patients who are just fed up getting slightly sore toes all the time, or mouth ulcers. And it sounds like I'm complaining about relatively trivial things, but for some patients that does impact on their quality of life. And as I say, in our practice, moving from ibrutinib to acalabrutinib is permitted. So we are simply able to do that. I guess it's difficult, the cardiac side, if you've got a 70-year-old male who's stable on ibrutinib and you're saying, well, look, I want to switch on to a different drug because I worry about an annualized risk of a cardiac event. And it's quite hard to give a direct percentage. What is that risk? But it is clearly influenced by a patient's cardiac risk status. So I do have those conversations and we have moved many of our patients. But of course, we do still have some patients taking ibrutinib in day-to-day practice. So I've talked mostly about approved drugs and drugs that, at least in the UK and Europe, we can get access to. And this is my final slide, really. The future, what is the future direction? Combination therapy. There's a lot of debate. And I know with a big audience, half of you will think combinations sound like a great idea, and half of you will think, why on earth would you do that? Why don't you just keep them to use them in series? Because, you know, CLL is not necessarily a disease like myeloma or things where you can break through, get lots of end organ damage and problems. You know, if you have your first line and you get 5, 6, 7 years, and have your second line and get 5, 6, 7 years. Of course, if you're 70, 75, that might be absolutely fine. And pushing someone hard to put them in a deep remission may just not be right for them. And I think we have to remember that ibrutinib venetoclax, very effective regimen. And we've used that in the GLOW trial and in the FLAIR trial. And in younger patients, it is deliverable. As patients get older and a bit less fit, you know, the neutropenia, the infections, the admissions, we saw those cardiac events, and I'm a little bit unsure as to whether I'll be using that combination in anyone who isn't properly fit. The next point there, will triplet therapy come in? We've seen the German data now being presented. They have randomized triplet therapy in younger patients. Is it going to provide benefits? If it doesn't, I think for me, philosophically, if it doesn't provide a standout benefit, is that really what we want to be doing? Significant immunosuppression issues, reduced blood counts. Yeah, I'm just not sure. I think if you have a younger, fitter person and they're wanting time-limited therapy, for me, it's likely to be Venetoclax and Emicizumab at the moment, or possibly young, fit, unmutated IGHV. I might go for ibrutinib Venetoclax, accepting a degree of cardiac risk. And then what about the next step? I touched on those non-covalent BTKIs, so pirtobrutinib, nemtabrutinib, really interesting drugs, very clean side effect profile from what's been published, presented, and my own experience in the trials clinic. And I'm just about to open a nemtabrutinib trial with first patient going in next week, so I'm very excited about what that will bring with it. But just the principle of being able to stick with BTK as a target. And then the final point, these BTK degraders you may have seen. So this is this whole thing about using molecular biology to target a molecule to the proteasome to be degraded and broken down. So we're not inhibiting it as with a covalent or non-covalent inhibitor. You're actually getting rid of the protein. The drugs are in trial. So we've got patients in the UK on these drugs and some early data presented at ASH. Quite interesting. I think the philosophical point that we're still going for BTKI because biotech and pharma, they've seen that targeting BTK with an ever cleaner drug has really good side effect profile. And actually, if you can just keep working on that molecule, many of our patients, even if they're relapsing on ibrutinib or acalabrutinib, are still going to get benefit from targeting BTK if you can do it a different way. Not all, of course, because some will bypass it in other ways. But it's very exciting that we can still get developments in this space. And I think on that point, that is 10 past. You chaps must be absolutely exhausted with a full day of talks, but I will very happily take questions if we are ready for those questions now. Thank you.
Thank you, Dr. Fullis, for impressive and comprehensive talk. Now we move to the questions. If anyone have a question, please.
Thank you, Dr. Polo, for this comprehensive speech. I want to ask about what happened to the patient who was forced to stop the treatment because of the adverse event. Did they maintain a controlled disease, or did they have a flare of the disease and more or worse disease? Thank you.
So that is such a good question because it opens up this whole question about time-limited therapy with BTK inhibitors. Because we know from the American first-line trial that patients who stopped ibrutinib because of adverse events on average were stopping at around 15 months. And on average, took 22 months to progress. So we've never really, as an academic community, been able to explore these drugs properly, because I don't want to be unfair about big pharma, but the pharmaceutical industry designs trials with drugs which are open-ended, and we all have people in the clinics who, because of either adverse events or because they simply want to stop taking them, or co-funding, they might be supplying, having to pay for part of these drugs, they simply decide to stop. And we know that many patients with BTK do not race back and relapse. We were influenced a lot by the early trials, and those early patients who'd had 5, 6, 7 lines of CLL treatment. They were really unstable, and they went on ibrutinib. And we remember people telling us at ASH in 2010, 2011, saying, you stop ibrutinib and the disease races back. And I remember some of my first patients, again, incredibly unstable. And you dread them, say, going to have their teeth out. You'd have to say, look, you've got to stop your ibrutinib for 3 days, and then 3 days after. And the disease would come storming back in just 5 or 6 days. But I do think in the modern era, when we're treating patients much earlier, they're much less unstable, and we're putting people into these good remissions. Actually, quite a few people can stop. And in my private practice, I shouldn't perhaps be advocating this, but I have got a number of people who I can have proper conversations and debate risk, who've simply stopped ibrutinib and acalabrutinib, and the disease has not come back. My longest patient is now 3.5 years out. So took the drug for nearly 3 years and then has been off for 3.5 years. So yeah, they don't all race back.
Okay. Can we follow them by the idea of minimal residual disease by flow cytometry or anything like that? So we can maybe stop the treatment if they have a minimal residual disease?
So another really good question. I think the limitation with BTK inhibitors is that they're not quite like Venetoclax. So with Venetoclax, we almost expect and want to see that deep clearance, and then you can do flow cytometry to track peripheral blood, etc., etc. But with BTK inhibitors, as we know, they work by, in effect, putting the CLL to sleep. You do gradually drop that clone size, but it's quite uncommon to push people into a very deep MRD negative remission, which is why the disease just tends to grow back again, but will often grow back at a relatively slow pace. So although it's appealing to think, well, look, why don't we put them on BTK, check their flow, and if after 2 years you can't detect it, then stop. I would say, well, if you make the decision to stop, well, I'll make that decision anyway, but I can make that decision anyway, but I'm not sure that decision making is based on enough science, and with BTK inhibitors. Yeah. Good question.
Thank you, Doctor.
It seems no other questions. Thank you again, Dr. Fellows, for nice and impressive talk. At this moment, I conclude this session, and I will finish my session. Thank you. Thank you.
Thank you very much for the invitation. I really enjoyed giving the talk to you all today. Thank you.